Apollo Hospitals Financial District. May I request Ms. Minnie Jose to please join us here on the stage. And I would also like to welcome on stage our second speaker, Ms. Nirmala G., Chief Nursing Officer, Apollo DRDO Hospital. With this, I now hand over the forum to our esteemed session chair to lead the discussion. Over to you, Ms. Jayashree.
Thank you. Good morning, everyone, and a very warm welcome to this nursing session. This is the first session for the day that brings together two powerful topics that define nursing excellence in today's healthcare environment. The first topic is upskilling and reskilling pathways from generalist to specialist, building nursing excellence, which focuses on strengthening competencies, developing specialty skills, and preparing nurses to meet growing clinical demands with confidence. The second topic is kindness counts, care amounts, symbol kindness as a force of healing, which reminds us that along with clinical expertise, compassion and small acts of kindness create trust, comfort, and a truly healing patient experience. We are privileged to have two eminent nursing leaders here with us today. Ms. Minnie Jose, she is the head of nursing, Apollo Hospitals Financial District, who will speak on from generalist to specialist, building nursing excellence. And the second one, Ms. Nirmala D., Chief Nursing Officer, Apollo Hospitals Hyderabad, who will speak on kindness counts, care amounts, symbol kindness as a force of healing. May I now invite Ms. Minnie Jose and Ms. Nirmala to kindly join. To begin the session, I request Ms. Minnie Jose to take us through her expertise on the topic from generalist to specialist, building nursing excellence. Over to you, Ms. Minnie.
Namaste to all. Thank you, Jayashree, for the wonderful introduction. Not able to see the screen. Not able to see the screen. Can you adjust it? So I have to look there and see. The screen. Where to control? Good morning to all, the distinguished guests, respected leaders, and my dear colleagues. I am Minnie Jose, Nursing Superintendent of Financial District Apollo, and I extend my sincere gratitude to our Director Nursing, Captain Usha Banerjee ma'am, for her continued guidance and for providing me with this opportunity to speak today. The topic I will be addressing is upskilling and reskilling pathways from a generalist to a specialist, building nursing excellence. So across countries and healthcare system, one truth remains universal: nurses are the backbone of the healthcare. We present at the most critical moments of a patient's journey, providing care, ensuring safety, advocating for patients, and coordinating a multidisciplinary effort. So to begin with, let us clearly understand what means by upskilling and reskilling. Upskilling focuses on strengthening nurses' existing competencies so they can perform effectively in evolving roles. As healthcare advances, nurses are required to integrate new technologies, adapt updated clinical protocols, and manage increased complex patient needs. Examples of upskilling includes developing skills in telehealth, advanced IV therapy, critical care monitoring, and infection control practices, and use the digital health tools. These competencies enables nurses to deliver care that is safer, more efficient, and firmly grounded in evidence-based practices. Reskilling, on the other hand, involves prepare nurses for entirely a new role. This supports strategic career transitions, such as moving from a ward nurse to an ICU nurse, from a bedside care to a nurse to an educator, or from a clinical practice to quality, safety, and informatics positions. Reskilling is not address workforce gap, but also opens meaningful new career pathways for nurses across the healthcare system. Together, upskilling and reskilling help us building tomorrow's workforce by adapting, increasing retention, and enhancing career satisfaction in a rapidly changing environment. So why upskilling and reskilling are in nursing? Upskilling and reskilling are no longer optional in nursing. They are very essential. Across the globe, nurses face increasing complexity in patients' care due to aging populations, chronic disease burdens, higher acuity levels, and public health challenges. At the same time, rapid technological advancement requires nurses to adapt electronic health records, telemedicine platforms, remote monitoring system, and even AI-supported clinical tools. From a professional growth perspective, upskilling depends clinical expertise, while reskilling enables transition into a new specialist and leadership roles. This directly contributes to career progression, job satisfaction, and long-term workforce retention. Most importantly, developing specialized nursing skills improves patient outcome, strengthens trust in healthcare system, and enhance organizational reputation for quality and safety. Upskill versus reskill. So understanding the difference, it is important to distinguish between these two approaches. Upskilling focuses on enhancing existing capabilities. It is a continuous process that helps nurses remain competent, confident, and relevant to their roles. This is often achieved through workshops, online learning, and in-service educations. Reskilling, in contrast, involves learning an entirely new set of skills for a different role or a function. It typically requires structured certification programs or intensive training and undertaken as a targeted process to support career transitions. While in different approach, upskilling and reskilling are complementary, and together they are essential for building a flexible, future-ready working force. So why nursing needs these pathways? There are several compelling reasons why structured upskilling and reskilling pathways are urgently needed today. First, digital transformation, which is happening across. Second, the global shift towards value-based care. Third, the patient expectations have significantly increased. Patient now expects seamless clinical coordination and population healthcare management and outcome measurements. Third, patient expectations have significantly increased. Patient now expect seamless expert and compassionate care across all healthcare settings. Finally, clear growth specialization pathway plays a critical role in a talent retention. Evidence consistently shows a structured career pathway improve engagement and significantly reduce costly workforce turnover. At the heart of nursing excellence lies in a generalist nurse. Generalist nurses are grounded in strong clinical fundamentals. They deliver holistic patient-centered care and collaborative effectively with multidisciplinary team. They demonstrate strong communication skills, time management skills, and truly form a backbone of healthcare system worldwide. Transition from a generalist to a specialist nurse is structured and a supported journey. It requires thoughtful combination of theories, supervised clinical practice, mentorship, and competency-based assessment. Leadership and organization support are critical during this transition to ensure patient safety, professional confidence, and sustain long-term success in specialized roles. When done well, this transition benefits only individual nurse but the healthcare system. So common nursing specialties Across healthcare organizations like globally, nurse can progress into wide range of specialty skills. This includes critical care, emergency and trauma nursing, pediatric and neonatal, etc. Each specialty contributes significantly to improve patient outcome and strengthen healthcare delivery at a system level approach. Innovation play a key role in strengthening upskilling initiatives. One example is the use of virtual reality-based training. Immense virtual reality scenarios allow nurses to practice complex situations in a safe and controlled manner. This approach enables repeated practice without risk, leading to improved confidence, preparedness, and the real-world performance. Practice mastery is measurable. This model supports practice with mastery. This impact is measurable. Staff confidence improves, safety indicators strengthen, and quality outcome become more constant across units. By empowering nurses to innovate and continuously learn, we enhance both clinical excellence and organizational resilience. Measuring success to ensure the effectiveness, upskilling, reskilling initiatives must be evaluated. Key measures include clinical assessment, patient outcome indicators, and satisfaction. So this includes in-house training programs. Training program focus on clinical protocols, skill lab, and simulation to encourage nurses to engage in hands-on training, continuous nurse education, certification programs, and clinical mentorship and preceptorship. The pathways of reskilling support 30 days induction program, cross-training opportunities, fellowship and bridge programs, academic partnership to promote lifelong learning, digital platform enabling anytime, anywhere learning. So the role of nurse leaders which plays, identify and address skill gaps, encourage life learning, provide resources and support, recognize and reward developments. So organization also play a major responsibility. Organization must take ownership, nurse development by creating structured pathways, investing in ongoing learning and aligning competencies. So the measuring success is not just training completion, it improved patient outcome, confident nurse, lower attrition, and stronger safety indicators. These metrics helps leadership to justify continued investment and acknowledge. So there are challenges in upskilling and reskilling. Despite it is important, upskilling and reskilling face challenges. These can be addressed through flexible learning models, leadership commitments, and alignment with education and clinical workflows. So the future of nursing excellence lies in an empowering nurses not only as a caregiver, but as a leader, innovator, and diverse with health transformations. So there are takeaways. In conclusion, upskilling and reskilling is not merely a professional development strategies. They are strategies, investment in nursing excellence. Upskilling strengthens our existing capabilities. Reskilling opens new career opportunities. At the transition from a generalist to a specialist, elevate healthcare quality across continent. Most importantly, continuous learning ensure that nurses remain competent, confident, and future ready in an ever-changing global healthcare environment. Together, let us continue to empower nurses as a caregiver, leader, innovator, and change agents, shaping the future of healthcare worldwide. Thank you.
Thank you, Ms. Minnie Jose, for sharing those valuable insights on building excellence, nursing excellence through upskilling and reskilling. Thank you. May I now invite Ms. Nirmala D. to share her expertise.
A very good morning and namaste, one and all. My heartfelt thanks goes to Captain Dr. Usha Banerjee ma'am and Ms. Sunita ma'am, Telangana Regional Director and Organizing Committee. It is an honor to speak at this conference on a theme that is simple, universal, and deeply human. Kindness counts, care amounts. Kindness in healthcare, we are trying to treat diseases, manage symptoms, and follow protocols. But healing is not achieved by medicine alone. Healing happens when care is delivered with kindness. What does kindness mean in healthcare? If you see, kind attitude towards everyone, treat every patient, family members and colleagues with respect. Involve with empathy, understand feelings and provide emotional support at all the time. Nurture trust, build confidence through honest and caring communication. Dignity in care, maintain privacy, respect, and patient rights at all the time to our patients. Never ignore concern, listen carefully, and respond with responsibilities. Encourage healing, create positivity, hope, and comfort. Support patients and colleagues, work together as a caring team. Serve with communication, compassion, provide care from the heart, not just for his duty. Six C's for promoting a culture of kindness, and 6 P's is very important in healthcare sector. 6 C's, if you see, communication, commitment, confidence, compassion, complete, and competency, is all 6 C's plays major role in healthcare sector. At the same time, is important of 6 P's. 6 P's is nothing but the medical, nursing, all 6 persons, social health worker, dietitian, and supportive departments. What consists of kindness in healthcare? Active listening. We have to listen properly with the patient's concerns without interacting. Dignified care, empathy, respect, and compassion. Larger level concept and objective of kindness. Instill a service-oriented mindset. Build a team of kindness ambassadors, compassionate, respectful, and caring culture. Consistent grooming, communication, and soft skills across all patient touchpoints. What was expectations? Open mind, active participation, reflection, consistency, and execution. Learning goals, understand and demonstrate core kindness behaviors, improve grooming, non-verbal communications, develop understanding, empathy, and compassion, practice handling difficult interactions with confidence and professionalism, support and guide junior and peer by being a role model or role model. What was the impact? Enhancing the patient experience, delta change in kindness scores, reduction number of complaints. It will be impacting, and we also implemented in our organization R&R with this, and it was given motivated for our staff too. Why nonverbal communication is important? As for why nonverbal communications are important? As for 73855 rule of communication, body languages counts 55% of our interaction. Hence, nonverbal communication plays a major role in any interactions. With good, effective language, we can communicate better than words. How to effectively say no. Communication framework. Stay calm and centered. Acknowledge the respect. Yield empathy. Note the boundary. Name the limitation clearly. Offer alternate. Empathy, sympathy, compassion are integral to kindness. Empathy, I feel suffering. Sympathy, I care about your suffering. Compassion, I want to relieve your suffering. 10 commandments are followed by healthcare. Healthcare professionals. So be kind is very important, and 10 commandments was greet with warmth, be present and attentive. Greet with warmth, welcome every patient with smile and respectable words. Be present and attentive. Give full attention, listen without detracting the interaction of the patients. Own every consent. Take responsibility, ensure patients' consents are addressed. Communicate very clearly, speak politely, calm, and explain in simple language in their own language. Protect privacy and dignity. Respect confidentiality and maintain patient dignity and at all the times. Guide, don't point out. Help patient and families with care and patience. Go the extra milestone. Small additional effort can make a big difference in our patients' daily experience. Be consistent. Provide the same quality care to every patient at every time. Keep an environment clean and welcoming. A clean, calm space promotes comfort and healing. Respect colleagues, support teamwork, and treat co-workers with respect. I have a small video to play on Be Kind. Sound, please. Simple act of kind. Simple acts of kinds, we implemented in the nursing profession. It is years back by Captain Dr. Usha Banerjee ma'am. We have started EDIT, is acknowledge, edit, introduce, explanation, and thank you. The same way now we hospital-wide, that 5 P's is important. The 5 is important, same way we have started. It's introducing yourself, that edit scripts, it is acknowledge, duration, introduce, explanation, and thank you. The introduction yourself and addressing the patient respectfully, explaining procedures calmly and clearly before performing any procedure to our patients. Listening patiently and patient consent without interruption. Offering reassuring during anxiety or discomfort to our customers. Maintaining privacy and dignity at all the times. Using polite and compassionate communications. Responding promptly to patient needs and call bells. Supporting and guiding patient families appropriately. showing patience during delays or difficult situations, treating every patient with empathy and respect. Why it counts? Kindness counts because it triggers profound physiological and psychological changes, the benefits the giver, the receiver, and society at a large time. Kindness counts compassion, respect, and empathy. I wanted to share one small example here. In Hyderabad, we are the one who is having the burns unit. And years back, like 7 years back, we have received one child who is having the now affected with burns. He is a 12 years boy is playing on the terrace, the kite during Sankranti time. He got that electrical shock and he came to our hospital and it's more than 78% burns. And he was stayed with us more than 2 years and unfortunately we could not save his limbs and he lost 4 limbs. And it's more than the financial, it is bandwidth. The organization is supported a lot and the staff went to their home and their own interest after their duty and for dressings. So in spite of losing his 4 limbs, today he is able to do his daily activities with the help of specialists. And he comes every his birthday to meet our consultant and who was existing the same staff in the hospital. The kindness and courtesy, sympathy, empathy remains with us. We show little concerns to our patients. It remains in the mind in lifetime. Kindness counts, compassion, respect, empathy. As it care counts, quality care saves lives, prevents complication, enhances recovery, reflects professional responsibility. Care amounts safety, quality, and accountability. Caring attitudes during comfort in times of fear and pain. Compassion helps patients feel valued and understood. Holistic care addresses physical, emotional, and psychological needs. Patient-centered care strengthens trust and satisfaction. Kindness supports emotional healing along with medical treatment. Respectable care improves trust and patient cooperation. Patient feels safer when care is given with empathy. Small gestures of care leaves lasting impact. The true quality care combines knowledge, skill, and compassion. Professional care is not only what we do, but how we do it's important. Empathy reduces anxiety and enhances patient experience. The 2 pillars of healthcare is equally important, kindness and care. Kindness without care is incomplete. Care without kindness is also important. Emotional kindness consists emotional connection, empathy, respect, and compassion. Care consists clinical excellence, skill, responsibility, and commitment. Kindness without care is comfort only. Care without kindness is cold treatment. Kindness, care, complete treatment. Role of healthcare professionals. Create trust, reduce patient anxiety, and improve outcomes by showing empathy, respect, and warmth through actions like acting listening, comforting words, and attentiveness, fostering a supportive healing environment for patient families, colleagues, and promoting a positive culture that enhances the entire care experience. Kindness moves beyond clinical competency to address holistic well-being, improving adherence to treatment and patient satisfaction. Strategies for healthcare professionals on kindness. Implementing the training programs focused on empathy, communication. The training programs we have to strengthen, and in Apollo, we have the academic councils where each nurse can access in their depths, in their free time. They can see their modules, and this mandatory trainings is maintained by our academic council members, and is for had 8 hours of the training sections, 8 hours the mandatory training classes to attend in a month per head, and 3 hours is a bedside training is a mandatory. That is helping to our nurses to free time they can access and they can learn whatever the topic, whichever they want. and interpersonal skills and enhancing healthcare professionals' ability to show kindness and patient and colleagues. The kindness sections was we have included in our inductions and also to our mandatory trainings once in a month. Measuring kindness and care quality tools also is some assessment and feedback, utilizing the survey links, feedback forms and patient interviews. And we also has that it is a analyzing system. It is doing the CAPA and where the appreciation will give it to the staff for the motivation and corrective actions will be done. We are doing. The message as healthcare professionals, let us remember that true healing goes beyond medicine. It begins with kindness. When we care with compassion, we don't just treat illness, we restore hope, dignity, and trust. Let kindness be the legacy we live in every patient's lives. To conclude this section, when we combine clinical skills with compassion, we offer more than treatment, we offer healing. Every healthcare professional has the power to make a difference through simple acts of kindness. Let us commit to caring with both our hands and our hearts, because true healing begins with kindness. Namaste and thank you. Thank you once again. My heartfelt thanks goes to organization for giving this opportunity. Goes to organization committee.
Thank you, Ms. Nirmala, for sharing your expertise on kindness. As she rightly said, care without kindness and compassion, that is incomplete. So today's session clearly highlights that the future of nursing lies in competencies with compassion. Strong clinical skills supported by human, respectful, and empathetic care. On behalf of the organizing team, I thank both our eminent speakers for their time and contributions. I thank all the participants for your attentive presence. With this, we conclude this session. Thank you.
May I please request everyone to come forward for a photograph? Thank you to our esteemed speakers and the chair for an insightful and impactful nursing session. So moving on to our next session for the day. Ladies and gentlemen, as we continue this insightful journey at the IPSC 2026, it's time to shift our focus to one of the most exciting segments, that's our spotlight sessions. These sessions are designed to shine a light on groundbreaking ideas, pioneering research, and transformative solutions that are reshaping the future of patient safety. It is my privilege to invite Dr. Ashwin Bele, co-founder of Life Science Presence, to the stage. He will be presenting on From Hype to Hospitals, Real Lessons from an AI Startup. Dr. Bele, may we please have you on the stage? Let's welcome Dr. Bele with a huge round of applause, please. Over to you, sir.
All right. Good morning. Thank you for those who have made it this early. I wasn't expecting to speak this early, but here I am. I do appreciate the organization as well as the audience here. So I've been spending about 17 years now developing clinical decision support systems, essentially AI. It used to be called machine learning back in the day. I've been doing this in healthcare for 17 years, 15 of which was on the implementation side as well, not just developing, but also implementing. So along the way, there are some lessons learned here. I've made plenty of mistakes, and mistakes are important, so that way you can learn from those mistakes and see how you can do better. So today I thought I'd put together some of those lessons learned, especially from a healthcare organization perspective, but also from the tech perspective. It's important to see how we can bridge those gaps in those lessons. And, this was 17 years ago, this was true, and it's especially true now. One of the most common questions I get asked either indirectly or very much directly is AI going to replace clinicians? And the honest answer here, from my perspective, is no. It's not going to replace clinicians. Although, I'll tell you what will replace clinicians. It's other clinicians who have adopted AI into their workflow. Because AI is there to augment the existing intelligence that's already in place. Healthcare it's a very interesting sector. Human in the loop is going to be an extremely important aspect of healthcare. As humans, we prefer other humans to be the touch point, the feel point, the expression point. And so we can't have technologies just replacing that through and through. And that's going to remain true at least for the foreseeable future. So AI and other technologies are there to essentially augment the intelligence that the clinicians bring to the table anyway with the patients. What this will do is surface up the right information at the right time so that the clinicians can be more informed, can be more efficient, and also can spend time more with the patient so that they don't have to do the mundane work that they are now forced to do in many cases as we get more electronic health record systems in place, as we get more screen time in front of the computers, because doctors are spending time entering a lot of data, reading a lot of data, and so on and so forth. So really, we need to think about it as AI helping clinicians, and those clinicians who start using AI in a meaningful, systematic way will start replacing clinicians that don't use it, because they'll be far more efficient and better at their work. But the dirty truth of adoption of AI is that it's actually somewhat easy to build the technology in itself. I won't trivialize the building portion. It's still challenging. But what is more challenging is making sure it gets adopted into the hospital, making sure clinicians actually adopt it. And much of the work that I have been doing in the last decade has been on the more difficult side, which is what does it take to adopt these kinds of new med tech, particularly AI, into their clinical workflow and into their day-to-day. So most of healthcare technology especially fails because nobody is using it. The tech itself might be fantastic, but it fails because nobody is using it in these hospitals. Because healthcare, interestingly enough, is a workflow problem. But it poses itself, this problem poses itself as a technology problem. So technologists like myself from around the globe are trying to build solutions over and over again, hoping that the doctors will adopt it. But they don't realize it's actually the workflow that needs to adopt the technology, not just the technology in itself. So the first lesson that I want to impart here is success in medtech, particularly healthcare technologies, requires two things: product market fit, which every technology requires, whether it's healthcare or not. But in healthcare, exclusively almost, you need delivery model fit as well. What does that mean, delivery model fit? Well, let's take the Silicon Valley example of technology development. Typically, how it works is, let's just build it, and they'll come. So let's use the example of ChatGPT. OpenAI built ChatGPT, not knowing exactly for what particular end use it would be used. If you ask them, they'll say everything. And so people had to go in, figure it out, start using it, start experimenting, and then realizing, I can use it this way, I can use it that way. And so it really, they built a product, and the users flocked to it. Healthcare, unfortunately, doesn't have that luxury, right? You have to first build the product, then you have to figure out how to integrate it into a hospital. Then you've got to figure out how to configure it along the workflow that already exists within the clinicians in that hospital. Then you have to align all the stakeholders, the doctors, the nurses, the IT, etc. Then you have to train those clinicians to use it in a certain way so that they're not misusing those technologies or deciding not to use the technology. Along the way, you've got to prove value, both clinical as well as efficacy in other measures. Manage change, because change management is going to be an important aspect of adoption. And finally, ROI. And ROI could mean different things to different stakeholders within the hospital. So when you do all of this, there is a chance hospital may approach you and say, actually, I want your technology. But that's also still rare. You have to go continuously to each hospital and go through this process over and over again. And that's how you actually scale in a health tech, in med tech, in hospitals. It's a very challenging environment to scale. It's not easy. Other industries go from 10 users to 1 million users, sometimes within a month, within a year, and so on. In healthcare, it takes very long time to scale. It's not exponential. Now, if you look at solutions in healthcare, there are plenty. There's no lack of technology in healthcare. In fact, now we're getting even more, and all the doctors are being inundated with a lot more technology. So let's assume there's a problem right at the ER door where they're trying to get the information from patients. They just need to fill in a quick information, so why are they here, et cetera, et cetera. Today it's somewhat manual. You go talk to the front desk, explain, they note it down. What if that needed to be solved? There's a technology for that. What if billing needs to be solved? There's a separate technology for that. Pharmacy, reordering automation, there's a technology for that. So there are plenty of point solutions that already exist, but the problem is adoption of those point technologies. So if you think of it from a CIO, CMIO level, they have to now manage all these point solutions. I've heard some hospitals have up to 400 separate software solutions running in parallel. So when you think of it that way, as we build, technologists build these technologies, we have to think of adoption as an operating system first. We have to think first about what does it take to get adopted within hospitals, and then think about what features can I add. Right? Adoption is not just a separate feature. It is the operating system of how you build these technologies. And what do I mean by that? So these are the tenets which I think if you're a hospital, if you're a doctor evaluating new technology, these are the tenets that you should ensure there is some hand-holding from the technologists themselves. There should be some shared responsibility here. For example, workflow. Clinicians are used to some workflows. How does this technology work into their workflow? The technologists should help you understand that and work with you to figure that out. Integration into existing systems. You'll have your own HIS, HMIS, etc. How does it work with your existing technology? They shouldn't ask you to adopt a completely new electronic health record system just so that their technology can work. Data privacy, like HIPAA, GDPR, these are expected, these are the norms. But it shouldn't be the hospital's responsibility to ensure those data privacy exists. Regulatory compliance. Nothing to be said there. Obviously, it's the technologist's problem to ensure there's regulatory compliance. Monitoring performance. Once it's installed, how do the clinicians and the hospital know that it's working? So the technologies need to continue to handhold post-installation to ensure that there's value-driven accountability of how the performance of these models are. And then change management and training, etc. These also go hand in hand. If a technology is not providing all of this, then you need to be wary about using those technologies or adopting those technologies into your hospital. Now, most technology developers would want to start small. Oh, let's start with this one feature and then we can add, we can build things. Unfortunately, in healthcare, even though it's fraught with lots of different problems, they only prefer solving the big ones, the big, most challenging problems. The small ones actually become too noisy for them to solve. It's the big ones that they like to tackle and solve first. So as we develop technologies, we have to think about solving big problems first. And this I learned from experience. Now, we know the problem we tried to solve was gap in monitoring. Now, we all know the ICU has fantastic monitoring, right? Lots of data, great patient-to-nurse ratio, great patient-to-doctor ratio. But you look at the rest of the hospital, particularly the ward, that suddenly goes down from a ratio perspective. The data also goes down tremendously. You're requiring nurses to take manual blood pressure, heart rate, etc., periodically once every 6 hours, sometimes 8 hours. And then that's the data they get. So that was the problem we started to tackle. We started to tackle in the ward. How can we augment data collection at the same level as the ICU, but in the ward? And so when we started there, we started seeing a lot of efficacy. But what we quickly noticed was it had to scale, because that problem existed elsewhere too, like in the ER, at home, because once the patient leaves the hospital, you don't know what happens to the patient, whether they're, because most of the patients are reluctant to come back. Even if they're not feeling well, they'll be like, no, I'm going to sit at home and walk this off, try and get this out, and then decide. When it's really bad, they come back. So these readmission rates are actually more critical than it should be. So we started thinking, okay, the data problem that we wanted to solve actually exists in a variety of echelons of care. So how do we span across? So when we started building the solution to a point where it goes from ambulance to home and everything in between, and even the ICU, where we use bedside monitors data as is, whichever bedside monitors you have, that is when we started seeing a lot of traction. Because even though we were solving the right problem, we started small. What we learned was go big. So when you go big, you're able to then scale quite efficiently, and you're solving a massive problem for a hospital as opposed to a small, tiny one that some hospitals value more than others. And similarly, what we noticed was, wait, once you've gone digital, why not solve the same problem, but for a hub-and-spoke model? As we see in India, as in Western countries, there's a consolidation that's happening with hospital systems. Most medium-sized to small-sized hospitals are being bought over or somehow getting affiliated with larger hospitals. PE has become a huge incentive structure now, where there's private equity coming in, buying out larger hospitals, which then buy smaller hospitals to run economies of scale when it comes to hospitals. Otherwise, your profit margins are really low. In order to enable that, we realized the problem then can be extended outside as well. So we had to go even bigger. So what I mean to get at this is solve big. Don't start small, solve big. And when you start showing clinical efficacy at that level, I think adoption is much easier. The other lesson I would want to talk about is early adopters trap. So when we first built the product, we had some, we were trying to find the right folks to try and sell. We were ready to sell to anyone. Anybody who will adopt it, please take it. We'll give it for free for a few months. And there were a few who said, yeah, I think you're solving a good problem here. Let's start. So they were the early adopters. When we started working with them, we suddenly realized they're loving these features. So for example, we had started automation of discharge summaries, automation of medical shift notes, etc. So click of a button, the whole thing gets produced, because we are gathering large swaths of data from the patient's journey perspective, starting from the ambulance all the way to home. So we are able to generate these reports in a very quick manner. And this was a clear issue because doctors spend between 1 and 3 hours writing up discharge summaries sometimes. And if those discharge summaries are not good enough, reimbursement is an issue, so on and so forth. So we thought we had really hit the nail on the head in doing this with the early adopters. Some of the doctors we worked with, they loved it. What we didn't realize was those early adopters were willing to work with our product being rough around the edges. They were not complaining about small things that would bother anybody else, because they were willing to work with us to figure out how they can use this kind of new technology. And they are an early adopter mindset, which are very important. But the lesson learned here is early adopters are not representative of the rest of the hospital sector. Most hospitals are not early adopters. Even the smallest problem that they incur, they will stop using the product. So we needed to figure out really quickly how something that automates through and through, because electronic health records and stuff are becoming more common, actually needs to work when it's not there, when electronic health records are not there, when data is not completely digitized. They're still on paper-based. So we had to come up with innovations across the board. We had to build our own OCRs, which captures images of handwritten notes, pulls the data, quantifies it, puts it into the AI in such a way that it's structured medical knowledge, irrespective of handwriting, spelling mistakes, scratches, and freehand notes that the doctors typically write. Nurses capture handwritten vitals. We had to make sure these kinds of forms are pulled in. Labs are giving PDFs. We had to make sure that's being able to absorb without adding manual labor to any of the clinicians on board. We had to deploy our own people to just upload data. So these are the kind of solutions we had to innovate on, because what we thought the early adopters liked and we thought would scale did not scale when we went to a customer who is not of the early adopter mindset. And then someone asked, can I talk to it? I'm talking to everything now. Devices are talking back to me, so can I talk to your device? So we had to figure that out as well with regional language support. So we had to add 5 different languages, retrain our models to understand those languages, just so that nurses and doctors who are used to speaking in certain languages can talk to it in their native tongue. Another lesson learned, I've spent many years as an academic prior to starting companies. And as an academic, it was publish or perish, right? I had to constantly publish. Similarly here, when we build these technologies, we recognize the value of continuing to publish. So we continue to publish. We have a lot of different publications on our efficacy, clinical efficacy, generalizability, etc. But the challenge is, when we produce these kinds of publications, these are the kind of results. This is just a snapshot of a couple of the results from 2 different papers that we have. The results are typically represented as AUC, AUPRC, because this is machine learning models. This is AI, sensitivity, specificity. These metrics don't translate that easily to clinical realities, right? If a data scientist like myself is presented with this, yeah, maybe we understand it. That also maybe sometimes. But when you take this to clinicians, you're expecting them to understand a completely different language here. So it is not how clinicians think. It's not based on sensitivity. It's not based on AUC. How do clinicians think? That is where the challenge lies for innovators like us. Yes, publishing is important to ensure that peer-reviewed publication has approved your clinical approach and shown clinical efficacies in statistics and so on. But ultimately, how can you boil it down to clinical language that clinicians adopt? Simple questions. How much workload will it add to me? So we have to figure that out. For every 100 patients, there will be just 4 alerts. If News, QSOFA, Muse are producing 25 alerts, we are producing 4. How much in those 4, how many patients consistently deteriorate? At least 1 will. Maybe more, but at least 1. The next thing, I think that bell is for me, so I'm going to speed up here a little bit. Governance is also a shared responsibility. So what does governance mean? Once you deploy a product, how do you quantify that it's working? Today, it's unfortunately the responsibility of the clinicians to go back and figure out, wait, has it really improved care? Has it improved outcomes? Has it improved my life? And then report up to the administrators to say, yes, return of investment is there. No, it's a challenge. It's a huge challenge. And so it is also a shared responsibility when it comes to the technologists. We have to work with the clinicians to continue to show whether it's working or not. And to be honest, if it's not working, that's okay. It might not be the technology. It simply could be a workflow change that was required. It could be some small technology change that was required, a new feature needed to be added, simple things. But usually those simple things, if you candidly work with the clinicians, you'll be able to figure out, solve, and suddenly adoption goes up. And so we do things like case study reports every month of interesting case studies that happen within their hospital, monthly reports, and so on and so forth, just to keep them appraised on whether our technology is working within their own institutions or not. So to wind up here, these are the brief other lessons. There's plenty more. I really had to pick and choose in terms of which ones to highlight here. The other lesson I would say is build with clinicians, not for them, because as technologists, it's really exciting and easy for us to start writing code and continue writing things, building things without really truly understanding whether it's needed or not. I've done this many times myself, so guilty as charged. But ultimately, if the clinicians don't like it, then it's pointless, your effort is wasted. So work with the clinicians from the design board itself. When you're drawing things on napkin, talk to doctors, because they're very easily tell you that you're an idiot, you're not doing it correctly, you don't know what you're doing, etc. Learn from that, because ultimately they are the end users, the nurses are your end users, so make sure you learn from that. Return on investments. Just showing that outcomes have improved sometimes is not enough, because return of investment means different things for different stakeholders. Clinicians buy meaning. They want to see that their patients are improved, their outcome improved, their workload reduced, etc. Executives in the hospital, administrators, prefer the economics side of the questions. And we need both. As technologists, we need to prove both. Otherwise, your technology doesn't get sold. It's a burden, but we have to do it. And it takes a lot of effort to do both. Tiny pilots are a trap. Please avoid tiny pilots. If a doctor tells, oh, let's work on 10 patients. Let's just see if your product works on 50 patients, even 100 patients. Usually, 90% of the time, by my estimate, at least, it doesn't really change anything. At the end of the day, they might not adopt it. They won't care. They'll say, we need to do this on more patients. You've given it just for a month. Give it for 10 more months. Go big from the beginning itself. Show that you're solving this at scale. And then maybe your pilots will actually succeed within the hospital. Clinical champions make or break. So find the right champion to work with. And lastly, go live. The minute you install the product, most hospitals, most companies think, that's it. now cash is coming in, we are good. That's your starting line. That is where your real work begins, because if they don't figure out how to adopt, then your technology fails. So start that as the starting line and not the finish line. All right, thank you so much.
Thank you, Dr. Bele. Those were some really meaningful lessons. For the next session, I would like to now invite Dr. Tejaswi Chitkala, Department of Emergency Medicine, Apollo Hospitals, Hyderabad. So may we please have you on stage with us. He will be speaking on optimizing outcomes, evidence-based approaches to vascular access management and care in critical care settings. Over to you, sir.
Thank you. I'm Dr. Tejaswi, the consultant from the Department of Emergency Medicine from Apollo Hospitals, Hyderabad. I will be talking on newer advances of peripheral intravenous cannulations, what is the importance of it. This is my disclosure, conflict of interest. Patient safety is a paramount for achieving. As an NABR 6th edition elevates patient safety to a central pillar of hospital accreditation and requiring structure protocols, continuing monitoring, and culture safety. Hospital must demonstrate the measurable improvements in the outcomes, risk reduction, and patient satisfaction. These are the most important paramounts which we need to be thinking about. As per the patient safety goals achieved by establishing a patient safety and quality committee, conduct monthly safety audits, training the staff in the 5 WHO moments of hand hygiene and NIH biomedical waste management, implement incident reporting system, engage patients through education and feedback loops. When it comes to the main important, I'm going to discuss on the difference of the central venous catheterization and peripheral intravenous catheterization and how you reduce the collapsing. These are the two different types of cannulations. Central venous cannulations are indwelling device inserted into the large central vein, advanced until the terminal lumens, resides within the inferior vena cava or superior vena cava. It can be also in the femoral vein. There are different types, conventional PICC lines, Hickman lines, and the port lines. These are used for central venous pressure monitorings, infusion of different vasopressors, and as well as large bore fluids. They commonly used for critical ill patients admitted to the ICU. The more than 5 million central venous catheterizations are inserted every year in the United States alone. And in India also, the more than 1 million of central venous catheters have been inserted. Whereas the peripheral intravenous cannulations, these are indwelling single lumen plastic conduit, which are inserted into the peripheral vein under the skin. There are different types, SP, IVC, LP-IVC, and MCs. These are different lines. This is generally preferred for the short-term IV access for about 3 to 5 days, or sometimes I can extend to maximum for 7 days. These are usually safer, easier to insert, less painful than the central lines. I think you don't require the local anesthetic until unless there's a pediatric age group. In the hospital neonates, infants and peripheral IVCs, insertion is one of the most frequent performed invasive procedures. As per the research and things, these are the CLABSI lines where the bacteria-associated CLABSI have exhibited high AMR and the use in the United States. About 18% and 28% of CLABSIs according to the short and long acute care hospitals. NABH prioritize the vascular access impact and outcome measures for achieving patient safety and healthcare worker safety goals. The NABH priority for the hand hygiene, for the vascular impact, before and after line care should be taken care, and the measure outcome here, the collapse reductions. For the sharp safety, the safer disposal post-IV in the vascular impact, and also, which decreases the needle-stick injuries. Whereas the bundle care, the collapse bundle and the vascular access impact should be taken care, and we should implement the bundle care, which reduces the infection rates, and the risk management, the RCFR CRBSS is reduced, and the correction actions, the patient safety, component satisfaction, and which increases the patient scores. These are the infusion systems, which compares the three-way stopcocks with the closed infusion systems. The open IV infusion systems, which are exposed, whereas the closed IV system, which are the closed-loop systems. Vascular catheters traditionally used for open systems in which small catheter tube with open port is used as connecting points to an IV administrative site. This system is open to the air without a membrane when cover is not in place, and for that reason, it's considered as an open IV system. Whereas closed IV infusion systems, these are closed, don't have open ports or caps, and are used close connections such as needle-free connectors for preventing needle stick injuries. Upon withdrawal of the needle, the tip is automatically shielded, protecting the healthcare workers from injuries and the blood contact. The open IV connection devices are three-way stop clock, Luer clock, disposable or standard cap, slip tip port on three-way stop clock, non-closed catheter access system, open system peripheral cannulations. Whereas closed IV connection devices, needle-free connector, closed catheter access system, and closed peripheral intravenous cannulations. Use of needle connectors, needle-less connectors provides needle-free access for IV medications, administration, fluid infusion, withdrawal or blood samples, or connecting administration set to the IV catheters. Unmet need for using needless connectors offers the possibility of connecting administration set to VATs by eliminating the use of needles. Prevent needle stick injuries, reduce the risk of exposure to blood-borne pathogens. It reduces 50% of the CLABSI rate after switching to the NFCs. The flushing VATs, as per the Nursing Society, flushing as the act of moving fluids, medication, blood and blood products out of vascular access devices and into the bloodstream to access the and maintain patency, prevent precipitation due to solution and medical incompatibility. There's a different flushing system that maintains catheter patency, prevent thrombosis and phlebitis, decreases formation of biofilm within the catheter lumen, which are the most common problem we encounter. They prolong catheter dwell time. Clinical impact and cost effectiveness of split septum and a single-use prefill flushing device versus three-way stopcock on the central and associated bloodstream. Infection rate in India is 1 second. And the split septum and the single-use prefill flushing devices group has a reduced CLABSI rate when compared to the three-way stopcock when we have done the study. This is about, p-value is about 0.006. Conclusion. The use of split septum and the single-use prefill flushing would provide a saving of $402 compared to the three-way stop clock and manual flush syringes. For each extra $1 invested in the central line bundle, the $124 could be saved. Whereas the limitations, the data retrospectively collected, introduction bias, and the language and citations. In Apollo, we have conducted the PRIME program, preventing the risk of infection and medication errors in IV therapy. It's a patient safety initiative developed by an accreditation of the Joint Commission in partnership with the BD. It focuses on reducing the bloodstream infection and medication errors related to intravenous therapy while strengthening the hospital safety, culture, and compliance with international standards. Implementing quality improvement projects achieve safety goals by preventing harm, reduce risk of medical errors, infection, falls, and adverse drug events, build trust, prevent feel safer and more confident in the care they receive. Compliance, accreditation bodies like NIBH, JCI, and WHO mandate safety protocols. Cultural safety encourages staff to report errors without fear, leading to learn and prevent. Better outcomes, fewer complications means shorter hospital stay, lower cost, and improved recovery. Smarter tools for patient safety. The future of vascular access isn't just about the right line, it's about the right technology for a zero-harm future. The smarter tools today mean safer patients tomorrow. Let's lead the shift from getting access to preserving health. Let's stop reacting to the complications and start engineering them out of existence. Thank you.
Thank you, Dr. Chitkala, for those critical insights. Now, our third speaker is, I would like to invite to the dais Mr. Anand P. Surana, CEO Icegen Computing Inc., talking about AI Patient Concierge. Mr. Surana, we are glad to have you on the dais with us. Over to you, sir.
Hi, morning all. I will make it a little interactive than me making it one-sided. Talk about a patient journey, and before I get there, I know we've got some veterans from Malaysia, we've got veterans from globally, so let me put up this simple question. Remove your hats off from where you are and put yourself to the patient's side. Imagine you're on the bed, and the question is, imagine the room in the bed and you see that there's a light flickering, you see that your tap water is leaking. Who would you first call for? Good morning. Who would you first call for? Sorry? Nurse. Perfect. Let me just tell you, that's not right. Nurse is meant for clinical job, not for non-clinical. And Dr. Bale very rightly said, put the technology which actually acts as an operating system and works in a workflow and gets into workflow and not as a piece. If you put it as a piece, it will not work in. So what exactly we are bringing in is that everybody's been talking about AI. We're trying to bring not clinical, but a non-clinical, how exactly that agentic AI can replace what nurses have been doing, but they're not supposed to be doing. So what we're bringing here is beyond clinical excellence is also there as a non-clinical frontier. And if you really see what exactly I'm trying to focus on is that we've got robotics one side, which does a lot of clinical excellences, and doctors, as you rightly said, will not be replaced, but doctors who adapted technology well, especially AI, will create clear edge. But on the non-clinical frontier need, there's an opportunity. What the opportunity is that you need to bring total experience in the hospitals. What I'm making it very clear is that the clinical outcomes make you a hospital for sure, but the total experience, the journey of a patient makes you a leader. That's exactly what you need to be. What is the total experience? What are we talking about? What is the equation here? How do you bring the patient journey to make a wow factor? Let me tell you, patients, when they walk in, they don't walk in as in a hospital. They walk in they're walking in the hotel, and they want that customer delight. And they are looking forward to a disruption, like how Uber's made, how Amazons of the world made. The pivot here is that they are looking for a disruption right here. They want something new. They want something which the wow factor is up there in the hospitals too. And that's exactly why it makes you a leader where you are. And how do you get that? The pivot here is very clear, the concierge services. And how do you get that making the concierge service? And I'm telling you, it's no more luxury. It's a basic necessity, which is extremely important today, that hospitals understand that nurses are the key. And nurses are meant to be nursing us and not doing administrative job. They're not meant for that. Everybody says nurses are pillar. Absolutely, they are pillar. We need to respect them for what they are, but how? When technology could do the job, why do you make poor nurses do all these non-clinical jobs for you? So what we're talking about, how do you bring the total patient satisfaction is that bring in clinical results, which is extremely important. That's what we get admitted for. And then comes administrative ease, which is where technology comes in. And then comes the emotional support. That's where it makes a total experience. Let me just start this with telling you live experience of what happened with me exactly. I was admitted 8 months ago into the hospitals, and I was in one of the highest wards up there. Anything I needed, whatever I wanted, or my mom wanted, my wife wanted, all we did was pushing the button. Right, we were given one of the top wards of the best of the hospitals in the world over. All I could do is want a bottle of water, call a nurse. I have an issue with something going on, my thrush to be removed, call a nurse. And poor nurses come in running, and then they go back, and my mom was like, and my wife was frustrated now, why is it taking so long for them to even come and do a simple stuff? I was thinking in the bed, it's not the nurse's job. And I'm telling you, that's when, it sparks up saying, we are in technology field. We do a lot of process automation. Why can't we simply think that nurses are not supposed to be doing this job? And that's when we came up with this. And then I did a lot of research. This is quite funny, but this is important to know. What is pajama time? People ask me, what exactly does it mean? All these clinicians, I'm telling you, majority of them, if they don't have EMRs in the world or whatsoever, they sit in, do a lot of research, and do the documentation job post their clinical time, which is not advisable, which is not what they are meant for. That's exactly when you see the balance what I'm putting right here is that you'll see the more load is going on doing a lot of logistical tasks rather than doing more of clinical tasks. The best of the nurses, the best of the doctors are doing all those mundane jobs which is not supposed to be done by them. And that's why you see this absolute imbalance right there. And what we're talking about, you see the burnouts is really high. And if we could save 1 hour per shift, there's enormous saving right up there for all of these guys to actually concentrate and allow them to do what they're supposed to do. If you really see what exactly my top work is, very correctly saying, nurses should nurse, system should serve. Our system should be so good enough, the technology should be so good, AI adoption, it should be so good, the system actually runs everything else, and nurses are meant to do what they're supposed to be doing, that's nursing. I'm assuring you, 90% of the hospitals, I was in 6 countries before I'm standing right here. And last 2 months of my study has been only this. Every hospital is working in silos. I saw that people, and Dr. Belli rightly said, people spend with 400 different softwares, and they spend a lot of money in every department thinking that, yes, my food and beverage department, wow, what a software. Go ahead and put it up. Maintenance, good software, go ahead and put it up. You talk about feedback systems, good system. I was amazed. I was in one of the good hospitals in Malaysia. Dato is right here, who's the Dawn of the healthcare, and Dr. Kuljit up here. Dato, you should be knowing, Dr. Jacob, that when I was up there in one of Malaysia's largest chain hospitals, I was seeing the bedside, there were 4 different barcodes. And all these barcodes are like, one is for patient feedback, second is for food and beverage, third is for complaints of your, housekeeping. Oh my gosh, imagine I'm a patient. You can't expect me to pull up a system and go and keep checking up and, keep clicking buttons on the phone. No, I'm not meant for it. You need to take care of me. I can't be doing this mundane job, what you're supposed to be doing. That's exactly what I'm telling you. When you work in silos, hospital systems can never deliver the system or never deliver the patient satisfaction level what we're looking for. Not they can bring in the patient journey with a wow factor what exactly hospital is supposed to do. That's when you see an absolute imbalance right here. And that's when we say that we are trying, we need to connect this patient concierge with exactly what the concierge layer to the patient experience. And rather than making silos, fragment and bring in one platform, that's exactly we say, you might have EMRs which actually track. Now, beauty is here. We put cameras, right? We put cameras to monitor. But does it give action immediately? No. That's where it is. We bring in reactive versus proactive. We need to bring in something, rather than giving the feedbacks and waiting for the complaints to be taken care of later, it has to be immediate. The action has to be, immediate. And then comes the siloed operations need to be, this is exactly what we say, service delivery disconnected from clinical care, which is actually, again, a huge gap right there. So we need to bring all of these into one platform to make it AI work well. This is a very important slide. You look at that, what exactly is happening right there is that a system level concierge, what's happening right here is that on the bottom of it, you see that you have all these beds to EMR, so all of the right there, come up a little above, is what we put is that we've got patient concierge layer, which is, and above that is patient interference, and that's where we say, all of these, when you have in a defragmented way, it doesn't work. We need to fragment it well, sandwich it well to make sure AI comes in. How does AI come in? AI makes sure that all of these, what you're sandwiched in, is that it creates an intelligence between the hospital and the patient, which is extremely important. AI brings up saying, how could you Uberize these tasks, which all are working in silos? AI brings in and Uberizes this task, and then what you see is that accountability, which is extremely important. You put hundreds of the systems, but is there any accountability? It's not there. So what we bring in is that we bring in all of these, we sandwich it so well that AI makes everything work at a click of a button. So how do you bring this reactive services? Simple. Rather than a nurse, bring an AI agent, which could be on the bedside, which could actually help you do what you need. And that's exactly what you say. If there's a clinical and non-clinical, how do you actually bifurcate this? Everything right now, one point of contact is the nurse. So when we have this AI agent coming in and who intelligently bifurcates it and brings in medical emergencies separately, brings in service seekers separately, imagine how easy you make nurses' life. That's exactly what, people say, how could AI help? We may not bring in clinical everywhere. Getting into clinical AIs and bring these results, or we need still a lot of time. But what you could do right now using AI is you can improve your service requests, and bring in the patient journey. So what exactly is happening here is that we operationalize, bringing the concierge concept, wherein philosophy is only one. What gets measured gets improved. That's exactly what we believe in. And what we bring in is that if you see this omnichannel engagement is now real time and with real and with SLA enforcement. So let me just bring this up. What you're seeing right here, this is true and we've proven it. And this is happening. The ROI with the automated compassion is that you will see 40%, volumes of nurses calls have gone down, and the reductions in the burnouts has been 30%, which is quite impressive. Nurses today are in huge demand. And if we're going to push them to all of these, I'm telling you, we set up huge investments in the hospitals, but without nurses, hospitals are going to be an empty shell. Doctors are important, but nurses are much more. So with that, what exactly are we bringing with 2030 is that predictive patient experience. This is where it is. We say that, how do you lead the next frontier? How do you do it is that it's clear partnership. When we have partnership with leaders of the country, all we do is we say that AI manages the complexity, which is very important. Let the complexity be managed by the technology, and the humans can manage the healing. That's exactly what the hospitals are here for, and that's what we end up there. So predictive operations and zero friction hospital is exactly is what it's all about. And that's exactly what we say, let's empower nurses to nurse. And finally with that, let me run a small video, which I'm going to show you, and I'm sure everyone else will connect as to what exactly I'm trying to say, and what is the message we are actually conveying. Can I have the video, please? That's typical, yeah? A little volume, please. That's look at that. All he did is that after the phone, nobody turns up, so he's putting the nurse.
Why does it take so long for simple help? I need something to eat.
I'll be right back with something for you. Why me? I'm a nurse, not support for non-clinical requests.
And that's what we do is remove the nurses, bring in AI agent. Look at what it does.
How can I help you today?
I am hungry. I need some fruits and juice.
Sure. Your request will be processed in 4 minutes. Request assigned. Nearest staff notified.
Here you go, sir. Thank you. That was quick.
Well, that smile is exactly what we are looking for, and that's why we say, allow the nurse to do nursing, and allow these systems take care of all those problems, and let the healing be done by humans. Thank you for that. Thank you.
Mr. Surana, those were some truly innovative solutions, so thank you for bringing immense value to today's session. I would now like to invite our next speaker, Dr. Muhammad Afzal, Medical Director, Chief Flight Physician, Blue Dot. He would be speaking on managing information gaps in air ambulance operations. May we have you join us on the dais, please? Over to you, sir.
Hi all, good morning once again. So, when talking about quality and patient safety as in this dais, we all talk about the patient safety inside the hospitals, right? But there is this under-discussed topic where what's the quality that we are going to measure, or how the patient safety is being assured when these patients are being taken outside that four walls of the hospital. Pre-hospital care is not something which is not discussed about. That's not what I'm talking about. But it's even more. What if we are taking the patient outside the hospital, across borders, across continents, and how we assure the safety of those patients? How we measure those quality indices. So that's what I'm going to talk about now. So it's all about transforming this air ambulance missions into this quality controlled operations. When we talk about air ambulance, I like to put it as aeromedical operations, because air ambulance as such, when that picture comes into mind, people think about this ground ambulance flying and ICU setup just flying, but it's not just that. There are different versions of that. And I'm just going to give just two different paradigms of that. One is a private air ambulance, and one is a commercial airline medical escorts. So I'll just go into the pictures, but again, before that, private air ambulance itself is like in two diverse. One is a fixed-wing aircraft, a private aircraft which can fly patients all across the globe, and the small ones like the rotary wing, we call it, or the helicopters, as in general terms, which can go short distance and take the patient. But the aeromedical operation doesn't stop there. We have something called commercial airline medical escort, where as in we use the normal commercial airline as the one that we all fly in, like the normal national carriers, with proper setup, the proper or the equipments and the right team. That can also be a cost-effective method for transferring patients, and it can be a long range as well, because they fly like non-stop along. But what are the difference? What are the key? But again, I'm not going to talk about the rotary wing helicopter medical services here, because it's again a full different set of things that has to be discussed, and it's short range. Mostly I'm talking about the private air ambulance as in the fixed wing and the commercial airline medical escort. What are the key differences? As you can see, if it is a private, self-explanatory, it's a private air ambulance, right? We have the full control of the environment, full control of the aircraft. A full medical crew is available, and the custom ICU setup is possible. We can take whatever is in an ICU, nowadays even an ECMO, even a dialysis, outside of the hospital and fly the patient across the globe, across continents. And fully flexible scheduling is one thing. If it's the private, then the scheduling is up to us, right? And unlimited supply of oxygen. When I say unlimited, you can say, yes, oxygen can still run out, right? But we can still land and we can refill, we can like charge things and yes, go on the mission. And easy systems. But compared to that, so this is what I was just talking about. See, as you can see, this patient is on an ECMO with full integrated ICU inside a private aircraft, which he's being taken from point A to point B across continents. What about commercial airline medical escorts? Here, we have to operate within a different airlines environment, like a national carrier or any local carrier. But here, that limitation is like huge. We are not in full control of the timeline, the schedule, even the passenger cabin is like limited. But when I say this, it doesn't mean that we are just taking a patient in a place where the normal passengers are flying. We have a custom setup over there. We can even transfer patients who are even ventilated inside a private aircraft. But again, it's all limited as compared to the privates. That's the difference. But again, the schedule is dependent on the airliners, and it has to be restricted. It has to be pre-approved. They also have to approve this, that patient can go in their airline because it's their protocols, which is more. Here, you can see the difference. It's more limited. But again, if you can clearly see that patient is on a ventilator with monitoring and infusions going on, but this transfer is going on inside a commercial airline. That's the difference. It's a small setup, but again, a long, high-value transfer because the patient is being transferred from across miles, across different countries. So these are the two major environments which we are talking about. One, a private fixed wing air ambulance setup, and a commercial airline. This commercial airline, I will just mention CAMI because it's, a big term to like spell. So the contextual difference here beyond the entire process in an air ambulance, and the quality, the measurements, the KPIs can be very much clinical. We don't have to look into a lot of logistical things of the other industries like airlines or ports. But in CAMI, again, I'll be using that term now for the commercial. So we operate within another organization systems, right? So that measuring the quality is not just clinical. There's like a lot of coordination-based indicators there. So we'll just get into it. But why these KPIs matters, the key performance indicators or the quality indices? Only these qualities, if we measure it, then we can improve that into the patient safety part, right? So consistency is the most important thing. When such an operation happens across the globe, I have to say across the globe, it's not like confined to one place. The consistency of giving that standard care, delivering that standard care, it gets fragmented, right? It very obvious. But how can we standardize that delivery process across diverse airlines, diverse airports, different countries, different type of healthcare systems? So getting that consistency is the key here, how we can provide the same care across the globe. And safety. So monitoring such a patient, just look at that picture. This patient, again, on an ECMO with multiple infusions, a lot of moving parts, a lot of human factors coming in. Just, one single, the drugs has to be calculated up to micrograms, the equipment's charged up to the time of flying. All these things will take part in that safety of that patient, not just at four walls and the team surrounding, and also the backups. As you know, on air, we don't have any rescue calls, we don't have any more backups, but we can bring backups, but that's it. We cannot go on with a lot of stuff on 35,000 feet. So how to manage that safety? That's another key question. That's why we have to look into how we can control the quality over there. So, and the risk factors is unique to different aircraft cabins, different aircraft settings, the environment, and hospital, airports, the border security, everything is different. The risk, the safety, everything changes. Accountability, yes. Whatever we do, we are accountable. And when we are working outside a hospital setting, in a pre-hospital setting, especially on air, 35,000 feet, in a different airspace, which we are not even maybe authorized to work with, how we take that accountability on our shoulders. So the medical escorts are working without a full crew support. They are over there in a different airspace and still working with accountability. So specifically, especially in commercial airline medical escorts, we don't control the aircraft, we don't control the cabin, and we don't even control the timeline because it's all up to the commercial airline and how we take care of the patient with all those limitations in place. So when you talk about the quality and safety in this aeromedical industry, there are the three pillars that I always want to talk about. One is clinical excellence, for sure, because we are talking about patients here, right? So yes, clinical excellence and delivering that clinical care, the standard of care inside a hospital at 35,000 feet is the standard here. The clinical excellence where the patient safety, the medical outcome of the patient, why the patient is being transferred, what care he has been getting, and what the medical outcome of the patient, that's one of the major pillars here, right? Fitness to fly assessment, that also, when I say patients can be transferred, not all patients are for transfer. There are patients who cannot be transferred and should not be transferred. We cannot go into a suicidal mission, right? So making that patient fit to fly by properly assessing on a bedside or over a call or a phone with assessing reports, that also is one part where it starts even before the transfer by preparing the patient. If we if we don't plan proper, then we are again, going into a mission which is not going to be a successful one. So we just adapt and monitor all these approaches. The second one is the operational coordination. The transfer as such is, yes, the most core important clinical part, but the preparation and the coordination for all this is much more important, where multi-agency logistics like the airport, the ground ambulance, the border security, customs, immigration, all these multi-agency logistics has to be coordinated and put into one place and has to happen at the right time, the right place for a mission to be a success. And managing that timeline of all these third-party agencies is also important to make this mission a success. And the airline relationship also is very much important here, because when we are operating in commercial airlines, the relation with them is also much more important. This determines the mission success actually. And the stakeholder experience, whoever is the client, the patient, the family, the insurance, the government, everyone, their satisfaction is also a direct quality indicator, and that also tells about, the safety of the mission. So in air ambulance, when I say air ambulance, the private one, the clinical matrices is the most important one because it's more clinical, because there's not much of a logistical nightmare over there. But in CAMI, yes, this operational and logistical quality matters. Their KPIs is just, when you ask, it is actually, sometimes matters more in commercial airline than clinical. But when we talk about all this quality, and we go word with word, but how we are going to measure this? What are the challenges? This is challenging because, again, we are operating in an outside hospital setup, in a different place, in a different airspace, in a different country for that matter. What are the challenges here? The first one, as you can already say, the fragmented data source. The information that we need to improve our quality, which itself impact the patient safety, is fragmented across different organizations, the airlines, the airports, the hospital, the receiving hospital, and the hospital where the patient being treated, the ground ambulance, the ground handling. So the information is scattered across different organizations. And the worst part of it is it's not under our control. Most of this organization is not under our control. So getting that fragmented data source to get the improvements is the most challenging part here, if you ask me. And not just, the data that is in different organizations, it might be in different languages, different countries. And the non-standard part of it is also the other problem is, it's not standardized. And the event frequency, this doesn't happen every day. So yes, that low event frequency, that also makes an issue. And there are subjective quality indicators like, the coordination, quality, communication. These are subjective, not objective. So to measure it is another challenge. And that building that, that culture for measurement is where, we can make this data, even when the data is imperfect, that's what we have to look into. And not least, and not least, here, when we transform this data, there are a lot of changes which can happen. Documentation delays can be improved. We can make structured checklists which can improve this thing. And we can get into this airline industries where we can make MOUs and discussions with them where we can improve their way of working as well. And these continuous improvements can be done. And we here, actually, in our part of the world, there are a lot of agencies. We can regulate these standards for air ambulance operations. So we had to come together and get this, like URAMI in the European side, CAMS, NAMTA in the European side, NABH in our subcontinent. So all these agencies has to come together, and international and national data sharing policy should be there, and a standardized process can be built in, which can finally making this aeromedical transfers a quality operated operation. And together, yes, we can elevate these operations from just ad hoc, fragmented coordination to a measured one and an optimized one and a world-class patient care. Thank you for listening.
Thank you, Dr. Afzal, for the meaningful insights. Ladies and gentlemen, as we prepare for our upcoming session, we promise it's going to be very interesting, so let's look forward to those. But before that, I have a few important announcements to make for all of you. Before we proceed, may I please share some important pieces of information that would assist you all. We request all delegates to please keep their mobile phones on silent mode during the sessions. We request you to collect your registration kits, which include the list of activities, postcard, and your lunch coupon if you haven't done so already. Kindly wear your conference tags at all times, as this will be required for access to the conference halls and common areas. The restrooms are located just outside the hall. Our volunteers will be happy to guide you if needed. We request everyone to adhere to the session timelines and be seated on time so that we can maintain the flow of the program. For any logistical support or queries, our volunteers and badges are more than happy to assist you. And on top of that, most importantly, your questions matter. And here's how you can ask them during the conference sessions. Please log in to the IHD app, go to IPSC, open the menu, select Conference Agenda, choose your session, tap on Ask a Question. Submit your questions through the app. Selected questions will be announced during the session and answered by the speakers. Once again, thank you for your cooperation. Before we proceed, some more important announcements for you. Before the sessions, we also have lined up a series of fun, engaging, and rewarding activities, from lucky draws to interactive challenges to creative social media contests and immersive experiences across the exhibition areas. Don't forget to navigate the pathway to care through maze that promises to be really interesting. Do remember, all rewards and awards will be announced during the valedictory ceremony on day 2, that is today. So stay engaged, participate actively, and don't miss out. So keep your eyes open, scan those QR codes, visit the stalls, and most importantly, enjoy the experience beyond the sessions. Today, we also have Hope and Clinovate sessions, so please do take out time to hop in between those sessions as well. You would certainly learn something new. And we prepare for our next session now.
Innovation, we are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference.
Ladies and gentlemen, what you hear right now is the IPSC anthem that's specially been prepared, celebrating the spirit of patient safety. So do enjoy those magical musical moments while we wait for a really interesting session. It is also my proud privilege to acknowledge our title partner, Winmec Healthcare Group. Our sincere thanks to our platinum partners, Roche, Pfizer, and Abbott, and a special mention to our diamond partner, Samsung. And let's give a big round of applause to all our esteemed partners for standing with us and making this wonderful event possible. Thank you for your trust and partnership, and thank you to each one of you for being present here.
We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. to improve safety across. We across.
So, ladies and gentlemen, let's bring some more energy into the room. After an enriching session of discussion and insights, we now invite you to sit back and enjoy a captivating dance performance. So we have some wonderful dancers for you.
We are here for patient safety. We are here for quality care. We are the champions of today.
Wow, what a mesmerizing performance. Thank you to the group.
We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies.
Ladies and gentlemen, welcome to our joint plenary session, which brings together 4 powerful platforms: International Patient Safety Conference, Healthcare Operations and Patient Experience, which is HOPE, and THIT, Transforming Healthcare with IT, and Clinovate, our new addition, each playing a unique role in advancing healthcare excellence. To lead the conversation on collaboration and shared impact, it's my privilege to invite Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospitals Enterprise Limited, on the stage. Ma'am, may I please request you to join the stage?
We are here to make a difference. We are the International Health Dialogue. Technology is our power. We commit to improve safety across.
Over to you, ma'am, to address the gathering. Thank you so much.
Namaste and good morning. We finished an exciting day yesterday and we're looking forward to progression of the thought process that we had yesterday on how we come together to advance healthcare, to create new solutions to save more lives. Yesterday, as I was talking to many people, they kept saying, you're telling us at a conceptual level, but please go down deeper and tell us what you do. So I'm going to share some more of those thoughts. This morning I told the team, please, pull out some different slides. But let's begin with first thanking, welcoming, and addressing our many, many dignitaries who are here from various countries, CEOs and leaders from various hospitals, partners from the Joint Commission, ISQA, and others, other excellencies, and most importantly, healthcare leaders, our doctors, our nurses, our technologists, who are all coming together to make the world a better place. I also want to do a special mention of one of our doctors, Dr. Vijayanand Reddy, who was recently awarded one of our Indian civilian honors, Dr. Padma Shri. So let's happily begin by welcoming him and saying, congratulations, doctor. We're going to have you on stage later. Thank you. So, can I have slides, please? So we'll talk about how we can scale performance using technology, focusing on outcomes and saving lives, and embedding empathy into everything that we do. And that brings us to International Health Dialogues, a confluence of patient safety, transforming healthcare with IT, healthcare operations and patient experience, and Clinovate, the latest in clinical. So that's how this has all come together. But I just want to say that this is your conference. You are the ones who are making this happen. Yesterday in the award ceremony, there were people who have received this award. Someone said, I've been attending 13 years in a row. I've got this award 11 years in a row. And I see speakers who yesterday were unwell, but today have found a way to make it here. Hi, Neelam. So this is a community. We are now becoming a tribe who comes together with the same idea, with the same vision, with the same purpose of transforming healthcare. And in this mission of shared purpose, yesterday, Gauranga Das, one of our spiritual leaders, he said, don't worry about the noise. You have social media, you have your telephones, you have your pagers, you have 100 people calling you. If you have a purpose then everything combines towards your purpose. And I think our purpose, and truly we're all here for that, to bring healthcare within the reach of everyone. This purpose of higher quality, greater access, sustainable cost, and also finding a way not just to treat people when they're sick, but find them early, focus on preventive care and keep them healthy. This is our unified mission. A minute about India. I do want to say we're a young nation, but we will soon have one of the oldest populations as well. But 43% of our population is under 24 years of age. We produce over 118,000 doctors annually and 120,000 nurses. So this goes with what I was saying yesterday to some people. The heal in India, the heal from India, and the heal by India. Our AI skills in terms of penetration are in the #1 category, because while you may look at the development, the platform layer, the energy layer, the chip layer, in terms of the dispersion layer, India's adoption of AI is incredibly high. And of course, 600,000 talent pool of the AI technology. So these are the pillars of the foundation. And because of our high out-of-pocket expenditure, we've learned how to keep our costs low and evolve a new healthcare system of high quality but low cost. The journey for Apollo began with our mission, our chairman, Dr. Reddy, who returned from the US in '83. This is his story. May I have volume, please? Because nothing tells the story as good as some pictures. And starting from, a difficult beginning of groundbreaking when it was, people didn't conceive world-class healthcare at that point, to the inauguration by Ziani Zail Singh.
Apollo began as an idea. Today, it's a movement, an institution, a commitment. Apollo isn't just a hospital. It's India's healthcare backbone. From one hospital to 79 hospitals. From one doctor to 13,000. From one bed to 10,400 beds. 6,800 pharmacies. 2,200 diagnostic centers. 165 dialysis clinics. 252 dental centers. 275 clinics, 800 telemedicine hubs. From serving one nation to earning the trust of patients across 150 nations. 200 million lives touched. Because at Apollo, care isn't delivered. It's orchestrated with precision, pace, and presence. Exceptional outcomes. Not just excellence, but repeatable, scalable, evidence-based mastery. This story of lives saved, futures rebuilt, behind every milestone, a mind that wouldn't give up. At Apollo, with AI-powered videos in 30+ languages, live webinars with doctors, millions engaged on our website and social media platforms. Our doctors now inform, influence, and inspire. Across borders, across languages, across lives. They work inside India's most powerful healthcare engine, backed by data, driven by research, and elevated by technology. With systems that support, with platforms that scale, with tools built around clinical thinking. From drone-powered medicine deliveries navigating the toughest terrains of Arunachal to teleclinics connecting patients. From caring for the elderly in our senior living homes to screening school children in the remotest districts. Apollo's care doesn't end at the hospital gate. It crosses borders, breaks barriers, and reaches wherever healing is needed. Because for us, healthcare isn't a location, it's a promise. Here's to the future.
Thank you all. This cheer belongs to 100,000 Apollo family members and the vision of our chairman, who you will hear speaking later. But I think coming together, what we know is that this is just a step. We're not even halfway in the race, and we need to work towards creating a new framework for healthcare. A framework which is backed on building additional infrastructure, on scaling our preventive healthcare focus, on enhancing and creating a digital data backbone, of bringing, reducing the skill gaps and enhancing the number of healthcare workers who are AI-enabled and technology savvy, but also who have embedded the empathy in reducing regulatory drag so that we can think as one world and take healthcare workers across the world to serve wherever they are needed. This flywheel, which will continue to serve each other with a base of innovation and new solutioning. Finding ways to do that, one of the core processes that I want to bring, many of us here today are engaged most of our time in curing the very sick, in healing those who come into our emergency rooms, our theaters. We must look at this new era of preventive healthcare. And here, this platform that we have created is something that we are ready to share with the world in terms of the AI-enabled health risk scoring, a comprehensive reporting, appropriate testing, and then a guided path to wellness. I also believe that being close to the customer is critical, and therefore Apollo 24/7, India's largest omni-channel healthcare platform, which is serving over 40 million people, connects this ecosystem to every customer on their mobile phone with various features and capabilities. Our clinics bring healthcare closer to individuals and find a way to ensure that they're not denying themselves care because they're scared of going to a large hospital or the hospital is too far away. We need to bring care closer to the individual so that keeping themselves healthy is an automatic. Also, over the last 4 decades, one of the most important things we've done is advanced clinical care, whether it's high-end diagnostics, which helped our doctors find more and heal more. It's oncology with the best treatment capabilities. It's robotics and minimal access surgery and genomic testing. So the latest in terms of pioneering, and of course Asia's first proton machine, each one of these were steps towards bringing high-end clinical care closer to the customer. But ultimately, you are only as good as your outcomes, your benchmarking, and your validations. So we're proud to have been the first JCI accredited hospital in India, among the largest number of JCI accredited, thank you, and privileged to have this with the Joint Commission team here. And we will continue our journey in this area, but also the clinical outcome scoring methodology, where the parameter, the benchmark, and the outcome is tracked continuously across the ecosystem. Today, this is a digital dashboard. We auto-capture these outcomes, and we've added prompts or the patient-reported outcomes as well, because it is the most important thing to stay close to the customer, to work with the clinicians, and to ensure these high-quality outcomes. And finally, while you do all these wonderful things, people need to be able to afford them. So clinical care at an affordable cost, which is the magic mantra in enabling access. We have found ways to innovate in terms of the supply chain, the ecosystem, the methodology, and bring costs to 1/10 of global prices. And it is because of these outcomes and the cost that we are able to have patients from 140 countries come to us. And this is not just Apollo. There are many other hospitals in the audience who are doing this. All of us are together in this concept of Heal from India. We're very, very thankful. Many of you are here today. Thankful for your trust. I see patients from Tonga who come in, and I hope they're feeling at home. I see patients from Zambia. We've learned how to cook like the Tanzanians like to eat ugali. We are trying to be close to our customers, but give them this high-end care with a sense of being away from home. But it's also important to continue to build the innovation ecosystem, to push on research, to guide with knowledge, and to partner extensively. And these are some of the things that we're doing in that area. And ultimately, one of the things that our teams always remember, that whatever work we do, each one is a personal story. So whether it was sending the conjoined twins back home on Christmas Day so they could celebrate with their family, or this young boy with Nebelen-Rhodes disease who saw the world for 11 years upside down. And because of this surgery, which was a complex and difficult surgery, he now sees the world from the right. So I I thank our doctors for the great work that they do. And I believe that our people are our greatest strength. So our nurses, pharmacists, technicians, every single one of you whose heart is beating for Apollo and for the healthcare of the world, congratulate yourselves, feel proud of what you're doing, and find the energy to keep going. We are only halfway in this race or this marathon. And we have lots of new tools to help you, and technology is going to be one of the greatest tools to enable. Yesterday I said this, I repeat it again. Our challenge cannot be handled by linear growth. We need to look at exponential growth in our solutions and our access to be able to bring healthcare to the world. That's how we have to achieve the affordability, the scale, and the quality simultaneously, embracing technology as our engine. Some quick things into the work. One is teleradiology, so that advanced, super specialized opinions can be given on reads, given fast, given across the world, so that the entire aspect of using artificial intelligence appropriately with algorithms that make a difference. Whether it's our antibiotic prediction program, whether it's our pre-diabetes or risk screening program, to date we've had 3 million API calls across the various streams, and I believe we've just touched the very edge. We're just beginning in this journey. So I think that across, if we partner extensively, let 1,000 flowers bloom in terms of the AI algorithms that you embed, so that nurses are more aware, so that we never have a drug-drug interaction. There's so many things that we can fix by embedding AI into our workflows, and then putting agentic AI, so we remove mundane work. Our call centers must be manned by agents first before human beings. Our clinician co-pilot that we've done with Microsoft, we may share that a bit, and the patient co-pilot. Each one of these are bringing agentic AI into the forefront with the human in the loop, and re-engineering care pathways with AI embedded in them, so that we're a safer environment, a smarter environment, a more proactive environment, and an environment that can reach out to more people. In this one, we've had over 200,000 patients monitored, but the beauty is that today in the wards that are being covered, I'm happy to say we've had 0 code blue, because when the parameters begin to change, the med team can go in, decide whether they're changing medication or moving the patient to ICU. We don't want to have an emergency crash or a code blue in the wards when they're in the hospital. These are things where the pathways are changing. And over 100+ clinical protocols have been built, embedded, and therefore we're creating safer environments. And these are solutions that we're very happy to share with other hospitals across the world, other health systems, other governments, so that you can leapfrog your development stage and bring these safer environments within the reach of your people. I must say that this journey began for us in the year 2000, when we started our first telemedicine, when President Bill Clinton was visiting India, and our chairman, Dr. Reddy, my sister Shobna, who will be here later, were right there when he pressed the button, connecting our village with the place where my father was born. Just 7,000 people live there. He connected that to our high-end hospital, and this was in the year 2000, so 26 years ago. It's been a great journey, and I really believe that we can do so much more, and we're very happy to share these. Now, some of these are things which are in the maze of the activity which is happening in their hospitals. Deciphering our health systems into moving from retrospective quality analysis to real-time intelligence and reports is another very, very important thing, so that you can proactively go in there and make a difference. Our CEO from Sheba yesterday was telling us some of that. Health Access is our technology company. The teams are around here. They're very happy to share anything that you need to know across the spectrum in terms of building solutions, AI platforms, and workflows across the care continuum that you can embed, that you can put on top of your existing IT systems, that you can use in a modular manner in any aspect. In the new hospital that we're opening, we'll share a little bit more about that. We're actually connecting the ICUs. The emergency room is connected with a 5G ambulance. So many of these are modular solutions that you can pick up and share. I hadn't intended to go through each one of these, but yesterday many people said, get into details, tell us what all of you are doing. So this is some of those being shared. I think one of the most powerful things is the AI-enabled command station. So you do a connected ward, you look at the EICU, you look at the home, you add the ambulance connectivity to it. This is 2 validations from just partners who are already using. I'm not going to go into this because we're running out of time. But this is the CEO of Mayapada Hospital talking about how he's using the APIs.
And advanced digitalization, including collaboration in AI and health technologies. Today, AI-based risk prediction has been applied to more than 40,000 individuals, supporting early identification of cardiovascular risk, pre-diabetes, and type 2 diabetes. We have also established Mayapada Apollo Batam International Hospital as a key milestone in our partnership. This collaboration reflects our shared commitment to advancing healthcare standards in Indonesia, and we look forward to deepening this partnership in the years ahead.
Through the collaboration with Apollo Health Access and Arkansas Heart Hospital, we are so proud to have started our efforts together in the customer call center, where we have together dropped patient average hold time between 7.5 minutes to 9 minutes on average. We're so thankful for the efforts of the teams thus far. We have so much coming here in the next few months. Things like business analytics, things like longevity, and what we're very excited about in the imminent future is our coding collaboration. So we're very thankful for the collaboration between our 2 health systems, between our cultures, and we're excited about the future.
I actually wanted to spend more time also talking about the work we do in rural healthcare, in primary care, but I think we're really running out of time. So I want to end with sharing a concept or a vision that we were working on building. There's a new hospital coming up in Financial District. We're due to open this week. We called it the Hospital of the Future. We looked at connected environments, AI-assisted diagnostics, smart laboratories, the 5G ambulance I spoke about. We haven't yet finished, but a digital twin is coming up, the electronic health record, a paperless hospital, immersed learning so that in 15-minute modules, your nurses can do quick learning about things while they're in between patients. Each one of these, drones for pickup and delivery of ambulances, of medication, various aspects, whatever technology can give us, can we embed it into healthcare to make healthcare better? Besides, of course, the digital facility management, command centers. So this was a very hospital-centric view. And then I said a hospital of the future is not enough. If we're thinking proactive, predictive, personalized, preventive, we need to go to the next level, which is the health system of the future. So the hospital buildings are then connected to the clinics. The command centers can talk to small emergency rooms or urgent care centers. The data can be used with partners for research across to accelerate discoveries, biomarkers, novel new cures. The digital front door connects the customer into the home, and each one of these are connected through your mobile phone with your customer. So many of these. So I think now we've expanded our thought process to say, how do we build health systems of the future? And again, I see collaboration and partnership from technology companies, from hospitals who want to do this, from individual doctor practices who want to get connected into this ecosystem. Let's find a way to make healthcare smarter, safer, more equitable, and think about working together. Because at the end of the day, the seamless connection surrounding the customer, surrounding the healthy individual and keeping him healthy is really what the world is all about. That's the responsibility that we have taken upon ourselves, and the world is looking to us. So let's find ways to do it together. Once again, I want to thank every single one of you for being a partner, for being a friend, for being a well-wisher in this journey of building a healthier world together. God bless you all, and let's find the strength and the courage to do what the world is looking at us to do. Let's co-create the future of healthcare. Namaste.
Thank you, ma'am, for your address. May I please request you, ma'am, to stay on stage? Okay.
We are the ones who pave the way.
Ladies and gentlemen, to continue this conversation about working together to create meaningful, sustainable impact for caregivers, institutions, and most importantly, for our patients, we are honored to welcome our guest of honor. Ladies and gentlemen, please join me in welcoming our guest of honor to the stage, Shri Konda Vishweshwar Reddy ji, my Honorable Member of Parliament, Government of India. Please join me in welcoming our guest of honor, Shri Konda Vishweshwar Reddy ji, to the stage. May I now invite Dr. Jonathan Perlin, President and CEO, Joint Commission, to kindly join us on stage.
That is changing people's lives. We are here.
Ma'am, may I please invite you to join us on the stage? It's my honor to now welcome our honorable international ministers of health coming from different countries here to the stage. To start with, may I request Professor Jean Rosaire Ibarra, Honorable Minister of Health and Population, the Republic of Congo, to be here on the stage with us, please. May I invite Dr. Grace Nsu Danka, Honorable Minister of Health, Ghana, to join us here on the stage. May I invite Mr. Huaka Vemeliku, Honorable Minister of Health, Tonga, to join us here on the stage. And we invite Dr. Sarah Cleto Rial, Honorable Minister of Health, South Sudan, to join us here. I also take the privilege to invite Ms. Shobna Kamnini, Executive Chairperson, Apollo Health Co. Limited and Apollo Pharmacies Limited, here to the stage.
We are the champions of today. We are the ones who shape the future.
Thank you all the dignitaries for joining us on the stage. May I request you to take your seats, please? To give us an overview of IHT 2026, now I request the AV team to quickly play a video for us. Thank you. Now we start with our felicitations. May I invite Mr. Subramaniam, CEO International, to felicitate our guest of honor, Shri Konda Vishweshwar Reddy ji. Ladies and gentlemen, Mr. Subramaniam, honoring our guest of honor here, Shri Konda Vishweshwar Reddy ji, Member of Parliament, Government of India. Thank you so much. A true pioneer of Indian healthcare, whose vision placed quality, compassion, and patient safety at the core of care delivery. We now invite you to witness a virtual address by Dr. Pratap C. Reddy, Chairman, Apollo Hospitals. May I request the video to be played, please?
A warm welcome to all the delegates gathered at the International Health Dialogue 2026. We have come together not merely as representatives of healthcare sector, but as stewards of a common vision, a vision that envisions healthcare safer, more innovative, and centered around the patient. I think this is very much. Continuously must think of what can we innovate. Now, in the present day, once again, healthcare stands at defining moment. Around the world, we're witnessing extraordinary advances in science, technology, and clinical capability. At the same time, healthcare systems are facing increased pressure and rising expectations from patients and communities. These realities may look different across the countries and healthcare systems, but the underlying challenge is shared. So, how do we translate progress into care that is safe, more equitable, and truly centered on the people? That shared challenge brings us together under the theme Global Voices, One Vision, Patient First. It reflects our belief that while few patients may differ, our responsibility to shape the future of healthcare collectively. At Apollo Hospitals, we've always believed that meaningful progress in healthcare is shared through a dialogue. Over the last 43 years, since the inception of Apollo Hospital, we've brought several incentives to make a significant impact on patient care. First, of course, the establishment of the first multi-specialty hospital in the country, which today is over 74 hospitals, and in almost every single field, we have reached global standards and global value. I'm a cardiologist. I started because I lost a patient who couldn't go to abroad for cardiac surgery. Today, we have done over 300,000 cardiac surgeries with over 99% stake, first in the world. So I think this is because we continuously said, whatever we will do, patient as our first priority. I think patient priority, and now we are talking about saying health first, and health should be prioritized for every individual. And over 12 years ago, Sangeeta worked together to create this Internet Health Dialogue to be a platform where global voices come together. I think I'm very happy that today we are all here, several places in the nation. Health leaders, clinicians, innovators, policymakers, practitioners, and practitioners who share their insights and learning. The International Health Dialogue brings together multiple conferences that address healthcare through interconnected perspectives. So ISPC, we focus on strengthening patient safety and quality as foundation of care. That explores the responsibility of using technology and digital innovation in healthcare delivery. HOPE examines healthcare operations and patient experience scale. This year, a new edition is Innovate, a focused platform for clinical dialogue and innovation across cardiac oncology, cardiac sciences, women's healthcare, longevity, lab medicine, and diagnostics. The total focus should be around the patients. IHD stands for collaboration over silos, learning over assumption, and action over intention. So, as the next decade unfolds, the direction healthcare must take is becoming increasingly clear. Patient safety must remain non-negotiable foundation of every system. Technology must enable better decisions and better outcomes while keeping higher at the scope. Healthcare system must evolve a delivery quality, access and trust, and scale across geographies and generations. My intention is that we should continuously innovate. As I said, in the 40 years, we brought the multi-specialty hospital, but there are many, many good hospitals in the country and around the world. We are continuously improving and innovating to give better scale. As I said, we are beginning to, in the 40 years now, we are not saying, we are now, the healthcare today, around the world is progressing very fast. But the involvement of the entire healthcare system should be equalized and continuously innovate. The newest innovation, I won't say innovation, the newest thing that we're going to announce is going to start with the whole world. Everything works. The hotels work, the airlines work, the coffee shops work, all of these work 365 days. Why hospitals don't work on Saturdays, Sundays? Are we safe on Saturdays, Sundays? I think that this is where Apollo is going to break this big news, announcing we've already prepared. All of our hospitals, all of our clinics, all of our systems will be available for people throughout the year, 365 days. Already we brought the first time in the nation emergency, 24/7. And now, today I make an announcement before you, and I think the world must wake up and say why we are not working on Saturdays, Sundays. Because healthcare is most important and doesn't save them on weekends. So this is where new thought-breaking incentive, which should have been done earlier, now we are announcing to the world that Apollo hospitals and Apollo system will be worked 24/7, 365 days every year. Every Sunday and Saturday, there's no sickness, there's no holiday for Apollo never sleeps. So I think all should adopt the system so that we will be able to give good care all the time to all people and continuously innovate. Above all, healthcare has a moral responsibility, and this calls upon us. This is why I realize it's a moral responsibility to have brought in the best healthcare systems in the country and best technology. And now I realize that the world is sleeping on weekends when healthcare is required 365/24/7 to build the economic system that are resilient, transparent, and prepared for the needs of tomorrow. Therefore, we shape through this dialogue, will influence the lives far beyond these halls. Whatever we are discussing here, we're taking it to the world. It will shape the futures of families and nations who count upon us with hope in their hearts. So let's move forward together and wisdom, humility, and compassion. The time is now for us to herald a paradigm shift in the way we look at healthcare and in the health of individuals, families, and communities must be protected and nurtured, not within the hospital walls, but in everyday life. And this is that belief is the heart of my vision for the future of health at health, happiness at home. So please take you that we are all here to bring health, happiness at home. And remember that Apollo will launch, Apollo never sleeps, we will be open on Sundays. And hope all of you will follow this so that healthcare is available for people when they require. Because nobody knows when they're going to fall sick. So health should be priority for everybody. And remember, health, happiness at home. God bless. On this important conference, I'm announcing a major announcement which I've made, that Apollo never sleeps and it will work 365 days. There's no holiday, Saturdays, Sundays. So all of our Apollo services will be open for people because health should be a priority for everybody, and for hospitals it should be a priority to give it to them when they're sick, because nobody knows when they're going to fall sick.
Thank you, sir, for your insightful address and for continuing to inspire us with your vision and leadership. May I request Mr. Russ Brenzel, Chime CEO, to join us here on the stage, please. Thank you. May I request Dr. Jonathan Perlin. May I now request Dr. Jonathan Perlin to share his insights with us, please.
Namaste and good morning. On behalf of Joint Commission International, it's a delight and an honor to be here amongst Your Excellencies, Dr. Reddy, and fellow colleagues committed to a global vision, global voices with one vision for safer, more effective, more compassionate healthcare. Thank you all for what you do in making the world a better place. It was an honor and delight to hear Dr. Reddy describe his vision for healthcare and to hear Dr. Sangeeta Reddy describe the marvelous accomplishments of Apollo. I use the word safe and effective and compassionate healthcare because that's really the product of trust. And I know in Apollo and amongst this convening that Dr. Reddy, Chairman Reddy, gave voice to the requirements for healthcare to really be built on a foundation of quality to build trust. Joint Commission International is a global not-for-profit organization with the privilege of working in 86 countries. Our vision, the way we give voice to safe, effective, and compassionate healthcare is by our vision statement, that all people always experience the safest, highest quality healthcare across all settings. That's 3 all. All people, always, all settings. And our mission has 2 parts, some of which echo what I said yesterday about the relationship of Safety 1.0 to 2.0. It's to enable and affirm the safest and highest quality healthcare for all. The affirmation is really in the form of the gold seal that identifies that certain criteria for which a patient can place trust have been met. But importantly, it's not only to affirm, it's to join with others to enable, to uplift, to assure that safety, that effectiveness, that compassion. While our traditional remit has been really more complex healthcare organizations, ranging from community hospitals to academic health centers, I'm very proud of a new initiative that we launched called our Pathways program. It was really founded by our wonderful colleague, Dr. Neelam Dhingra, who's here today. Dr. Neelam was one of the founders of the Patient Safety Unit at the World Health Organization. And the Pathways program has 3 parts. It's really directed toward lower-resourced environments, and it's a program that thus far we have no charge for. It has no cost to these organizations. The first part is a ministerial level engagement, and this is occurring today in 3 countries, in Cambodia, in the Maldives, and in the Philippines, building in an infrastructure to address quality and safety, trust, and compassion. The second part is the Trainer of Trainers program, and this is really exciting. This is the notion of building capacities, strengthening capacities and capabilities across countries. And just last year, that started with only 15 countries, and this year it's already 30 countries, including, and I am so proud and appreciative of the partnership here, including India. It started with the AIMS program interactions in Bhopal and Delhi, and we hope it will expand even further. And the third part of the program is our global patient safety grand rounds. To date, thousands of individuals have joined in, and our next discussion coming up in March is on the topic of compassion in healthcare, something you heard echo throughout the conference, something you heard echo throughout Dr. Reddy's comments, something you heard echo throughout Chairman Reddy's comments as well, and something that we're proud to have Dr. Anupam Small. Dr. Anupam will speak about compassion in healthcare at that patient safety grand rounds in March. Let me close by the framing thoughts that guide our work today. It's really what we call our HELP agenda. HELP being an acronym for health equity, environmental sustainability, learning based on responsible AI, and finally, performance integration to integrate equity, sustainability, and responsible AI into the operations of healthcare across all circumstances. So while Joint Commission is but one voice, we really join with hundreds of thousands of voices across 86 countries and proudly join voices with all of you in one vision for safer and more effective and more compassionate healthcare. And with that, my heartfelt gratitude, namaste, and thank you so very, very much.
May I now invite Ms. Shobhana Kamineni, Executive Chairperson, Apollo Health Co. Limited and Apollo Pharmacies Limited to join us here on the stage, please. Welcome, ma'am. Now I may request our International Health Minister representing various countries to share their perspectives. And I invite Professor John to share their experience.
Mesdames et Messieurs les ministres, chers collègues, distingués invités, Mesdames et Messieurs, c'est avec un grand honneur, en ma qualité de ministre de la Santé et de la Population de la République du Congo, que je prends la parole ici à Hyderabad, l'un des pôles les plus dynamiques du monde en matière d'innovation médicale.
I'm deeply honored to my capacity as a Minister of Health and Population of the Republic of Congo to take the floor here at Hyderabad, one of the most dynamic pools in the world in terms of medical innovation.
À l'occasion de ce 13e dialogue international sur la santé, j'aimerais évoquer un enjeu stratégique majeur pour nos nations.
On the occasion of this 13th International Dialogue of Health, I would like to raise a key strategy issue for our two nations.
La coopération internationale en matière de santé et plus particulièrement le partenariat entre la République du Congo, la République de l'Inde et le groupe hospitalier Apollo Hospitals.
International cooperation in the field of health and more specifically partnership between the Republic of Congo and the Republic of India, in particularly with the Apollo Hospital Group.
Je remercie chaleureusement les autorités indiennes pour leur accueil ainsi que les organisateurs de ce dialogue qui symbolise une plateforme exceptionnelle de partage et de collaboration internationale.
I would like to express my heartfelt thanks to the organizer of the dialogue, which symbolizes an exceptional platform for sharing and trans-international collaboration, to acknowledge the support of both India and Congolese government, whose cooperation helped create a favorable environment for the successful holding of today's event.
Distingués invités, Mesdames et Messieurs, dans un contexte mondial marqué par des crises sanitaires récurrentes, la montée des maladies non transmissibles et la nécessité de renforcer la résilience de nos systèmes de santé, la coopération internationale apparaît plus que jamais comme une réponse essentielle et durable.
Ladies and gentlemen, in a global context marked by current health crisis, the rise of non-transmissible disease and the need of strengthening of resistance of our health system, international cooperation appear more than ever as an essential and a sustainable response.
En effet, nous vivons une époque où les défis sanitaires dépassent largement les frontières nationales. Les maladies émergentes, l'expansion des maladies non transmissibles, la pression démographique, les crises climatiques et les inégalités d'accès aux soins nous obligent à repenser les modèles de coopération internationale.
Indeed, we are living in a time of healthcare challenges that extend far beyond national borders. Emerging disease, the spread of non-emerging disease, transmissible disease, demographic pressure, climatic change, crisis, and inequity in access of healthcare require us to raise existing international cooperation framework.
Évidemment, les partenariats ne sont plus une option. Ce sont des leviers essentiels pour renforcer les systèmes de santé, moderniser les infrastructures et garantir à chaque citoyen un accès équitable à des soins de qualité.
Obviously, partnerships are no longer an option. They are essential levers of strengthening the health system, modernizing infrastructure, and guaranteeing that each citizen has equitable access to quality healthcare.
La République du Congo, sous l'impulsion de son Excellence, M. Denis Sassou Nguesso, président de la République, chef de l'État, s'est engagé dans une dynamique ambitieuse de transformation du système de santé de notre pays.
The Republic of Congo, under the leadership of His Excellency Mr. Denis Sassou Nguesso, the President of the Republic, has engaged in ambitious dynamic of transforming of our country's health system.
Nos priorités sont claires. Améliorer l'accès aux soins spécialisés de qualité, renforcer la formation des professionnels de santé, moderniser nos infrastructures hospitalières, promouvoir l'innovation et la digitalisation des services de santé, développer des partenariats solides pour soutenir cette évolution.
Our priorities are clear: improving access quality of specialized care, strengthening the training of healthcare professionals, modernizing our hospital infrastructure to promote innovation and digitalization healthcare system, develop strong partnership to support our evolution.
Notre objectif ultime est simple: offrir à nos populations un système de santé résilient, performant et tourné vers l'avenir.
Our ultimate goal is simple: to provide for our population a resilient, efficient, and people-oriented health system for the future.
Pour matérialiser cet objectif ultime, nous avons inauguré au mois de novembre 2025 3 nouvelles formations sanitaires modernes dans 2 hôpitaux généraux, construits chacun sur une superficie de 5 hectares, dotés d'un plateau technique de haute performance et d'une capacité de 35 lits.
To realize this ultimate goal, we have inaugurated in November 2025 3 hospitals, new model healthcare facilities, including 2 hospitals general. Each built on area of 5 acres, equipped with a high-tech platform performance and a capacity of 235 beds, and Institution National of Biologic and Health Monitoring Agency, equipped with 5 interconnected multidisciplinary laboratories, convey the molecular, biologic, functional genetic, and microbiology, microchemistry, and immunohematology, and the food science.
Cet institut a pour mission, entre autres, d'assurer une surveillance biologique et épidémiologique des maladies à potentiel épidémique, de détecter et de prévenir diverses pathologies humaines.
This institute's mission includes, among each things, to assure biological and epidemiological surveillance disease with epidemic potential, to detect and prevent various human diseases.
Distingués invités, mesdames et messieurs,
distinguished guests, ladies and gentlemen,
les relations entre la République du Congo et la République de l'Inde reposent sur des fondements solides, nourris par une vision commune du développement, par la coopération sud-sud et par un engagement constant en faveur du renforcement du système de santé de notre pays.
Relations between Republic of Congo and Republic of India rest on solid foundation, fueled by shared vision of development, by South-South cooperation, and through a constant commitment to strengthening the health system of our countries.
À cet égard, la coopération entre la République du Congo et la République de l'Inde et le réseau Apollo Hospitals repose sur des axes majeurs clairement identifiés.
In this regards, the cooperation between the Republic of Congo and the Republic of India, along with Apollo Hospital Network, is based on clear identified major acts.
Premièrement, le développement de la télémédecine et de la santé numérique à travers la mise en place des plateformes de consultation spécialisées à distance, le partage d'expertise médicale et l'appui aux structures hospitalières nationales.
Firstly, the development of telemedicine and digital health through the implementation of consultation platform realizing remote services, sharing expertise, medical and support for hospital structures nationales.
Deuxièmement, le renforcement des capacités humaines par la formation et le perfectionnement des professionnels de santé congolais, notamment dans les domaines de la médecine spécialisée, de la gestion hospitalière et des technologies médicales.
Secondly, capacity building human development through training and professional development of Congolese healthcare professionals, particularly in the field of specialized medicine, of hospital management and medical technologies.
Troisièmement, l'amélioration de l'accès aux soins spécialisés permettant la prise en charge des patients nécessitant des traitements complexes en complément des capacités nationales existantes.
Thirdly, improvement access to healthcare systemized, enabling the management of patients requiring complex treatment in the complement to existing national capacities.
Quatrièmement, le développement de partenariats hospitaliers structurés favorisant le transfert de compétences, l'échange de bonnes pratiques et l'accompagnement institutionnel dans la modernisation du système de santé.
Fourthly, the development of partnership structured hospital facilitating the transfer of skills, exchange of best practice and institutional support in mobilizing healthcare system.
Enfin, le renforcement de la diplomatie sanitaire à travers un dialogue institutionnel soutenu, l'appui des représentations diplomatiques et la mobilisation de partenaires techniques et financiers autour des projets de santé à fort impact est le pilier essentiel du développement humain et de la stabilité sociale.
Finally, the strengthening of health diplomacy through a sustainable institution dialogue, the support of diplomatic representation, and the mobilization of technical and financial partners around the high-impact health project constitute the key pillar for human development and social stability.
Distingués invités, mesdames et messieurs,
distinguished guests, ladies and gentlemen,
cette coopération illustre notre engagement commun en faveur d'un système de santé plus performant, plus inclusif et plus résilient, et témoigne de notre volonté de placer la santé au cœur de nos priorités de développement et de notre action gouvernementale.
Such a cooperation illustrates our shared commitment to our more efficient, more inclusive and more resilient healthcare system. It demonstrates our commitment to placing healthcare at the heart of our development priority and our government actions.
Je forme le vœu que ce partenariat se consolide davantage et qu'il contribue de manière tangible et durable à l'amélioration de la santé et du bien-être de nos populations.
It's my health wish of strong, tangible and sustainable partnership that contribute to the improvement of healthcare and well-being of our population.
Distingués invités, mesdames et messieurs, pourquoi envisager un partenariat entre la République du Congo et la République fédérale de l'Inde intégrant les réseaux hospitaliers Apollo?
Ladies and gentlemen, why considering a partnership between the Republic of Congo and Republic of India joining the Apollo Hospital Network?
C'est tout simplement parce que nous sommes conscients que l'Inde a démontré au cours de ces dernières décennies qu'un pays peut transformer profondément son système de santé en misant sur 3 piliers innovateurs.
We are aware that India has demonstrated in recent decades that country can profoundly transform its healthcare system based on the innovation pillar.
Le capital humain, la technologie et les solutions adaptées aux contextes locaux.
Human capital, technology and solutions adapted to local contexts.
En effet, le réseau hospitalier Apollo Hospitals incarne parfaitement cette réussite, car avec son expertise en soins hautement spécialisés, en santé digitale, en télémédecine et en gestion hospitalière, Apollo constitue un partenaire stratégique pour accompagner la République du Congo dans ses ambitions.
Indeed, Apollo Hospital Network embodied the success because of its expertise in high specialized care, in digital care, medical, telemedicine, and hospital management. Apollo Hospital constitutes a strategic partner to support the Republic of Congo in carrying out its ambition.
Ainsi, ce partenariat repose sur des axes concrets.
This partnership based on a concrete principle.
Distingués invités, mesdames et messieurs, la collaboration entre la République du Congo et l'Inde via Apollo illustre parfaitement la force et la pertinence des partenariats sud-sud.
Distinguished guests, ladies and gentlemen, the collaboration between the Republic of Congo and India via Apollo perfectly illustrates the strength of relevance of South-South partnership.
Nous souhaitons que ce modèle inspire d'autres initiatives sur le continent africain et au-delà, afin de construire un réseau global de coopération efficace et équitable.
We hope that this model will inspire other institutions and African continent and beyond in order to build a global network of effective and equitable cooperation.
Je vous remercie.
Thank you.
Thank you. Thank you, sir. Now I may request Dr. Grace Hansu Dankwa, Honorable Deputy Minister of Health, Ghana, to address the gathering, please.
Good morning and namaste to everyone. Chairperson, distinguished colleagues, global health leaders, partners, ladies and gentlemen, innovation in healthcare only delivers impact when it is inclusive, well-governed, and people-centered. For Ghana, innovation is not defined by technology alone, but by how our systems are designed to deliver safe, fairer, and more resilient care for every citizen. At the heart of our health reform agenda is our free primary health care. It is a deliberate policy choice rooted in the understanding that the most effective and equitable innovation is early access to care without financial barriers. Strong primary health care reduces avoidable harm, supports prevention, and strengthens trust between communities and the health system. This vision is strongly championed by the President of the Republic of Ghana, John Dramani Mahama, whose leadership places equity, access, and social protection at the center of national development. Under his vision, free primary health care is not only a service delivery reform, it is a patient strategy ensuring that conditions are identified early, complications are avoided, and care is delivered close to where people live. Innovation must also protect those with the greatest vulnerabilities. In this regard, Ghana, through the visionary leadership of His Excellency John Dramani Mahama, has established the Ghana Medical Trust Fund. This fund reflects a clear national commitment to ensuring that financial hardship does not determine health outcomes, particularly for people living with non-communicable diseases such as cancer, cardiovascular diseases, renal conditions, and other chronic illnesses. The intention of the Ghana Medical Trust Fund is to address a critical gap in health systems across many countries. The rising burden of non-communicable diseases and the catastrophic cost often associated with their care. Through this mechanism, Ghana is advancing innovation in health financing, protecting households and ensuring dignity in access to specialized and long-term care. This is innovation that directly translates into equity, safety, and impact. Digital health is a key enabler of this agenda. Ghana is investing in digital tools to strengthen disease surveillance, epidemiology, and continuity of care. We see strong opportunities in interoperable electronic medical record system, national data dashboard, and the responsible application of AI and automation to detect risk early, support clinical decision-making, and reduce preventable errors. However, we are clear in our approach. Technology must be governed as a patient safety intervention. Innovation without governance can introduce new risk. Therefore, our focus is on data quality, interoperability, privacy, cybersecurity, and clear clinical accountability. Technology must enhance judgment and not replace it. Innovation also means investing in people. Ghana is strengthening capacity not only for doctors and nurses, but across the entire specialist workforce, including allied health professionals, lab scientists, pharmacists, biomedical engineers, infection control specialists, and others whose roles are essential in safe care. A modern health system is only as safe as the skills, protection, and confidence of its workforce. As we look ahead, Ghana believes that the future of healthcare innovation must be safe by design, inclusive by intent, and measurable in impact. We remain committed to collaboration through South-South cooperation and global partnership to share learning, build sustainable capacity, and ensure that innovation delivers what truly matters: safe care, stronger systems, healthier population. Thank you.
Thank you, Dr. Grace. May I now request Mr. Huaka Wamaliko to please address the gathering.
Hello. I'm just going to give you a very short version of what I was supposed to say. I know we're running out of time. So just a bit of background about Tonga and the Pacific countries. We're in a very big oceans, very small landmass. For example, in Tonga's case, I mentioned it yesterday, we're about half of the landmass of California. And of that, only 1% is land, 99% is ocean. So you can see some of the challenges that we actually face. We don't have, we lack human capital, so that's something we have to work with. We have the burden of NCDs. We have, as I mentioned earlier on, geographical divide and also digital divide. We're still building up our infrastructure. And one of the partners we're looking at to actually supplement and complement what we have is Apollo Hospital, which is why we're here. And I'd like to just touch on about 5 areas where we're looking to collaborate with and where we found the partnership most useful. The first one is the fact that we don't have expertise and capacity in some of the areas that we've been discussing. And so we are working towards strengthening our referral systems, including teleconsultation and so forth. Second one is telemedicine and digital health, looking at closely at what Apollo is actually doing. And also the fact that to cut some of the costs down to actually make the most of telemedicine. And the third one, the fact that we don't have the capacity or the expertise on how we can collaborate to actually build our own local capacity, whether it's through online courses or whether it's training in Tonga, or a combination of both with a train-the-trainer type of approach. The fourth one is NCD prevention and public health. Again, using AI, we can do early detection and screening initiatives. We can do more data-driven monitoring of NCD outcome. And lastly, it's about emergency. Tonga is the number 3 most vulnerable countries in the Pacific, in the whole world. We have cyclones, we have tsunami, we have volcanoes, you name it, we have it. And so we are very keen to actually look at how can we strengthen our resilience through partnership. And that's something that we like to discuss more with Apollo to see whether they can provide that additional level of support to make us a little bit more resilient, especially when we are encountering crises like the disasters and what have you. But we're also very mindful that if we invest a lot on especially the main population areas, we're probably going to have advanced healthcare there. But at the same time, it might widen the gap in terms of what we provide the rest of the population, which tend to be in a different islands, hundreds of miles away. So we have to be mindful that what we are actually doing won't widen that healthcare gap that we need to actually address. So technology will be a key part of that discussion or that partnership with Apollo to make sure that we close that gap between our islands and at the same time make sure that it's safe and secure. With that, Chair Lady, I hope I give you some more time for your other speakers. I thank you.
Now may I request Dr. Sarah, Honorable Minister of Health, South Sudan, to please address the gathering for 2 minutes.
Excellencies, distinguished delegates, ladies and gentlemen, on behalf of the government and the people of the Republic of South Sudan, I, the National Minister of Health, would like to extend our sincere appreciation and gratitude to the organizers of the 13th International Health Dialogue for convening this important and timely forum. We are especially thankful to the government of India and our hosts here in Hyderabad for the warm hospitality and excellent organization that made this dialogue both productive and memorable. We truly felt welcome and supported throughout our participation. Excellencies, distinguished delegates, ladies and gentlemen, over these past 2 days, South Sudan has benefited greatly from the rich discussions, shared experience, and practical insights exchanged during this dialogue. The conversations on health system, resilience, patient safety, quality of care, and innovation in fragile and transitional contexts have been particularly relevant to our national priorities. We leave this forum better informed, encouraged, and inspired. We are particularly grateful for the opportunity to visit Apollo Hospital here in Hyderabad. This visit provided invaluable practical exposure to high-quality patient-centered care, a strong clinical governance, and the effective use of technology and innovation in service delivery. The experience offered concrete lessons that will inform our efforts to strengthen referral systems, patient safety practices, and quality improvement initiatives in South Sudan. In this regard, allow me to extend a special appreciation to Dr. Sangeeta Reddy and the leadership of Apollo Hospitals for the warm receptions, openness, and generosity in sharing experience and knowledge. We are inspired by Apollo's commitment to excellence, innovation, and patient-centered care, and we look forward to continued engagement and learning. This dialogue has reaffirmed the importance of global solidarity and partnerships for countries like South Sudan facing protracted humanitarian challenges, climate shocks, displacement, and disease outbreaks. Such platforms are not merely academic, they are essential for learning, cooperation, and progress. The knowledge we have gained here will directly support our ongoing health sector transformation. I would also like to commend all the speakers, panelists, technical experts, and participants for their valuable contributions. Your openness and commitment to shared learning have enriched this dialogue and strengthened our collective resolve. Excellencies, distinguished delegates, ladies and gentlemen, as we conclude, allow me to reaffirm South Sudan's commitment to continued collaboration and partnership with the international health community. Together, we can translate dialogue into action and ensure that no country and no patient is left behind. Once again, on behalf of the Republic of South Sudan, I say thank you. I wish all who came from far a safe travel back home. Thank you so much.
Thank you, Dr. Sarah. Now, we move quickly to our felicitation ceremony. May I request Sangeeta ma'am and Shobna ma'am to felicitate Dr. Jonathan Perlin here on the stage.
We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for
Ladies and gentlemen, Dr. Jonathan Perlin, President and CEO, Joint Commission. And now we are felicitating Honorable International Health Ministers, Professor Jean Rosaire Ibarra, Dr. Grace, Mr. Huaka Wemeliku, and Dr. Sarah. We have honorable ministers joining from the Republic of Congo, from Ghana, from Tonga, and South Sudan. And now, one important felicitation. Now we are going to felicitate Mr. Russ Brenzel, Shine CEO.
That is changing people's lives. We are here for patient safety. We are here for quality.
Sure.
We are here for innovation. We are here to make a difference.
Ladies and gentlemen, we now move to a moment of great pride and honor as we felicitate distinguished doctors whose dedication and contributions have made a lasting impact on healthcare. May I please request Sri Konda Vishweshwar Reddy ji to felicitate our doctors. Dr. P. Vijay Anand Reddy, Padma Shri awardee, honored for his exceptional contribution to cancer care and oncology in India. May I request Dr. P. Anand Vijay Anand Reddy to kindly come forward for the felicitation.
We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety.
We'd now like to felicitate Dr. Oun Issam Al-Shea, Director of Health, Ministry of Interior Affairs, Iraq. May I request Dr. Al-Shea to please come forward for the felicitation.
We are the seekers and the finders. We are the thinkers and the doers.
Dr. Al-Shea is also a member of the International Society for Prosthetics and Orthosis, member of Iraqi League for Bone and Joints, head of Iraqi Medical Rehabilitation, SIGS.
We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives.
May I now invite our guest of honor, Shri Konda Vishweshwar Reddy ji, here to the stage to address the gathering. Ladies and gentlemen, Shri Konda Vishweshwar Reddy ji, Honorable Member of Parliament.
Distinguished guests, policy makers from across the world, eminent doctors, industry leaders, nurses, engineers, and students who are present. A very good morning to all of you. Tomorrow is the most important day, annual day, in the Parliament of India. Our finance minister is going to present the budget tomorrow. And as a precursor, 2 days ago, our finance minister presented the Economic Survey of India. This survey places artificial intelligence at the center of economic strategy of India. The emphasis is on deployment of artificial intelligence in real-world problems like healthcare, agriculture, and education. It is not just a business opportunity for our IT industry. Artificial intelligence is a strategic priority for Government of India. India is second globally in AI skill penetration already. A phased roadmap from early adopters to global innovators is already made and is being implemented. The push for artificial intelligence, and that too in healthcare, is from the top, from our Prime Minister Modi ji, along with his flagship program of Ayushman Bharat. Ayushman in Sanskrit means a healthy and long life, but he wishes, as per our core values, an Ayushman Sansar, which is a long and healthy life for the entire world. The IT minister recently at the World Economic Forum laid out the plan for India, and we already raised 70 billion, not raised, implemented a $70 billion plan for artificial intelligence infrastructure. And the government is already on the phase 2 of AI Mission India, India AI 2.0. But what is really exciting is what Indian biotech companies, Indian pharma companies, and Indian healthcare leaders have contributed to the world in collaboration, which is providing cheap and high-quality vaccines, high-quality drugs at a very inexpensive rate, and high-quality healthcare to the world. What the Indian pharma, healthcare, and biotech companies have done and proven, the Indian AI products, services, and companies are going to do the same and help the world along with helping ourselves. As data gets transformed into information, knowledge, and wisdom, and that is traditionally done through expertise of our highly qualified doctors, AI is going to do exactly the same thing. And what is exciting is this knowledge, wisdom, and expertise is going to get institutionalized. In India, it's already being done. And once it's institutionalized, it will reach the poorest and the most remotest corners of India and the world. India, as we speak today, has the world's largest public digital infrastructure. The physical infrastructure of publicly owned communication networks, whether it's wired or fiber or wireless, a publicly owned network, and a digital ID, identification system called the Aadhaar, and the world's largest digital payment system. As we speak today, every day more than 750 million digital payment transactions are happening in India. So the AI and the Ayushman Bharat vision on top of the public infrastructure. AI is dependent on data, quality of data, and data which is finely granular, data which is highly local as well as globally relevant, and data which is unbiased. And I'm sure this conference will be a great success because I see not only eminent doctors and healthcare professionals, but I also see engineers here. I'm especially thankful to the organizers for inviting me here and wishing you all Ayush. Jai Hind. Thank you.
Thank you, sir. I would also like to acknowledge the presence of dignitaries today joining with us. His Excellency, Mr. Percy P. Chanda, High Commissioner of the Republic of Zambia. His Excellency, Mr. Carlito Nunes, Ambassador of the Democratic Republic of Timor. Dr. Paul, Chairman of the Papua New Guinea Medical Board, Papua New Guinea. Major General Salah, Director of Medical Affairs, Ministers of Interior. On behalf of the Honorable Minister of Interior. Dr. Yusuf Mohammed, Advisor to the Minister, Ministry of Public Health and Prevention, Republic of Chad. With this, I would hand over the forum to Mr. Gaurav Rolia, Senior Vice President, Operations and Patient Experience, for his heartfelt sign-off.
Thank you. Respected dignitaries on the dais, distinguished speakers, colleagues, ladies and gentlemen. Today, we have beacons of excellence in healthcare on the dais from people who actually are innovators and visionaries, who create processes and systems, who are the policy makers and actual healers who execute and deliver care on the ground. It also includes people who actually evaluate the whole process of care delivery. With that, I would like to thank everyone for this, for participating and being a part of this conference and the larger dialogue. Also the organizing committee, partners, volunteers, and participants for making this conference very meaningful and memorable. Thank you so much.
May I request everybody to come forward for the photograph? Thank you. Thank you to all the dignitaries.
We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety.
Ladies and gentlemen, this
we
is
are here
IPSC
for
anthem getting played for all of you.
For innovation, we are here to make a difference.
Ladies and gentlemen, we now move to a very special session that promises to be insightful, candid, and unscripted. A conversation that goes beyond the ordinary and explores perspectives from leaders shaping healthcare and patient safety. It's my privilege to introduce the session Unscripted with one of India's most influential voices in journalism, Mr. Arnab Goswami, Editor-in-Chief, Republic India Network.
Joining him on the stage today is our distinguished guest, Ms. Shobhana Kamineni, Executive Chairperson, Apollo Health Co. Limited and Apollo Pharmacies Limited, a leader whose vision, dedication and expertise continue to inspire excellence in healthcare. So, without further ado, may I invite Mr. Arnab Goswami along with Ms. Shobhana to the stage to begin this exciting session. Sir and ma'am, may we please have you join us on the stage. Ladies and gentlemen, please give a very warm welcome to our panel and the host.
We are not alone in this mission.
Hello everyone, it's good to see you in such a big hall. Shobhana ji, this almost looks like it looks bigger than the Parliament of India, perhaps, in size. The problem is that I've been told that the subject for the session is unscripted, which is what I do every night. And I kept asking the organizers, what is my time limit? Shobhana ji, they said there is no time limit. I said, this is the most dangerous thing you can do with me. Give me a mic and no time limit. And I can continue on. And they'll have to ask us to stop. But thank you very much for having us over here. Thank you for inviting me. Thank you to the wonderful and very warm Apollo family for inviting me here today. And I want to begin by saying it's a great honor to be part of your beautiful conference and to have an opportunity to talk about matters of health with you. But if I may start by saying something on a more personal note, if you allow me. I am deeply inspired by Apollo Chairman Pratap Reddy sir. I feel he is one of the greatest, perhaps the greatest entrepreneur in the country today. And I feel what he has done for the country and for our healthcare sector is remarkable. And I would like to begin by, on stage, paying my deepest regards to him. I hope to see him soon again. And thank you for inviting me. Thank you very much. Thank you.
Thank you. Thank you, Arnab. And truly, this is the health parliament of not just the country, but probably the larger part of Asia and all the delegates that have come here. So we're so honored. I think that Sangeeta and the team here have put in, they've done this for 15 years.
Wow.
And each time it's bigger, it's better. And more than anything else, everybody goes back having deeply learned and with a renewed commitment to do and shift the needle in healthcare. And this is the audience that can do it. So thank you for being here. No. And I guarantee you that, or maybe the audience is not going to be like your nightly programs, because I think both of us, you know so much about healthcare, and both of us are so deeply entrenched with the passion of it. So I think this will be more of a collective joy.
Yes. No, I don't know too much about anything. I'm a jack of all trades. But I hope to learn. So at the very start, I just like to start with a broad question in this unscripted conversation. I feel as a country, we are at an inflection point now, Shobhana ji. We're in a moment of change. If you look at the world around us, there is whether trade, technology, politics, geopolitics, there is a churn all around us. And when there is a period of churn, what we call in Hindi manthan, one can be sure that the past will never be close to the future, and the future may be such that you may not be able to identify the past. And it is upon us to make things better or to make things worse. I believe we cannot be a Vikasit Bharat unless we are a healthy Bharat. And I feel very concerned when I see reports that we are moving forward economically in terms of our place in society and everything, but we are not taking care of our health. I saw a report, I hope it's not true. I hope it's not true, which said that among the individuals born between 2007 and 2015, I don't know whether it was part of your report or something else I read, that there are millions of people who will have gastric cancer at some point of time in our lives. And that is an avoidable problem. And a lot of things have to therefore do with lifestyle, the way we are. And that's why the entire philosophy of prevention being better than cure is so important. My first question to you is, and I want your broad perspective because you live and breathe this every day. We think technology will save our health. We think that wearing these phones, which tell us the number of steps, tells you your pulse rate, having technology, AI. We read about technologies which say there is stem cell research which will change things. I even read something which is true apparently, that there is a Japanese technology that will help you grow your teeth back again. So we think that technology is going to save us. It's going to grow our teeth, build back our lungs, freshen our intestines, make us lose our fat and make us healthy. I even saw a gym where you don't have to move, but the gym does the training for you. So we depend on the press of a button for our health. Is that a good thing? Can technology save us? Can technology make us a healthy Vikasit Bharat? Just this broad stroke question to start our conversation, please. Thank you.
One is, I think that social media is so pervasive that all of us are engaged to read this every day. And I think health is the most searched, which is why ChatGPT wants to do health and Gemini wants to do health. Everybody wants to be in this space because the good part of that is, I think then there are more people taking ownership. This is a thing that has to be part of your everyday. Just like you look at your bank account, you have to look at your health account. And I think that many of us think about it too late. So the very fact that we're using, that there's so much out there every day, and has so much access, because 90% of Indians, especially the young Indians, are digitally savvy. So the more Indians that are actually thinking about health every day, those are the needle will move. So if AI is doing that, so this is one aspect of public perception. And moving back, I agree with you, Arnab. We are a nation in somewhat of distress, because if you look at it, you know that average Indian is less healthy than a decade less healthy than the average person in a developed country, say Singapore, our neighbor. And this is because environmentally also we don't do so good. The way that, so from not just pollution, but the food we eat, the food that's cultivated for us, all these are factors that, you know, here we were a country that actually knew how to use whatever we had to, and the Ayurveda, all our science and the way that we grew to be able to lead long and healthy lives. And now what's happened is that we have all these layers, which is the most fantastic thing, that India has used that, but we've also accelerated, because I'm here and I belong to a family that really believes that medicine and medical science can and will make a difference. But it will only make a difference, you know, we don't want to build more hospitals. We really want to be able to keep people from coming to hospitals, and that is Viksit Bharat. When you can use a triad, use the platforms, then after that, let people start engaging. So platforms which will tell you air pollution not good, or this is the thing of a pandemic, or something like the Nipah virus that's going to come out, and get people, activated, the government activated into it. Let the government start working on 10% more of their money being put into prevention. And this is the next part of it, that we will finally move into a program where Indians themselves, every Indian, you will use your device, you'll use your phone, you will use the ability to be able to contact a doctor 24/7, and use all these with you, and the fact that we do get medicines at an affordable price. So how do we make ourselves and lift ourselves? Because if India is supposed to be Viksit Bharat, we can't afford to lose the 30 days we are today for health leave. We're less productive. And I think that when this moves into society, that we can take charge by ourselves. The government has to make sure that a wide variety, like Ayushman Bharat, the largest health insurance program in the world, these are the initiatives that the government will do. And finally, it comes on the burden of all of you sitting in this room. And it's not a small burden. It's so many of you and everyone you touch that every morning when you come to work, you're not just an economic activity, you're not just an industry that keeps this country moving. But what you do is every time you generate value, it's not just economic value, you're saving a life. And that's the real beauty of what my father has taught us and why we're so passionate about this field.
Well, thank you. From finding out to acting, Pratap Reddy sir talks about heal in India, heal by India, and heal from India. And I'm so happy that you spoke about traditional practices. Because our traditional practices, our traditional way of life have told us that very important aspect of balance. Lead a balanced life. Have a balanced diet. Have balance in your mind. And be calm in your thought. Then you will be more effective in action. That is what our traditional systems have taught us. And I think don't you think we actually underplay our traditional knowledge systems? While looking upon us, while looking at health, is it important to go back a little bit to our traditional knowledge systems and what they teach us in terms of prevention as well, Shobhanaji?
I truly believe that. And I think that's why Apollo made an investment 5 years ago in buying one of the largest Ayurvedic hospital chains in the country, Ayurved. So now we're trying to put them in our hospitals. Medanta has one. So it's not just in Apollo that is looking at it, but many doctors, hospitals are thinking, how can we scientifically, now the problem is that everyone here cannot do things, what they believe in, what they have an intuition or they have a belief system in. This audience actually needs science and you need proof. So I think the onus is upon us to provide more proof to the world that we can move the needle through a more holistic system.
Yeah.
So I'm hoping that with Ayurved in an Apollo hospital, maybe that'll move the needle and it'll be a very unique way of discovery.
We have the information. Suppose we have the information, we have the technology, we have all these AI tools, I'm told we have self-test kits, connected devices, AI-driven risk prediction. And yet, there is a strange thing. People are still becoming more unhealthy. So, how does one explain that? Ms. Kamineni, if we accept that the next frontier of healthcare is prevention rather than treatment, which is your guiding principle, prevention, not treatment, then technology becomes central. We have all these connected devices, we have AI tools, and yet we take more time after detecting the problem before symptoms appear. What I'm trying to say is that you have we have the information, but we don't act. We have the ability to diagnose, but we get anxious about the diagnosis rather than we treat it. There have been studies which have found out that people tend to self-diagnose their problems because they are playing with several tools. So people have the awareness, they have the tools, and yet they don't act. They try and, at a personal level, I think people put their personal health last and they make it a bit of a virtue in society that we have so many responsibilities that we don't take care of our health. Now, isn't that a huge contradiction? We have all these digital platforms, all the technology, and yet people aren't acting on the information that they have. If that is the case, how will we make health information, health awareness? Awareness does not mean acting. We assume that people will be aware of their problem or an impending problem. For example, how many people are borderline diabetic, for example? How many people would be borderline diabetic and how many people would act on it till it doesn't become a full-blown case?
So, quick answer to yours. There is a large cohort. There are about 200 million pre-diabetics in the country that don't know. But if you really ask me the answer to your question, and I'm answering on behalf of this audience, that we live healthcare every day. And I think among the younger generation, they really have started engaging with or whatever you spoke about the wearables, about using, asking AI models for health all the time. And they're starting to get more engaged. On the flip side, it's actually a bit of a pain for a lot of doctors because when they come in, these guys say, oh, but ChatGPT said this, but you didn't say this, or you didn't.
Yeah, we're all half doctors.
So this is another side of the problem that we face here. But what I'm trying to say is that generationally, this whole country is going to lift, and I don't like generalizing. The statements, because I can say that there's certain cohorts that because of the wearables, because of AI, they have become healthy and they've taken health into their own hands. And the more that we can do it, because there are studies that have shown this, and that's why there are more and more programs to engage that have come into, that you see. We have diabetic awareness programs. If you show me a person who has, who is pre-diabetic, there's so many lifestyle programs that we can actually work with through AI and through engagement to be able to change that and reverse it, and everybody is seeing it here. How many take it? I think what's happening is I'm seeing that in the urban 5 cities, the older people are actually starting to engage more. The middle class, younger, digitally savvy, who look after. I was looking at this data because I do 1 million prescriptions a day. So we know some of this stuff, the data that comes out. And what we're seeing is that in these top 5 metros, there are people that are, pushing the thing of using insulin injections by almost 3 to 4 years than they were 10 years ago. So all this is a good thing because they've started engaging. But none of this is going to happen fast. These are all generational life changes. Almost like people ask me as a woman, because Women's Day is like 2 months away, then they'll ask, when will women equal men? These are all generational things. It's the same thing with health. We're seeing that in pockets, more and more people, we're seeing that it's becoming more ubiquitous. And I think that the way that we engage is good. On the other side, I can't leave it because I never want to say that AI will leave people out of treatment. And I think governments are starting to use it. They're starting to use it to bring ASHA workers, give them AI, enable them so that people can actually, in a village where it's very tough to get high-end doctors, so that they can actually talk, seamlessly engage. So all this will require time, but I think we'll get better at it. We'll start seeing less of your stage 4 gastric cancers coming up.
Yeah, I really hope so. I really hope so. We have the budget tomorrow. And the economic survey, I don't know, did you get a chance to see the economic survey? I was seeing the 25-26 economic survey. Very, very important from the point of view of this audience. I want to share with it. It actually highlighted that rising consumption of ultra-processed foods is a huge problem in our country. So makes me wonder whether affluence or slight affluence is making people more unhealthy. You know, and it also highlights, the economic survey, that industrial products which are high, very high in fat, in sugar, salt, extremely low in whole wheat content, are aggressively marketed to children. That's really worrying. Really, really, really worrying. And I spoke to some people. I can tell you the inside story. I spoke to somebody who heads a parliamentary steering committee, and he said, the person called me recently and said, do you know that we are feeding poison to our children? He said some of the stuff being sold is to children is so bad, it should have big sort of markers like you put on cigarettes on them, and yet that is the stuff that is being given to children in the morning for breakfast as food supplements, and it's being told it's going to make your child stronger, taller, whereas the fact is it is a high concentrate of fat, sugar and salt in the morning. You know, so it so worried me. I saw this in the economic survey, and it says that individual behavior, the economic survey says individual behavior alone is insufficient. We need urgent coordinated system across. We need to make a policy. We need to put preventive safeguards. We are today, Shobnaji, aware of the problem that we are facing. My concern is not so much about our generation, but about the younger generation, about the children and those who we hope will be the leaders of Viksit Bharat. Don't you think we need a comprehensive policy very soon, so that this vulnerable category is saved? An awareness campaign of a point where, as you rightly said, and I commend you, you are probably the only people running a large healthcare company, and God give you more strength, may you become the largest healthcare company in the country, the world and everywhere. But this is something you're going to have to address. You're going to have to play a very important role in saying, see, to the government, you have identified the problem, now stop it. Don't feed our children cigarettes every morning. I call all of these sugary stuff cigarettes. And it's not the problem of the parents. The parents don't know. These are people who will advertise their food as fruit drinks, whereas it is only sucrose or glucose in the morning. Isn't that very bad? Don't you agree with me? Do you agree with me? Raise your hands up if you agree with me. There you are, Shobnaji, see, they're all agreeing with me. So we need to do something about it. You're going to have to do something about it.
And I really want to tell you,
yes,
2 stories on this. Quick one. This state, actually there's a doctor, Dr. Shivaranjani, I'm sure you all know her, that she lobbied for 8 years. It took her 8 years to get ORS correctly labeled because people were selling sugary drinks. And we were the first. I can tell you, 3 months ago, we've lost almost 100 crores in terms of, because we had it on our shelves because doctors would prescribe it. But now everyone has become so much more careful about saying that what is ORS? Let's give it to kids. Let's give it to grown-ups without that sugar. So these are changes that take place. Cerelac, all of you know how Nestle's was putting more sugar, about 7% more sugar in Indian Cerelac to make it taste better compared to others. And who objected? It's all of you, it's the public, it's moms. They stopped buying Cerelac. So those guys, so I think the social media, so we are doing a lot. I think that most moms, I know as a grandmom, none of my grandchildren were even allowed to touch sugar till they were 2 years old. And the studies show that such kids actually push diabetes away. So I think that And I don't want the educated moms, but how do we get the message to uneducated moms? And I really think what you're saying is right. And for that, how do you make it holistic? I just want to give a very old historical story. I don't know if anybody knew, but today, why are we not iodine deficit in India? That's because Indira Gandhi gave a diktat and said every salt company had to add iodine. And that's when you change the needle for the whole country, the rich, the poor, everybody. And I think that's what something we should be doing together. So while I agree labeling is important, and moms will see it and they will realize, and so will adults and everybody, but it's also that we can do programs like this to increase more protein in their food, good protein. So we're on the same page here, especially this audience, because they are working to make sure this happens.
Well, it's amazing. And this audience is a large audience. And before this audience, I also want to say one thing that, Shobna ji, I think that what makes you different is that for you, healthcare is not just a business. You're doing it from the heart. The problem is that, and everybody looks at everything as a business. I run a network, Shobna ji, and I say for me, news is not a business. Yes, I do business to keep my news organization going. Similarly, you do business to keep your healthcare effort going. There is a difference always, and I want this audience to remember, between professionals committed to a sector and to service, and others who come in with the only purpose of investment and making money. And that's always going to make you different and going to make Chairman's vision stand out for years. I just wanted to say this.
Very good message.
I hope this message goes home. Am I making any sense? Are you people bored of me? Just tell me to go away. I'll go away, don't worry. But when I go away, I promise you one thing, Shobna ji, that if I meet Nirmala Sitharaman for a post-budget interview, and when I'm doing my budget broadcast tomorrow, I commit before you that I shall make healthcare into at least 25% of the conversation tomorrow on my channel and the network. And I'm here today only because I do love this group, I love Chairman, and I love your vision. And I believe there need to be more people who are committed to a sector and service rather than just for money and investment. That will make you different. My concern is, however, on one front. I always say one thing, that never get too carried away with life if there are two places that make you completely realize that everybody is one. There are two places. You know what those two places are, Shobna ji?
I know what one of them is.
One, I say, is the ICU.
Yeah.
Because everyone's equal in an ICU. Everyone's equal. And I spent so much time, my family members, when they were in the ICU, I looked around, there were rich people, poor people, people with life backgrounds. I saw helplessness and hope. And for me, ICU was a very place which made you forget all barriers and hierarchy. The other place I won't tell you to go to is jail, ma'am. You go to jail, everyone's equal. But since I'm one of the only people who have been to both places, I can tell you that, you know, these are equalizing experiences. That's when you begin to appreciate a doctor, a nurse, a healthcare worker. And
or the law.
Huh?
Or keeping the law.
All?
Not breaking the law.
Or not,
So
no, I
you
didn't
wouldn't
break the
want to
law.
be-
Someone else broke the law and put me in
Of
there.
course, not you, but I'm just saying.
I was
that
just
in
a
that
victim.
place, yeah.
But even in jail, people were watching my channel, so I was fine, I was happy with it. But my concern is on healthcare professionals. My love and admiration is for healthcare professionals. I saw that spirit of service during COVID. I saw people who risked themselves. Some didn't go home. And I have great admiration for the Reserve Bank of India for the work it did. I once met Shaktikant Das when he was governor. He said, we all remained within RBI to keep the economic system going. Our people did not go home. Similarly in hospitals, it was amazing. I feel they are the most undervalued sometimes in our society. So I have a lot of time for it. And I wanted to ask you this, please. Thank you. I mean it from my heart. I'm not trying to be popular.
No, thank you
I
for
do mean
not
it.
forgetting. What's happened is that they did appreciate us a lot, but I think people forget.
People forget.
And they don't
People
want
forget.
unhappy memories. But I can
No.
tell you that families, that they're young nurses, they were like in their early 20s, and their families were scared for their life and said, come home.
Yeah.
And they refused to leave.
Wow.
So that
Amazing.
one of the lovely stories.
Amazing. So I wanted to ask you, do we have enough people? Straight question, and I keep, whenever I meet a big doctor, a big owner of a hospital, I know quite a few. You know, I know some great doctors. Dr. Ramakant Panda treated my father, Dr. Devi Shetty. Whenever I meet them, I say that, do we have enough doctors? Devi Shetty talks about it a lot. Are we not going to face an acute shortage of healthcare professionals? Plus, a lot of our talent goes outside the country. One of the greatest contributions of Pratap Reddy sir has been bringing the best of professionals into our country. I think we will always say thank you to him for that. But are we not going to face an uneven shortage, uneven distribution of healthcare professionals, particularly in rural and underserved parts of our country? And I'm asking you this because Niti Aayog has echoed this concern. Niti Aayog has said that India's health workforce density is much below the WHO benchmark of 4.45 doctors, nurses and midwives per 1,000 population needed to deliver basic essential health services. In that context, my question to you, Shobna ji, is, are we trying to solve a 21st or 22nd century healthcare problem or challenge with the 20th century manpower model? We can't do that. This gap should be bridged quickly if we are to become Viksit Bharat. Are we thinking as much on it? And how can we do it without compromising the ethics or quality of healthcare? Please, ma'am.
I think you've got lots of your answers in your questions. And so maybe I can just layer your perspective with what this group would say. And I think at last count, Apollo had sent almost 250,000 nurses across the world. So they train here, they go, and what they do is then they send money back to their parents here, and it becomes a whole economic cycle, and that's quite beautiful. More and more it's going to become necessary, because one thing that AI will never solve for is that human touch. So as the world's population declines, yesterday I heard a figure, and I can tell you that it is live in countries like Japan and many other countries that have such a negative growth rate. But if you look at it, by 2076, China is going to have only 400 million people with this. India is going to be 1.5 billion. And I think the rest of the world is going to have to look. So whatever India is looking at, it's not just how we solve for ourselves, but we will have to be the healthcare providers for the world in almost 2 generations. So this is very, very serious. I appreciate what the government is doing, because we've ramped up the number of medical colleges, and this is something, nursing colleges, every one of these. I do think that this is a sector that will always, at least for the next 100 years, and believe me, being in business, I can't predict more than 5 years for my own business. But I think for healthcare, for the next 100 years, India is going to have to ramp up and provide great quality jobs, not just for this country, but for the rest of the world. So I think it's a huge opportunity. Now, how will we do it better? Fortunately, more and more companies and everyone is getting into the act of how we can train better, how we can equip better, and if you really look at it, make the decision making. So today when they talk about that AI will make, that your breast cancer scan, Gemini or DeepMind can do it much better than a radiologist. That's fine. It's so important, and it will happen across. And the way that we use robotics today, 80% of our surgeries are robotics. Robotics is not great for a fantastic surgeon, but for a beginner average surgeon, it takes them 2 months, and they get that world-class expertise. So we're using technology to raise everybody's level. And I know this room, actually this conference, for the last 10 years, most of you have spoken about it. So I'm preaching to the choir. But what I feel is that we're really at an inflection point of a way bigger opportunity. And I think we have to see it like that to be able to give people real models how using technology, we've only become better, we've only been able to scale, and how we can make it for everybody in the country. Our doctors in Chennai, he told me, he said, I'm very soon, because again, 5G in India removes the latency. He can be in Chennai. He can have a junior surgeon in any hospital in a district, and he can perform a complex surgery. So I think these are the things that will bridge the gap model. And so this is, healthcare is truly, I can tell you, we are all evangelists for technology. We're the first people that embrace change. And we don't resist it. That's the good thing about all of us here. We just love it. We know that it'll make us better, and there's enough opportunity for everybody in this room. Tell me, do any of you fear for your jobs, or that you're going to get less work? Huh? Show of hands. Do you really think that AI is going to take your jobs with this?
No.
Okay, not many hands up, but
Yeah.
it's okay. I know it for a fact. As a job provider, we'll keep on doing more.
Yeah, absolutely. I'll wrap up with a couple of points here. See, I first of all, on this technology point, I agree with you. There was this chatbot launched in China by the Ant Group. It's called Ant Afu. And it quickly reached 30 million users within 1 month. But more than half of those people were living in smaller cities. So I think that it tells you that AI can help in access, in reach, and in connectivity. Yeah, what's that?
This is my dad's face.
Yeah.
So Ask Apollo.
Ask Apollo.
Is our chatbot. So you can ask it. It's got the expertise
Ask
of
Apollo.
all of Apollo for almost 20 years of what everyone in Apollo has been doing on data. And it is, we use the LLMs, the best LLMs in the world, and make it in using our data, layer our data.
Oh, wow.
Ask a question, please.
Oh, wonderful. That's what I'm going to log in on that. I'm going to check it out. Thank you very much. Thank you very much. Now, there was a study which was done by Lancet Commission comprising 30 global Indian and health experts from institutions including Harvard, Johns Hopkins, Ashoka University, our own IIM Bangalore. It concluded that India has a healthcare crisis which stems from systemic design flaws rather than capacity shortages. I keep coming back to that problem because it says that we have a problem in terms of our current insurance-led, fragmented and episodic care model, which results in inefficiencies, inequities, suboptimal outcomes for preventive and chronic issues which could be solved, and poor coordination between providers, payers and patients, which means somewhere our population has kept healthcare in the back burner. Somebody needs to come and make the population put healthcare in front. It is because of this problem of prioritizing healthcare second, third or last that we have a system where it is insurance-led and we look upon healthcare as a crisis in our lives rather than an inevitable outcome of the process of living for which we have to be prepared and our families have to be prepared for 24/7. So healthcare is like a challenge. Even if you see the advertisements, somebody has a heart attack suddenly, somebody has a stroke suddenly. Have you ever seen these insurance ads? They are aimed at psyching you about the possibility of something going terribly wrong rather than making it a part of your life. So my question to you was that we have the evidence. Don't you think, again, we need some concrete reforms? And I'm saying this because I think we need to emphasize it right now, which must make this fragmented insurance-led model change into a more integrated, publicly anchored, stable healthcare system with universal health coverage, chronic disease burden reduction, constant care, preventive care, rather than episodic, crisis-driven, and insurance-led care. Can we change the model on its head? Because now the world's experts are saying, see, you have a problem now. You do something about it. But now someone's going to take a lead in that. Who's that going to be? The government, the sector, or others?
First, a disclaimer. I did not even know Arnav is going to ask me this question with this. But
was it on your mind, this thought?
Well, I ran Apollo Munich for 11 years. Yeah. So I ran an insurance company. So knowing that in the next avatar, just before COVID, when we started Apollo 247 and that we started thinking about how using all the knowledge we have about somebody, how can we make it, how can we prevent them from an event from happening and use that as the fundamental, this thing that they come in to a program. So first of all, India will do many models. We're not fully in crisis. I think that there's only a 20% this thing of health insurance. There's only 20% of our people who are insured here. And universal health coverage, yes, Ayushman Bharat makes it good, but it has its own issues, and I don't want to get into that. But if you really look at it, I think that the data that we have today, and this is what we're working on, that we can go to a person and they say, see, for me the worry is that if you're diabetic or you're pre-diabetic and a lot of people lie to the insurers. So, that's where the trust breaks. So we have to bring back trust and say that actually, a guy who's a diabetic and looks after his health better and takes the medication on time is in better shape than me. And there are studies that prove it. So we have to be able to identify and help them and use those models. And that's where technology will come in. It's small, but we're making a beginning. And we're not a system as much in the crisis as some of the people who wrote the report who are America, they're completely broken. But the good thing is that we're starting out with this industry is just growing. Health insurance is not more than 15 years old in this country. And it'll go through these ups and downs and challenges and make it happen. And you all know, what was Apollo 10 years, even 5 years ago? 5 years ago, 30% of the patients coming in would be insured. Today it's 65%. So now when it's materially important, hospitals have started actually engaging with insurance companies, unheard of when I was running Apollo Munich. So now when the system is starting to they're engaging, now it's a bit adversarial, but slowly it'll become together, what can we do? And that's when good change happens. And we have an opportunity, and this is our responsibility as healthcare workers, that we have to make sure that it doesn't become as fractured as other parts of the world that we've seen.
Last question, ma'am. Every year I start, personal question. Can I ask a personal question? Should I ask a medical question? I don't know medical question. I'm a half doctor. I'll ask a personal question. Every year, Shobna ji, I start on the 31st, I say, this year I will have a fresh start. So every year I give myself a health resolution and I write it down in my diary. Only physical health, I don't think I have mental health problems. They must all be thinking he has a mental health problem which he shows every night on TV. That's all right. I have a mental health problem that I won't discuss on stage. On the 1st, I write my health target. By Republic Day, I forget it. Then on Independence Day, I start again. And after Diwali, I start writing it and I have a fresh resolution next year. This year, when I went to interview chairman in the Apollo Hospital, I was very scared. I took the side entrance because I thought the doctors will catch me if I enter from the main part and take me to different departments to do your famous health checkup. If I were to enter into any of the Apollo hospitals and if your best doctors are in one room, and this question is generic, whether it's Arnab or any one of them, what are the two questions which they would ask anyone, any person, when they enter a room? What are the two questions a doctor or medical experts will ask a person when they enter a room to find out about their backdrop? Because these questions are revealing. And what are the two pieces of advice they will give you regardless, without going through a checkup? I'm saying an individual enters the door, he's asked two questions. An individual leaves the room, he will be given two pieces of advice which will help him. What do you think those will be?
If it's only two, it's tough, but I'm sure you'll all agree with me, it's stress and sleep.
Stress and sleep.
They'll ask you, because I really think if a person can get, and I remember the years that I was CII president and sleeping 4 hours a day and thinking it's okay, it's not okay. It really took my health down. And today I sleep 7 hours without any sleep aid. And I think that this has really changed the longevity and this thing. If sleep to me is important. And I think that generically, I mean, everyone's stress level has increased from what, everywhere in the world. You know, so this stress, the world is at a heightened stress level. So I think these are, if you give me only two choices, I have a few sins that I would talk about, but two choices, it would be stress and sleep.
Stress and sleep, yeah. And two pieces of advice when I'm going out of the room. Stress and sleep again.
Gratitude and belief that I'm so happy I'm an Indian at this time. I know that we have all this opportunity to do better. Wow. So, and the fact that I'm a healthcare worker, it makes me, I think it helps my sleep and it helps my sanity, because I know, you know, humans are wired to actually to give. And I think this is we are in a sector that actually does that.
Yeah. Ma'am, I want to wrap up by saying a big thank you to you and everyone in the hall for going through this and hearing us. You know, personally for me, I think that we are blessed to be in this country at this time in the way that we are. And I think there is so much that we can give to Bharat, to India at this time. And we believe, I hope you come to our campus sometime, we don't say news first, we say nation first. Yes. And I think nation first is our philosophy. And we aspire in Republic 2026 on August 15th, we are going to launch a global news brand, Republic Global, to give stiff competition to the BBCs and CNNs of the world from the soil of India, from our soil, with our people, our mindset, our technology. And my wish and prayer is that the visionary work that you and your wonderful group have done in India goes across the world and you make us proud in all parts of the world. I thank you very much, Shobhana ji, to you and to all of you. Thank you very much. Thank you.
Thank you.
Wow, that was thought-provoking, intense, and incredibly illuminating. Thank you, Ms. Kaminini, for your visionary leadership, and Mr. Goswami for ensuring this dialogue was candid and unscripted as promised. So we close this compelling session and move on to our next session.
We now move to an important part of our conference, the panel discussion. Our next session, Rethinking Healthcare Coverage Through the Lens of Value and Viability, convenes distinguished experts and thought leaders to explore how healthcare coverage can be redesigned to balance clinical value. To guide and lead today's panel discussion, we are privileged to have with us our session chair, Dr. Nandini Ali, Chief Marketing Officer, Apollo Hospitals. Ma'am, may I please request you to join the stage? Dr. Nandini leads Apollo's marketing vision, overseeing brand strategy, corporate marketing, digital transformation, institutional business support, and customer relationship management. Welcome, ma'am. Please join me in welcoming our esteemed panelist, Mr. Amitabh Jain, Chief Operating Officer, Star Health. Dr. Rohini Sridhar, Chief of Medical Services, Senior Vice President, Apollo Hospitals. Dr. Sridhar, Head Medical Services, Dr. Reddy's. I welcome you all. I now hand over the forum to our esteemed session chair to lead this discussion. Over to you, ma'am.
We are here for patient safety. We are here for quality care. We are here for...
Does this? Good afternoon, everyone. After the power-packed session that we all witnessed with Shobna ma'am and Mr. Arnab, I think we'll have to do a little better job of keeping the heightened energy level and the conversational perspective on a tone and a frequency which will match theirs. We will try, but I'm sure we will have some shortcomings there too. But nevertheless, thank you everyone. Thank you the panelists for being here. Before I get into the conversations with the esteemed eminent leaders, I must definitely introduce them a little differently. And the reason why I'm saying so, each one of the panelists who you see here on the stage are representatives of the leading, the first and foremost organization in their sector. We have Mr. Amitabh Jain. He is the Chief Operating Officer with Star Health Insurance Company, which was, I think, launched in 2007. That was the first standalone health insurance company in this country. And this is the largest health insurance company of our country today. We have Dr. Rohini. She is Chief of Medical Services with Apollo Hospitals, the pioneers in healthcare, and of course the largest, again, in the healthcare industry. We have Dr. Sridhar. Dr. Sridhar heads the vertical of occupational health and wellness, again for the foremost pharmaceutical company of this country, Dr. Reddy Laboratories. Apart from being intellect and what wisdom and knowledge that they're going to bring on this stage today, I think we should definitely give them a good round of applause for the kind of work that they have already demonstrated in their respective sectors. Today's session, when we are talking about rethinking how the value and viability can be brought on for the end customer, I think it will be also important to look at how these players are in their own sectors as well as together making impact on how the consumerism, the change dynamics out there, how the technology and how the services are being collaborated from payer, provider and the consumer perspective. So before I get in there, my first question, Amitabh, to you would be to actually let us know on how the insurers are actually keeping pace with today's changing consumerism where Swiggy's and Zomato's are actually giving a lot of instant gratification.
Hi. First of all, my thanks and gratitude for having me here on this platform. Privileged to be here representing Star, but more importantly, the health insurance industry. Last discussion, Arnab pointed out that insurance-led care is only episodal. Okay. I can give this assurance to this August House that insurers are equally thinking about how insurance can be much more holistic rather than just have an episodic care and just being a payer, and how it moves from being a payer to a partner in people's health journey. Specifically responding to your question on how insurance is kind of gearing up with the trends that are evolving about, gratification, instant consumerism and so on. Let me put it this way, that when it comes to health, okay, some of these trends become even more important because the criticality of care at the right time and the availability and access become much more important than other forms of consumer needs. And to that extent, the way the insurance industry has evolved over the last 20 years, especially after privatization happened and newer players came, I mean, things which used to take days together or weeks for things to happen, claims processing, basic service, authorizations, have now moved to hours. And most of it is being led digitally and through platforms that are very accessible, be it mobile apps, be web platforms, and so on. And that has kind of catapulted the whole understanding of insurance to a very different level. And now pocket-sized insurance, bite-sized insurance, going as attachments, whether you're traveling, whether you're having food, whether you're getting exposed to a particular event, like a flight or a travel, okay, all of that is getting insured in some way or the other. At least that access is there. So the same trends that you see that are happening across the society for various other consumer needs are also impacting and shaping up the insurance options available to them. And I think it will just be a reflection of how the society as a whole evolves in various forms and shapes, and insurers are going to sort of adapt as well. A case in point is, the way insurance is sold today, right? I mean, it is available at the beck and call of anyone who's just accessing a web platform or any other, digital means. You don't have to wait for an individual to come to your home or office. These are things which are available on one tap. And with the availability of data across the entire profile of a corporate, of an individual, through various sources, has ensured that a lot of the stuff which you used to question people on is actually available seamlessly to the insurer for them to, evaluate the risk, ensure that they know fully about the insured life, and be able to offer customized solutions so that it basically is very precise, very focused, and value for the amount being spent by the insured.
Can just somebody change the mic? In the meantime, we'll share it. No, I completely agree with you, Amitabh, because I still remember the early days when we were part of setting up of a TPA, right? This is way back in 1990s, late 90s. The entire thing of the cashless authorization was a mystery, which today we have kind of solved a bit. And came the era of 2010s, where we started talking about how do we crunch the authorization time. And I'm sure most of the insurance companies and the providers together have actually brought down the waiting time, right? These are some of the indices, I think, which are very encouraging. I still remember Ms. Shobana was here. This is when we were in Apollo Munich, and she said, why are you people not having the instant authorization tap card? And I think that dream is still there, and I think the industry is working towards that. But building on that, Dr. Rohini, consumers today are maybe not looking at just the speed part of it, but they are also becoming more discerning about the quality and the outcomes. So in your view, what you think is fundamentally shifting the way consumers are making the choices of which hospitals to go and where to avail services?
Thank you, Nandini, and it's great to be a part of this panel. I think the three people or the three come in sectors of industry that we represent actually will determine how healthcare plays out in the future. So you have a hospital or a healthcare provider, you have insurance, which is actually the enabling arm, which is the lubricant which drives the process forward. And then we have the corporate, in this case, representing the consumer. And this is the triad that is going to take healthcare forward. So this is the context in which we need to frame the problem. Now, the informed patient is something that we are facing every day. And this patient is informed not just about the disease that he has, he's also informed about what should be or could be done to treat that disease. So both are important, what should be done and what could be done. And he's now aspirational in asking for, or if you could use the word demanding, the best healthcare be provided to him. So this consumer is informed not just, as I said, about what affects him, but he also has a way to evaluate hospitals which are providing care. So we know all of this stuff is out on the web, on social media, and ability to evaluate and understand. We have industry setting standards. You have accreditation, for example. And yesterday we saw with all the heads of the accreditation agencies, both national and international, that broadly speaking, accreditation has driven an improvement in clinical outcomes and quality. And the third thing, which we should not undermine, is word of mouth amplified by the power of social media. So today the consumer or the patient is also informed about which hospital and often about which doctor. And if you do this experiment of walking into any hospital, you will find that the queues are much longer in front of a particular clinician than another particular clinician, which is a reflection of how informed your customer is. And so he is looking at this data and evaluating this data and reaching out to us. He's also looking at what tech you can provide. What is the technology? What is the expertise that you have? And he looks at this tech in two ways. One, and primarily in terms of convenience. Does this tech give him less pain, able to go home earlier, less complications, more comfort, early ambulation? So this patient convenience is a strong determinant, and therefore we find that patient choice drives treatment options towards certain streams. Robotics would be a case in point. So he's looking one at convenience and one at what outcomes that tech will help him to deliver. So this could be better technology for diagnostics or better technology for treatment. So he looks at tech as well. And then he comes to the financial part. So by the time he reaches the financial part, he's walked through this entire journey of understanding his disease, seeing what is the best that the market has to offer. He's now trying to figure out a way to finance this. And based on all of this is how the patient will make the choice. And I think we have to come to terms with it. This is not a person who's walking into your offices with a symptom, asking you to help him. He's almost a partner in care with very clear expectations and very clear understanding of what needs to be delivered to him.
Very well said, Dr. Rohini. In fact, my next question to Dr. Sridhar is the phenomena that we witnessed today, it's not limited to just a retail customer, right? It is more and equally applicable to the cost, your corporate employees, because as ma'am was saying, the corporate employees are no more the passive recipient of the service. They're actively participating in the healthcare decisions, right? So as an employer, how are you witnessing the change when it comes to the expectations that employees have, right? In one, on their, designing and devising of their healthcare benefits under the employee health services. And how are these large organizations like yours dealing with this? Because you have heterogeneous and diverse employee base. So their expectations vary and differ at different point in life and stage and geographies, right? So how are you dealing with it? And as an organization, how do you look at this entire employee benefit management? Do you look at it as a cost or it's an investment item for you.
Thanks, Dr. Nandini. Thank you. For me, let me go back to myself as an end user. If I see as an occupational health professional, I'm also an employee in a company, right? So when I try to go into the company, a lot of these days, everyone looks health. What is the benefit that the company is going to give me? That's one of the things they look at. Yes. Previously, 20 years ago, 15 years ago, we used to look at just as a health benefit, as a hospital expense. The person goes, gets it done, the reimbursement used to happen. And as told by Amitabh also, the digital was not there. And as you said rightly, no admission, cashless was there then. You had to pay and claim reimbursement. Some places this exists too. These days, employees are looking for not just that healthcare delivery, they are looking extra value. What are we getting out of it? Means they're looking for preventive wellness, and mental health. That's the key thing that this younger generation are looking for. They don't hesitate to contact or have counselings. If they really need support, they say, I would like to have a support. And other part also that comes is the family. A lot of employees in India insurance, the parents and parent-in-laws, right? There are many companies which are including insurance provider coverage to the parents or parent-in-laws. So they look for that. What is the value the company is giving? That's one of the expectations that employees are looking at. When you come to an employer perspective, yes, there are many companies which have come forward and trying to change by collaborating, right? Trying to ask for, okay, how can we make it better? And there is a direct networking and set tie-ups that are happening with hospitals these days. So the employees and their extended families can get benefited from the closed networks that they have in the hospital. So that gives a better care and a better advantage to the employees in terms of financially too. And from a wellness perspective, many organizations in India, I can say many, are going into the wellness care, preventive care that is being applied right at the workplace itself with the occupational health perspective wellness that's there. Holistic wellness has come a long way. It's started in many organizations. I'm sure many organizations will start implementing sooner or later. That automatically will drive down what you can say is absenteeism or less productivity. So the company will have more productivity, less absenteeism because of giving all this preventive wellness care right at the workplace itself. That's happening. Mental health is one. I can say the other side of it, but for the good side, what we are seeing these days is many organizations have come up, especially I think it's the COVID that was a catalyst that pushed it further. Employee assistance programs have come up in a huge way in many organizations that is being given to the employees, that is being utilized too, right?
Very well said. In fact, on the space of preventive care, I think there are a lot that has been done and a lot will have to be done because in one of the recent survey studies that we were looking at, what is the uptake of the health check that the company sponsors, right? It is still abysmally low. And equally for the no claim advantage that most of the insurance companies, they do provide as a benefit for sponsoring the health check program once in 3 years, uptake of that also is pretty low. But coming to your preventive thing, I think the cost is one trouble that each one of us face at different point in time. While speed is expected, right, the quality and outcomes are expected, but there is an elephant in the room, which is the cost discussion that needs to happen. Affordability is one of the biggest concern of individuals and families, right? As Ms. Shobna was alluding to in her last session, that it's not as much of a problem of demand anymore, especially in the metro and the tier 1 markets, right? So there is access which is there, the affordability seems to be something which is kind of lingering on everybody's mind. So my next question to you, Amitabh, is with the advent of the new age medtech and the deployment of, the large technologies and persistent inflation that we all, come across, how are insurers balancing the immediate need to keep the premiums affordable without losing the sight to the long term, which is a reality that quality healthcare will not be cheap. It will come at a cost.
Yeah, that's the most. That's the most important question and debate going on. That's always a tussle, so to say, between the payer and the provider. But let me just step back a little and first talk about what is the role of an insurer and what is insurance all about. Insurer is just a mechanism of a segment of population or society coming together, pooling their funds with the understanding that some of them would need it at the hour of need. And the insurer is supposed to efficiently administer that process and ensure that, at that moment of need, it is done properly to the satisfaction of both the claimant and the non-claimants. Because it is the non-claimants' funds as well which are being used to pay to that claimant. Insurers are not growing this money somewhere else, right? They are getting this pool of funds from the policyholders and they are custodians of these policyholder funds. So at all points, the insurer has to remember and be aware of their fiduciary responsibility that they are doing this job efficiently, both at the time of settlement of the claim as well as acquiring new business in terms of managing their cost structures and keeping the cost efficiencies as well, so that the maximum benefit goes back to the policyholders, either in the form of keeping their premiums reasonable and also ensuring that they get their due when a claim is made. So it becomes a tightrope walk between these two sort of segments. And typically, from a number perspective, the number of claimants are much lower than the number of non-claimants. Meaning, at any point in time, if you have 100 policyholders, less than 10 policyholders actually claim in a particular year, and 90 do not claim. I'm talking about hospitalization, right? So, obviously, these 90 expect that since they have not used the insurance, their premiums to be under control.
Absolutely.
Whereas these 10 who claim want that every pie of what is being paid for at the hospital or the provider is covered and paid without any issues. Yeah. So this is this tightrope walk that you have to manage as an insurer. Now, while I understand that there is modern treatments, robotics, all of that coming, and ultimately the insurer will reflect these trends in the form of policy coverage of what customers want. If customers want these treatments, it will show up in policy terms and conditions, and therefore it will be covered for and paid for. But the thin line that we need to be careful about is how much of it is needed and actually required, and how much of it is abuse or wastage. Any article you pick up, any report you read on fraud, waste and abuse, and it says that not only India, but even most markets abroad, fraud, waste and abuse accounts for anywhere between 10 to 15% of the premiums. And that can be a huge cost for this pool to bear. And that finally shows up in the form of higher premiums for the end policy holders. So our request and our appeal to all the providers and all the other stakeholders in this entire chain is that you need to treat an insured customer just like you would have treated a non-insured customer. because it is ultimately their funds that we are utilizing to pay this invoice or this particular procedure. Often we find that the behavior towards an insured customer changes the moment a provider knows that this is insured, because they feel that the funds would be easily available. I think this fundamentally has to shift to say that whatever is needed will be done appropriately as the case demands, irrespective of whether it is insured or not. And I think that can solve a whole lot of problems.
No, very, very well said, because the value creation should not be value erosion for the other partner. Yeah. That's very, very well received. But coming to an extension of this, Dr. Rohini, because I belong to Apollo, so I know its core ethics and the value. For us, every patient walking into our doors is same. And if there's a relevance and requirement, that's when the protocols are exercised for guiding them through what is the line of best treatment. And as I see, the hospitals are most of the time at the receiving end of this tension, because patient walks in to the hospital corridors with a very high degree of expectation, because they're in the situation of crisis. And on the other hand, we have the payers who are also looking at how do they actually not get their value eroded, talking about the containments and the cost calibrations, right? So how do providers like you tackle with this conundrum of, the best price vis-a-vis the best service and clinical outcomes on top of it?
So it's a difficult question, I think. But let me just share with you a story of how we come to standard of care. We know that Apollo Hospital was the first in the country to put up a proton machine. This is just the latest example of what Apollo has been doing over the years. We are very proud of the fact that we lead with med technology. And when the proton came and was installed, I don't think we could have made I'm probably certain that we could not have made a very good financial case to install it. It was a 50-50 clinical case. There were clear indications, but there weren't as many as we would have liked. But we have to have the courage and the conviction to walk down that road. And that's the courage that our chairman demonstrated. And it's not just courage from a financial perspective, it's a courage of conviction that my patient should get the best. And for a long time, that was convenience and precision. But to the point today, and why I'm talking about today is January 26, actually on the 10th of January 26, Lancet has come out with a paper. This is a multi-center study led by MD Anderson, done across 21 centers across the world, which now says that proton may be the standard of care for oropharyngeal cancer. So this has been a long time coming. This is a 10-year journey. And in that 10-year, to the point where we can now say it's standard of care, is a road that all of us have to walk. The patient, the clinicians, navigating the cost conundrum, but making sure that unless you walk down that road, we cannot start with standard of care. We have to start 5 steps behind standard of care, and we have to get to standard of care. That's how medicine evolves. So today we have class 1 indications for robotics, but it was not always that way. We started 10 years ago, and today we can say that yes, it is the standard of care for urology, for prostate surgery. So that's an important prism and a lens that we must bear in mind. We start at a point where the treatment is comparable to the best, but not necessarily demonstrating advantage. And then there is a journey to where it is definitely advantageous, and then we are confident in saying standard of care. So I think this understanding is important, because there's considerable investment, not just financial, in terms of effort, in terms of those clinicians who have dedicated themselves to excelling, so that we now have standard of care. So please keep that in mind. So that's something that we need to keep, and something that we think about every day. And as Apollo, we are always ahead of the curve. with many of these procedures because there is a belief that it will end with something that will be the standard of care. So this is point one. The second thing which Nandini said, which Amitabh referred to, yes, we have taken it upon ourselves, at least over the last 4 or 5 years, to look very carefully at what we call appropriateness of care. This, for example, when you look at quality and outcomes, the patient going home well is not necessarily all that you need to measure in terms of good outcomes. So for a long time, that's the way we looked at quality. Patient didn't have any complication. Patient went home in 3 days. Everybody is happy. But today we know that there are many dimensions. It's not just efficiency, it's not just safety, it's not just that the patient went home without trouble, it's also appropriateness of care. So an easy example would be to look at whether this patient needed a cesarean section or not. It's a controversial issue, but it's something that we are all committed to looking at. And again, it's a journey in which we need to walk together. I think as individual clinicians, as individual patients, I think all of us have certain expectations. But I think if you look at it purely from the lens of what is appropriate care, we will go ahead a long way in making sure that when it is necessary, where it is necessary, we are able to provide it. But in being able to do this, we also have to take into account the work that happens behind the scenes in training the doctors, in training the nurses, in having the infra available so that the day you now have a Lancet, which is almost a standard of care recommendation, you are now ready tomorrow to deliver this at the standards which are expected of us. So it's not an easy answer, but I can assure the insurance and the consumers out there that we are looking at this very carefully, and this is an additional dimension of quality and outcomes that we are looking at to make sure that our patients get the best. And when we mean the best, we mean appropriately the best.
If I may come in, Dr. Nandini, I really appreciate that, the concept of, appropriateness of care. And these are the kind of initiatives, I think, that will help bridge some of this trust deficit that happens at times between payers and providers. To this end, we've been kind of advocating as an industry adoption of standard treatment protocols, uniform billing heads, so that the understanding of an item is the same across. And see, Apollo stands for a very high quality care model, and you've been the pioneer for so many things, and that's great. But then we deal with a spectrum of hospitals which range from this level to something very elementary. I mean, we're talking about 60,000 hospitals in this country. So the more we can sort of drive some of these standard protocols, the standard treatment guidelines, admission criteria, okay, all of this will help us basically to keep the waste and abuse out as much as possible and provide the best care to the people who really need it. I mean, if someone needs proton care, of course, that's what insurance is for. So I think that's the point we are trying to make.
Well said, Amitabh. Well said.
Just one point to this. I completely agree, and I think all healthcare organizations, within the constraints in which they operate, will be working towards this end. But I just would like to make a point that whatever these be in terms of protocols, I think the word that we use is practice guidelines. And I think the reason we use that terminology is that they are guidelines. So the power to take the decision, if you can call it power, should vest in the hands of the clinician and the patient. This is a joint decision-making process. And I think we need to create an ecosystem whereby we are able to improve or enhance this decision-making process in the direction in which we want it to move. So at all points, I think, and this is the belief by which we have, done what we have done in Apollo, is that the clinician there at the patient's bedside is the best person to take the call in conjunction with the patient. But we have to build an ecosystem that brings data back to him to tell him how this is happening and to increase his confidence and his ability to make those decisions in the interest of the patient. So just wanted to emphasize that. And I think that's the way that any, self-correcting system or mechanism should work. But we are a little, time away from that. I think we are moving in that direction because we now know there are government guidelines as well. ICMR has come out with some treatment guidelines, but that is what they are. They guide you as to what should be done in a certain situation, but as we said, the ultimate decision is made between the clinician and the patient at the patient's bedside, and that is something that we should all learn to respect, but work towards moving it in the right direction.
So collaboration for sure between payers and providers, and little more understanding of each of these aspects. The dialogues have to be on that. All of us work towards satisfying one person, which is the consumer. Let's hear from Dr. Sridhar, because the cost inflation that we talk about, there's certain things which are within control and most of it not, right? Every rupee that a payer pays to a provider, right, comes from the customer, right? So how are organizations like yours currently looking at the balancing the act of affordability vis-a-vis the employee satisfaction? Because the minute you bring down the sum insured or curtail on benefit sets and so on and so forth, bound to happen that employee satisfaction is going to go down. So affordability and employee satisfaction, how are you managing that entire thing?
First thing I would like to say is regarding accessibility rather than going into affordability. In India, if all the audience, I assume they'll agree, we have ease of access to any specialist anytime we want. We don't have wait times compared to the Western countries. That's the first thing benefit we have, that everyone should appreciate that we have that access, we can approach anytime, which is a struggle. I've seen working internationally, a lot of employees internationally, they struggle to get an appointment to go and get themselves fixed. That's one. In terms of affordability coming into an organization, these days OPD benefits is one thing that has been added, and a lot of companies are adding to it that helps with the direct tie-ups that I mentioned earlier with the hospitals. That's been done. It's being provided, but the challenge comes is how much is the employee informed? That's where always it comes as a dilemma, whether they are informed or not informed. So the more information is passed on in a better way, communication happens with the digital tools these days that have come. Definitely that has helped. And these days even all the, any hospital care that is being taken care of, any consultations done, they're done through telemedicine has come in. That is one that many organizations have taken with a both hands and offering it to employees to take care of it. As I said, with the working population that are like morning to evening and they don't have time to go, there are organizations have gone to a stage like, what do you call them, the helps, where there are organizations which have tied up with certain agencies. They go as medical helps. These people are the ones, they'll go to the house, especially those with joint families or extended families, the elderly care, they cannot take care while they're at work. These other helps, they end up taking A to Z care, right from home up to the hospital, connect with the doctor, bring them back, get them access to medicines, whatever is to be given. That is also being done. That's one way organizations are going in. Another part that comes is the wellness. And a lot of programs are being run in organizations these days. You call gamification, wellness gamification that are run 3 months, 6 months programs or around the year programs that are run. And a lot of employees are encouraged to utilize it. And yes, you see 20%, 30% might use, some of them might not use because of the different situations they are in. But definitely, certain group definitely gets benefited out of this. They do. And it's happening nicely. With regards to how affordability comes in terms of certain level of package, in terms of healthcare for in-hospital care that is required, companies have come up with a different model. They're not going with this one thing, big tie-ups with the providers. They make packages in such a way that the employee can choose based on their life, like reproductive health, age, or the maternal care, child care. That's one part. Some employees might want some might not need it because they don't need, they're at a stage they don't want it. So that packages is chosen, and where you can have your money more in such place and utilize it in a better way rather than just taking in a bulk and ending up not utilized. And as they say, if an employer gives benefits to an employee, if it is not utilized, it doesn't carry any value. It has to be utilized. Utilization is the key, and more communication helps in achieving that part.
So well-informed employee about how they can navigate into their health benefit does help in maintaining that balance. Thank you.
Yeah.
Moving ahead, let's talk about how the technology, not only the advanced medtech, but overall the deployment of AI and so on and so forth, actually impacting the way that we are delivering care and service to our customers. On one hand, there is again cost associated with deployment of these technologies, but these technologies are also promising enough that they will better the outcomes, right, and the efficiencies. So my question to you, Amitabh, is that what is the one most disruptive shift that you are expecting in how customers now will and going forward will define value from their health insurance programs?
Yeah, that's a $1 million question, so to say. But like I said earlier, insurance will reflect or mirror the overall change that the society is undergoing, And I think a big play will come because of AI, not only in terms of improving efficiencies, increasing productivity of operations at an insurance level. For example, say the cost of processing a claim, or for that matter, how customers are responded to at a call center through bots. And all of that is going to obviously bring down the cost significantly. The more we bring down the cost and the expenses of management, the more funds are available for payment back to the customer, either in the form of claims or better coverage, modern treatments, and so on, and also keeping the premiums in check. One of the things that we are investing on heavily is on wellness and prevention at a very different scale and size through our app, the Star Health app, and I'm sure that's a lot of other industry players are doing as well. Now, one of the features that we launched about a couple of years ago was Face Scan, where by just scanning a person's face for a minute on the mobile phone, you get about 6 very critical health parameters available, to the customer, including your blood oxygen saturation level, your blood pressure, and so on. And these are fairly accurate. So now this suddenly changes the entire concept of going and getting a health check done with a doctor every now and then. And now we are offering this as a complimentary service to all our policyholders so that they can fundamentally get a quick check on how they are doing. And the moment they get a red parameter there, we have a teleconsultation option available immediately at the click of a button, which again is complementary to the policy. And the person can actually talk to a doctor and get a first-hand view about those readings. So we are not saying this has replaced the traditional way of getting yourself checked or doing the diagnostics, but at least it raises the first level alarm or precaution the moment you get an adverse reading there. And then it follows up with a consultation, and then, of course, if you have bought an OPD policy with us, you also get to go to a doctor and consult. So these are the shifts that are going to happen, and I think it will become much more holistic, care as part of the overall insurance, rather than just being a payer of a hospitalization claim the way it used to happen.
Absolutely. In fact, there are lots that's happening at the companies front. There are lots that's happening at the provider front also. So Dr. Rohini, could you just allude to some of the latest deployments that you've had in the space of AI, which actually has elevated the customer experience, the patient experience, and the attendants, putting them into little more state of peace in their head when they are at a point of distress?
Yes. So I think AI in healthcare by itself a very large topic. I think one arm of this, which is the efficiency or convenience arm, as I call it, I think there is enough proof. It's already been rolled out. It's available for us to use. Largely, for example, what Apollo has with Apollo Assist or Ask Apollo, these are platforms which provide a forum or a way for the patient to actually get his questions addressed very effectively and very efficiently. And it also provides a way for the patient to stay connected and engaged with the healthcare system. I think this is important. We have deployed AI tools, for example, in managing the continuum of care, in bringing down wait times, in facilitating the booking of appointments. So this is a piece that's really well done. If, for example, with reference to insurance, there is the possibility that we can automate the entire claim book and connect it to them so that that process of sending in the paperwork and getting the claims addressed can be expedited. So these are all work in progress at different levels of deployment across the organization. The other piece is on the clinical piece that Nandini alluded to. And there I think we've made some progress on the diagnostic side, even including something like what Amitabh used or suggested. So there are such apps or such applications which allow you to, at the click of a finger, get a dipstick of what's happening, get a snapshot of what's happening. And though it may not replace traditional methods, it just gives you a sort of pointer towards the fact that you need more help. Of course, we have examples of AI being used in radiology and other diagnostic, including the lab. On the clinical side, and there is some concern on that, when we are using it to guide clinical decisions, there I think we have a way to go. We have done significant work with predictive analytics and risk scores and risk stratification. We have 13 such AI-enabled risk models which have been rolled out within the Apollo ecosystem, but they are not fully deployed, and we are yet to see in totality what are the benefits that we'll receive.
Thank you. Thank you so much, Dr. Rohini. Excellent insight into, how the tech and the services are going to be changing and reshaping the way the consumers are going to be. I'm just looking at the timer too, because Dr. Rohini has another panel discussion that she's supposed to be attending at 1:10, so we will have to close in the next 5 minutes. But my take on this entire thing is that there is so much of collaboration that is already being seen and much needed too, because the best of the best apps, the best of the best AI diagnostic tools, best of the best employee benefit management programs, right, deployed by each one of you, will fall short if we are perfecting ourselves in silos, and the moment of the truth is when the claim doesn't get served to the tune of what it should be, right? And that juncture of dissonance, it actually disqualifies every good effort that has already been put. The amount of effort, I come from health insurance background, I've been there for 18 years, then moved into the provider setup. I completely understand the kind of efforts that go in getting a policyholder, because Indian mindset is very, very clear. We think that nothing will happen to us, it will happen to the neighbor, right? And we look out for getting financing by any sort, including an insurance cover, when we find that there is something happening or there is something which is existing, right, in the imminent future. Now, this mindset actually gets tackled by the amount of distribution set up, both digital and offline, that the task force that is deployed by the insurance companies to go and convince people that you will need this someday, so why not get enrolled today? And on the other hand, the amount of infra, the training, the processing, the help desks that are being put by the provider setup to ensure that every person walking into the corridors are taken care of, tackled, and the dialogue between the payers and the providers then begin in the form of the authorization, right? But there's a lot that needs to happen, and we are learning together, we are evolving together, because the consumerism is evolving, and no service provider can say that we have perfected, but if we have perfected the solutions in silos, it may not help serve the end user. So coming the full circle back to Dr. Sridhar, my last question to you is, how, if you were to snap your finger on one thing, right, and say that this is what is going to be very useful for my employee, what would that be?
Okay. Many things, but I can say one, right?
Prioritize, please.
Okay. See, these days, every one of us, it will be the same thing is when you're going for a healthcare treatment and you are there and you want to get it done. Everybody of us will be anxious whether this will get approved or not approved, and how is it, what is it going to happen. It's all complicated these days. We have more of mental tension rather than getting the treatment done. It's another thing, stress adding to that place. So what I would do is, like an Amazon checkout, you go, you get it, see the provider, along with the insurer. There should be a collaborated approach where the person walks into the hospital and walks out without any trouble or hassles or stress to go through. They get their treatment done, they walk out. That is my dream.
Perfect. Thank you so much. It was lovely moderating this session with all of you.
Nandini, if I can have one summary statement.
Yes.
So I think to summarize, this has been a very good session. So I just had, it was running through my mind as I sat here. I think this is about the 3 Ps and the 3 Ts. So which are the 3 Ps? The 3 Ps are the patient, the payer, and the provider. So these are the 3 angles of the triangle that we discussed. And what are the 3 Ts? This is transparency, trust, together. I think Absolutely. If we do this, it will go really well.
Absolutely. Very well summed up. Yeah. Very nicely summed up. Thank you. Thank you, audience. I think we do not have time for questions.
If you would like to, ma'am, you can take a couple of them.
Yes. Yes, Dr. Ramesh. Can somebody hand over the mic to Dr. Ramesh? Or you can take this. You can take this, Dr. Ramesh. Yeah, you will.
So good morning, everyone. I hope you all enjoyed the session. You are all definitely come along with me. Why don't you give a big round of applause for the good moderating Dr. Nandini, because she has good experience in the field of insurance. She worked for the Family Health Plan Limited, if I'm not wrong. Yeah, and after that, no, she moved to in a different sector. My question to you, Amitabh, just now you told that it's a simple layman language. Insurance means pooling of money, pooling of finance. If your claim ratios shoots up more than 200% at 300%, what is your plan? And moreover, you are more worried about the urban insured persons. And you have any specific plans for the people who are living in the rural? So I would like to hear from you.
Yeah. So, you would know that because specifically if you're from Hyderabad, insurance is a regulated industry, and we are governed by the IRDAI, which is actually headquartered here in Hyderabad. And, it ensures that each insurance company runs on certain regulations, which will ensure that, even before we reach that 100% or 200%, okay, certain preventive measures will be in place to ensure that we do not reach that stage ultimately. But as a general management of any insurance company, the 3 distinct areas of intervention that happen to keep costs under control are: one, the expenses of management, which is the cost of running the show and acquiring new business and the renewals that happen. So there is a norm for that, and each company has to adhere to those norms as prescribed by IDAI. The second is the real cost, which is generally to the range of 70 to 80%, which is the loss cost or the cost of claims. Now, to keep those costs under control, we get into all these arrangements that we are talking about with providers, trying to ensure that we get the best deal for our customers, but also ensure that we keep fraud, waste, and abuse out as much as possible. Because a lot of money from the pool is taken out because of FWA. And that's an area where we need to work together, both providers and insurers, to keep this out as much as possible so that the genuine policy holders do not suffer, right? For a few elements who are out there to make quick money, okay, if we can keep them out, the whole lot of more than 90% policy holders will be actually benefited. And the third is to raise premiums. Ultimately, if your cost of care is going to go up, it will reflect in higher payouts to be done by the policy holders in the form of premium, because that's the cost of care in this society or in this country. So ultimately, it will reflect in the premiums going up. So these are the ways in which the whole pool is managed and administered. As far as products are concerned, yes, we have a range of products which services both the urban segments as well as the rural segments. There's a policy called Arogya Sanjeevani, which was actually launched by the regulator about 8 to 10 years back, which actually takes care of a segment that is rural or semi-urban. But we also have other products. The point is, there are a plethora of products available, but the cost of distribution and reaching to the end customer is huge. It's not easy to sell even a health insurance policy even today in India. It is a push sell. It is not something that is a pull. After COVID, there was an environment of 1 year, 2 years when there was enough pull. But after that, again, that has waned off because people started believing they are fine now. COVID-like incident will never happen again. And therefore, the awareness or insurance penetration has again kind of suffered. So it's a combination of that. But yeah, I mean, we keep doing that effort through better products, better services. And of course, it's much better than what it used to be 10 years ago. Thank you.
And just to add to what Amitabh said, Dr. Ramesh, you can be rest assured, players like Star will always honor your claim. They have a very robust, I think theirs is the most comprehensive and most robust reinsurance program that they run, right? So you can be assured of. I should have asked this at the beginning of the session. How many of you have a health insurance policy for yourself? Show up your hands. Yeah. Oh, very impressed.
That's a very good number.
Because I think most of them are coming.
And I think the biggest disruptive change in this segment has been brought by none other than the government of India 3 months ago, when they have equated health insurance as a very basic need by removing GST from health insurance. So, all of us owe it to the government that they have done that, and I think it's now the duty of each of us to ensure that we have a health insurance policy. Thank you.
Very well said. Thank you so much. Thank you for your august presence.
May we please request you to come forward for a photograph?
Safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient
Thank you, Dr.
safety.
Nandini, for chairing this session so seamlessly, and to our speakers for such a fantastic discussion. Ladies and gentlemen, with this, it's now time for a lunch break, networking and innovation showcase. So please head over to Hall 4 and 6 to enjoy lunch, connect with fellow delegates and explore the latest innovations. We look forward to promptly having you back for the next session that starts at 2 a.m. featuring Mr. Gaurav Loria as the chair, the top gear, speed, precision and power, and our speakers would be Dr. James Merlino, Dr. B.K. Rana and Dr. Illan Kumaran Kalyamurthy. So see you promptly everybody at 2. Enjoy your lunch.
We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who
Ladies and
pave the
gentlemen,
way.
please proceed for lunch.
We are
And we will start our next session at 2 p.m. promptly. So please come back. A very interesting and engaging session awaits you. You wouldn't want to miss that. Enjoy your lunch, please.
Make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. Safety across, we across. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. nation. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. are here to make a difference. For innovation, we are here to make a difference. We are the International Health Dialogue. Technology is our power. We commit to improve safety across. We across. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. For innovation, we are here to make a difference. We are the International Health Dialogue. Technology is our power. We commit to improve safety.
दुनिया में हर मिनट सन फार्मा की 1000 दवाइयां लिखी जाती हैं। यानी हर मिनट 1000 जिंदगियां फिर से खिल उठती हैं। हर मिनट 1000 कहानियों में कुछ नई कड़ियां जुड़ जाती हैं। हर मिनट 1000 दिलों में धड़कती है सेहत। सेहत जो मुस्कुराहटों को हंसी में बदल देती है, ताकि आप अपनों के साथ हर पल खुल के जी सकें। तभी तो सन फार्मा दुनिया के 100 से भी ज्यादा देशों में उम्मीद की किरण जगाता है। सन फार्मा, इंडियाज नंबर 1 फार्मा कंपनी।
today.
You are audible. How may I help you? Of course. My sense.
It's my pleasure to introduce.
We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here.
What technology do people consider valuable or beneficial for healthcare?
He does come across as a bit of an... Meet Dr. James... Meet Dr. Elon. Meet Dr. James Merlino, aka, let's be honest, he does come across as a bit of a know-it-all. 2 published books, global keynotes.
Must continue. This relentless innovation for life.
दुनिया में हर मिनट सन फार्मा की 1000 दवाइयां
Namaste everyone. Our Clinovate sessions have begun. Following are the details. Room number G01 ground floor gynecology sessions. Room number G03 ground floor oncology sessions. Room number 1.04 first floor pathology sessions and room number 1.02 first floor cardiology sessions. So all those who are interested in the Clinovate sessions, you can proceed to these rooms. Thank you.
And the finders, we are the thinkers and the doers, we are the dreamers and the achievers. We are here for patient safety, we are here for quality care, we are here for innovation, we are here to make a difference. We are not alone in this mission. nation. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. are here to make a difference. For innovation, we are here to make a difference. We are the International Health Dialogue. Technology is our power. We commit to improve safety across. We across. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. For innovation, we are here to make a difference. We are the International Health Dialogue. Technology is our power. We commit to improve safety across. We across. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference.
Hello. Few important announcements, everyone. I hope everybody have marked their attendance for day 2 in order to receive their certificates. Please ensure everybody quick reminder to mark your attendance for day 2. Please ensure that you scan the code and mark the attendance in order to receive your certificates on time. Also, there is an important announcement regarding Pro Health. Your delegate kit includes Pro Health coupons, Pro Health checkups, go beyond routine tests, and help identify hidden health risks early. We encourage each of you to redeem the coupon and prioritize your own health journey. Please check your kits in order to see the Pro Health coupons kept inside.
Make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care.
Ladies and gentlemen, we also have Clinovate sessions going on at various halls across different floors. Ground floor G01 for gynecology, ground floor G03 for oncology, first floor pathology, room number 1.04, and first floor cardiology, room number 1.02. So doctors who are interested in attending these sessions, please do visit them. Thank you.
We are here to make a difference. For innovation. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders.
Ladies and gentlemen, welcome back. I hope you all had lunch, and let's bring in some energy for a very interesting session now. It's called the Top Gear Speed, Precision and Power. We now move to an exciting and dynamic segment of our conference. The Top Gear Speed, Precision and Power. Get ready for an engaging exchange of ideas. To lead the session, may I invite Mr. Gaurav Loria, Senior Vice President, Head Operations and Patient Experience, Apollo Hospitals. I request you to join the stage, sir. Let's give him a huge round of applause. Come on, let's bring some energy. Yes, that's the spirit. Please join me in welcoming our industry leaders to the stage for the Top Gear session. Dr. James I. Merlino, Executive Vice President and CEO, Joint Commission. Dr. B.K. Rana, CEO, Quality and Accreditation Institute.
I hope these two
And
will be
Dr.
comfortable.
Ilan Kumaran Kalyamurthy, Regional CEO, Apollo Hospitals.
Thank you so much.
Welcome everybody. With
Thank you
this,
so
I
much.
now hand over the forum to our esteemed session chair to lead the discussion. Over to you, Gaurav.
Please have a seat. So good afternoon, everybody, and welcome post-lunch. This is the session which we have been doing for almost 5 years in every edition of International Health Dialogue. This session is not about, asking questions or figuring out what people think, but what's going on in their mind largely. That is their larger vision, and that largely makes an impact, among the healthcare community. Definitely not a panel, not a keynote address, but leadership without cruise control. So, we are going to go a little faster in some of the questions. We will slow down in some of the questions, and we will take a pit stop in some of the questions to see how it further goes. This session is going to have 4 laps. So we are going to do this in 4 different rounds. And we have very esteemed and key people here who really have made already and continue to make that difference in healthcare in their respective areas with the great work that each one of them have been doing in their respective fields. So with that, I would like to start with my first guest here, Dr. James Merlino. I recently had an opportunity to also have a podcast with him, which was uploaded on our link, and then we did go through some of the very interesting insights into leadership as well as patient experience and what he largely thinks about patient safety. So we will probably pull out some of those facts from there and discuss a little bit more about him and deep diving into some of these conversations a little bit more. But before that, my team has actually prepared a small video, a very small video on you to show it to the world. It's not Dr. Merlino what you see here, but there's much more behind it as well. So can we have the video for Dr. James Merlino, please?
Meet Dr. James Merlino, aka Jim. Let's be honest, he does come across as a bit of a know-it-all. 2 published books, global keynote speaker, travels the world telling hospitals how to do things better. And you know what? That's fair. He's earned it. Executive Vice President and Chief Operating Officer, Joint Commission Enterprise. But here's the real mystery. How does he manage to have so much fun doing all this? Seriously, Jim, how?
No. Thank you so much. So with that interesting introduction and also looking at and trying to understand how he does all these things, we get into the first lap of this round. And my first question to you is that, you started your career with kind of environment where everything is under your control. You know what to give as a prescription to patients, patient care is under your control. But today you are living in a system or working in a system where largely impact travel through systems, and it's about people whom you don't control. The global healthcare, you don't have a control on that. So what has been harder for you as a leader? Has it been having that control early on or learning to give that up in name of scale?
Well, first of all, I'd like to thank you for having Joint Commission represented here. And admittedly, when you asked me to participate on your panel, I was a little afraid because I've seen you in action, and then I had the opportunity to be questioned by you for the podcast. And I have to say, I walked away a little hurting after the questions. But you're an amazing facilitator, and thank you very much for the opportunity. And the video was incredibly touching to me personally, and I will get back at the people that I know gave those pictures to you. So, it's interesting because as a physician leader, someone who grew up as a physician and then ultimately took on an administrative role, the hardest part is to scale things that you're responsible for, because you're used to kind of having control over everything, right? Particularly in my field as a surgeon, you're kind of the captain of the ship. But the first thing you realize as a surgeon is that it really takes a team, right? You can't go in and do an operation all by yourself. You have to work with people. So at a very early stage in my career, before I transitioned, you learn how to work with a team, you learn how to empower a team. But when I got into a leadership role, I had very good advice from one of my first major leadership mentors, who was Dr. Toby Cosgrove, who's the former CEO of the Cleveland Clinic. And he told me two things that I'll never forget. He says, number one, he said, as you are working on things in front of you, do the best you can at what you have. And don't think about what's beyond your control or doing something else. Just do what you have, work hard at it, figure out how to get it done, and figure out how to get it done with the least amount of resources possible. Because when you do it that way, and you're ultimately successful, you're going to get more resources. That's the first thing he told me. The second thing he told me is never look ahead to your next job. Always think about doing the best you can in your current job, because if you are successful, you will get noticed as a leader and opportunities will come to you. And that is really what's defined my career.
I think you did speak a very important thing. Just do the best of whatever you do, irrespective of what outcomes you see in the work that you are doing. So thank you for sharing that. We all pick up leadership cues from our surroundings. As our young leaders, we are often rewarded with, great job done kind of remarks or being very hands-on. But with experience, many of us realize that these very instincts that helped early on sometimes can start getting in the way. For you, has there ever been a point that you realize that a skill or an instinct that once worked very well for you needed to be consciously dropped, and what changed it?
Yeah, it's learning to let go, to have other people do the work and help them be successful. I don't think that I'm a great leader. I think that I consider myself a leader that can get things done. I think you're always striving to be better. And as you scale your leadership capability, I think you have to build teams, and everybody knows the adage, your success is only as strong as the team around you. But it goes deeper than that. You have to recognize that there's probably three types of people in your team, right? There's the people that are really grounded, they have experience, they know what to do, you can let them loose, minimal oversight, give them some guardrails, make sure they have what they need, stay out of their way, let them be successful, right? And then there's the people in the middle who have some independence, that are definitely skilled, that maybe need a little encouragement, they need more support. That's a sweet spot. Work on those people, because they're going to be moving to the independence. And then the third leaders are the ones working for you that are relatively new. They're a little bit afraid to let go. They're a little bit afraid to take charge. And, your best opportunity is to develop those people, to help them succeed, help them develop their skills, and clear paths for them to be successful. But if you have a team of people like that, your job is more of the coach to make sure that your people are successful. And I think that, as you scale yourself from an N of one as a leader who's used to doing things, you have to be able to step back and help that team do things within their capabilities. And that is the way I think that you ultimately can rise as a better, more effective leader and have a great team.
Very well said. I once visited a hospital as part of one of the surveys, and very proudly they showed me their emergency evacuation system for fire. And their evacuation system largely was that, we were on the 10th level of that building, and they had like a chute which was from the window of that building, which kind of helped people to evacuate. You just slide down that chute. And I just asked them that, this is great, but have you ever tested it? They said, oh no, we are very scared to get inside that, because we don't know, because it's at such a height, when you just slide down through it, you don't know where are you going to land, or are you going to land safely. So the question that comes in is that, you have not tested it, you have not tried it, but you assume that it's going to be, safer. So from your experience, which is that one system failure that you think looks or have looked minor or a small thing on paper, but worries you most in real life?
What I worry the most about is when I was in healthcare, either as a physician or as someone that was helping to lead a healthcare organization, what kept me awake at night is patient harm. Because every time I would read a root cause report, or every time I would read kind of what people thought were the solution to the process, I knew in the back of my mind that we have not flipped the script on patient safety. We knew that we could fix something. We may prevent an error. We may not prevent an error. We'll certainly have a better understanding of what's going on. But I know that the true root cause, the culture, the behaviors, the leadership, probably was not addressed. And those are the kinds of things that you can't read on paper that keep you up at night when you worry about harming more people.
Yeah, I think very, very important thing again that you have pointed out, which should be a great learning for all of us and to keep in mind that. Thank you, Dr. Merlino. From him, we move to Dr. Rana. Can we have AV on Dr. Rana as well, please?
Meet Dr. B.K. Rana, founding CEO of the Quality and Accreditation Institute. What's interesting is not just that he's a pioneer and an innovator, it's what he actually does. He travels across the world, finding gaps, calling out what's broken, and implementing solutions. That's how healthcare organizations are uplifted, and we respect that. But what truly makes you pause is this. How does he do all of it with such poise? No worry on his face, always carrying that signature, charming smile. Breakthroughs without ever breaking a sweat. That's not easy. That's mastery. Hats off to Dr. Rana for always doing things with style.
Thank you, team, for kind of doing this video for Dr. Rana as well. So Dr. Rana is one of those persons whom I have been interacting with, quite a number of years, and I think that's really true about him. I have never seen worry on his face. He's always been smiling. So I think that's a great thing that a lot of us can actually learn from you. So starting with you, your role largely involves creating frameworks and creating those standards that work across the hospital. But as these standards travel from paper to actual practice on the ground, there are these reality bites that happen, right? So from a leadership standpoint, what has been more challenging and even frustrating at times? Spending years in creating these frameworks, right? Or watching them misunderstood and realizing that, this was not the intent. This is not why this standard was designed.
Thank you, Gaurav. Thank you very much for having me here. Thanks giving me the second position after I have just courage to talk to you. And thank you everyone joining this. Thanks for the wonderful video together. So I think the question is very, very difficult. And I'm sure you make sure that I am safe when I go out of this hall, because the answers coming out would be related to many of people sitting around, many leaders, practicing professionals in healthcare sector. So when you have, I think this is all three. What you talk about, the implementation of framework, misunderstood, or just on paper. So I think it's all three, coexist. I have seen systems where you have framework, standards, and you have compliance, which you could demonstrate. And sometimes it's misunderstood. But the most difficult part is when it is wrongly misunderstood. People know this is the standard, this is the framework they need to get into practice, but they don't. So it's not about misunderstanding the standard, but it's showing to be misunderstood. And the third aspect on paper, yes, there are systems which are existing beautifully on paper, but not on the ground. And the example you quoted about, I have seen one of the hospitals in Taiwan, but that did work. That did work. And that was as per the regulatory requirements of the government of Taiwan there. So I think it's a situation where we have all situations, all conditions, all probabilities of using the framework for what is intended to be meant to achieve, and also only just showing that, yes, you are intending, but actually you are not. Yeah. So it's on paper. And I think it's not bad, because there are many good or bad things. They coexist. in many sectors, including healthcare. So I think there are hospitals like yours, many others sitting here. There are hospitals who are just in nation state. They even don't know about what standards and frameworks are all about. So they may not be. But for me as a leader, the most frustrating is when you know what is there, but you don't do this. That's most frustrating. And at that point of time, we, as like I join him as well in saying, it's difficult for us to say, hey, Gaurav, you know it, but you're not doing it.
Yeah.
It's not easy to tell the hospital leader upfront. So I think there needs to be a whole ecosystem which tells each other that, hey, look, please stop and then move. So I think that's the most frustrating thing I came across when I go around and see.
I think it's not just the safe culture within an organization, but also that, it's a safe culture when an external body or someone tells you and shows you the right mirror and tells you on your face. So those comfort levels, developing those comfort levels, I think that's a challenge. And I hope all of you realize that he started with the point that that's a very difficult question, but he said that with a smile. So thank you, Dr. Rana, for that.
Thank you.
There's a very familiar cycle that, hospitals go through during an accreditation. You see tightening different behaviors and processes. Meetings happen more often than usual, or they are expected to happen. Hospitals suddenly look much cleaner than they are ever before, and then you realize that the thing which is about the normalcy or the normal situations, they start coming back again, right? So from everything that you have seen, what's that first bad habit that you feel is clearly visible after surveyors leave the organization?
Wow, that's why I said, please make sure I'm safe when I go out of here. So yes, it's connected to the first question you asked and how you really, as a hospital leader, put the framework into practice. You always say you have to have a documentation. Second is the implementation, which is the practice to generate the evidences and records of what you have been doing. And third is the verification of those implementation for effectiveness. So when a survey or assessment happens and everyone who is really want to achieve an accreditation, they are really worked toward it. They have fantastic documentation, good policies, procedures, SOPs, electronic paper, whatever they want to use, they have fantastic. And then start implementing, and finally they get a good certificate on the wall, right? And once you get it, you go back in many things. But the first and the most important thing what I observed in my observation is you stop implementing the standards. You have beautiful documentation which you implemented for last couple of months to show to Jim or to me or my team. Yes, you're doing good. All evidences exist, but then you start slowing down on implementation part of those documentation. For example, consent form, is one of the areas.
Yeah.
Even hand hygiene, very simple thing. So you slow down on that because the next survey is going to be happening after a year or 15 months or 18 months or 2 years, for example. And then you start again preparing. So I think that is sometimes frustrating, I would say again but that's something. But I'm not saying in general that everyone does that. There are exceptions always in all sectors, including healthcare. There may be hospitals who won't go back, even in smallest documentation. But this is in general I have seen across not only India, I have seen many parts of the world in accredited hospitals doing that.
And I think
pardon me, guys, please.
One of the other things that people do as soon as surveyors leave is that they take all their pending holidays and vacations that were quite pending from some time.
No, but that they deserve.
You suddenly see a shortage of manpower in the hospital, and then everybody is struggling to get it right. So I think that's the first thing probably that I would have seen largely in my experience. So I realized it much early in my career that when you look at processes, you look at data, you look at dashboards, it all looks green. Your processes seem to be set. Your outcomes that are measured are great. When you talk to people, they can answer questions. But when you actually go on the ground and you start evaluating some of the things, you really understand that there are some major gaps in this. So So what do you think, you personally lean on when these frameworks stop working?
Yeah, that's another challenging question. Tick boxes, what you mentioned is there are checklists based on the standards which you make sure that it is being done, practiced, implemented, and examined for verification. But again, when frameworks start cracking, and it's not just at specific places, it can be anywhere in the whole healthcare, starting from even before patient enters the hospital and go home after discharge. It can be any of the journey point framework can crack. And so what we say is in healthcare is everything is 100%. For example, when I ask my friend, Jimmy says my success rate is 99%. I said, that's fantastic, Jim, congratulations. But what about that 1%? That 1% is 100% for that patient. So same thing in the whole hospital environment. When any of the steps in the framework breaks or cracks, it started losing its own value. Yeah. So perhaps what I should do, or I would be doing in given an opportunity to, is to make sure that my framework exists. If there are any weak points which amount to crack, I'd make sure they don't. So it may happen that I need not to have everything on one. I can mobilize the resources to make sure that the system exists. May not be the perfect, and I would say then there is no perfect system exist. Yeah. Every system, every organization has an opportunity for improvement. And that's, I think, we aim as an accreditation body through standards that you show improvement, not just perfection. So I think that I would lean toward that fixing before it cracks, and giving the opportunity to all my team members to say, yes, we are there, don't worry, we'll make sure it exists, continue to exist. Thank you.
With one of his comments that he said that 1% is 100% for that one patient because it's about his life, and I think that's very critical. When you sit back, you think through it, it really talks a lot on, it could be just one error out wherein, one patient died, but it was that one patient who had to undergo that error. So thank you for sharing your comments with us. We move on to our next guest today, Dr. Ilan, and can we have a video on Dr. Ilan, please?
Meet Dr. Ilan, CEO, Apollo Hospitals, Chennai region. On the surface, he's the perfect company man, leading the vision, driving growth, and doing it all with relentless passion. But it seems he's leading a double life. We accuse him of living a life that's just a little too flamboyant for someone running one of the country's most complex healthcare systems. And it doesn't end there. Our investigators found something fishy. It's still unverified, but our instincts say, those glasses, they're not prescription. That's a style statement. We know your secret, Dr. Ilan.
Can we have a round of applause for him? Thank you. So, Dr. Ilan, I off late, I've started interacting with him a lot, and I really found him a very down-to-earth and a simple person who is very soft-spoken and puts his point forward, in a very clear way. So, thank you, Dr. Ilan, for being here today. You have been an anesthetist and also a regional CEO now. Which role between these do you think demand more emotional control for you?
Namaste all of you, good afternoon. My first disclaimer, this is a prescription class.
Okay.
Thank you, Gaurav. It's a totally unexpected video. Thank you so much. I think you did a lot of research, it seems, from my Facebook. Anyway, coming to your point, I was an anesthetist. My role was around ABC, airway, breathing, circulation of a patient. When I moved into this role as a manager, as a CEO, again, I believe there is another set of ABC for any organization. I would say alignment, belief, consistency. If I lose control on ABC of a patient, of course, it's a disaster for that particular patient and the team which I had been working on. Again, even for that particular moment, I have to maintain my emotional control. Still, if I lose my emotional control, there is a loss of one life and there is a reputation loss for a team. That's my role as an anesthetist. But coming here, again, if I'm not able to maintain this ABC of an organization or of the people, it's going to be a big problem. If I lose the emotional control, it's not going to sit within a room, or it's not only going to affect one person. It's going to affect multiple people in the organization. In a long run, it's going to affect culture of the organization. Yeah. I think both roles are important. Again, as he said, even one life is important. That point of time, I was very cautious, being emotionally controlled, because I was part of one of India's largest liver transplant unit. We do deal with very sick patients. I have to maintain my cool. But again, I was able to save one patient here. I had to be extra cautious. I had to be more controlled emotionally to maintain the integrity of the organization and to maintain the culture of an organization. I think this is going to be really tough. I hope I have been able to maintain that.
Thank you so much. Also, as an anesthetist, you know, a lot of these decisions that you would have taken, they were taken in like calmer environments or quieter environments with very less people around you. While as a CEO, the decisions that you make are watched by many in your organization as well as the larger community that's around you. So what has been harder for you to unlearn? Acting fast in a moment, or holding back and letting the system respond to it?
That's a fantastic question. And each role, not only in these two roles, any role would need a certain kind of behavior, reactional time, or a persona. I would call it as a persona. For example, as an anesthetist, we have to react urgently because many occasions the patients will be in a critical condition. That persona or that reaction time is really essential. Of course, as a CEO, in some occasions, not many occasions like as a clinician, in some occasions we have to react very fast. At the same time, most occasions we have to sit back, let the team react, and then guide them, advise them on how to move about. I think these two persona are really important. The most difficult situation for me is to unlearn reacting fast, because you're absolutely right. When I transitioning from a clinician role to CEO role, it took some time for me to unlearn that acting fast, because as an anesthetist we act very fast because we need the numbers to change very quickly. It took a few months for me to adapt to the new role along back. You're absolutely right, actually. I think we have to sit back and then do slowly things and based on a control measure.
Here I would also like to call out, I'm sure that there are many people in this audience who are either getting into healthcare, who have just got into healthcare, or who are aspiring to become leaders in healthcare, which I'm sure you will at some point of time. I think there are a lot of learnings that each one of you are sharing with you as the right learnings that will really help you to develop a clear vision and way forward for yourself as well after you listen to all the three eminent personalities who are here on the panel today. I've often, seen this happening, that leaders who move faster into the CEO role, you walk into the room and then you see people just agree with everything that you say. The conversations change tones, and a lot of times bad news arrives very late to you. So has there been a moment where you realized that power was starting to change the whole room around you? And how did that example or that situation largely helped to shape the kind of leader that you are today?
Brilliant question. Again, actually, it may be applicable to many leaders sitting here. This situation happens very frequently. Say when you are in a room, maybe with the clinicians or with your operations team or nursing team, if you don't allow them to speak, and if you start speaking and conveying all the messages, the power will completely shift. You wouldn't even know what's happening within the organization. So I have changed how I approach in any meetings. I let the team to speak. I wait until the end of the meeting. If there are multiple views coming from the team, at the end of the day, what is best for the organization, that's the kind of decision as a leader I have started making decisions right now. This is the important lesson as a leader all of us should learn, that in many occasions, let people come back with a solution, give them empowerment, create a culture of safety. If you are not able to create a culture of safety, it's not only going to impact patients, it might impact organization. So we have to let people speak even at the lower level. That's the kind of culture I have been developing.
I think very, very important and very well said. Thank you, Dr. Ilan, for your candid answers. With this, we will move on to the next lap of this session. Let's slow down here for a moment, but get faster answers from all the three panelists here. This is the pit lane where real fixes happen, and I'm sure you would have seen this, in different race courses or on screen. So it's a mid-morning. OT list is already running late. There is a nurse who flags off a near miss quietly, unsure if this situation is gonna slow down the cases for that day. You can sense fatigue among your staff, and patience is really thinning. Meanwhile, there is a patient's family member who posted online about the delay and the lack of care that's happened in your hospital. This is not a crisis as of now, but it could be a possible crisis that's coming soon. So Dr. Merlino, a question for you. Looking at this through a safety and a reliability lens, where do you think the system like this usually breaks first? Is it handoff? Is it hierarchy? Or is it fear? And which one worries you most before harm actually occurs?
Wow, that's the question. It's all three. As I was listening to the question, I'm thinking of the situation, and we all have examples of when we've been there with that. And each one of the things that you said, hierarchy, fear, handoffs, if you look at why safety events are caused, it's all three of them. For me, the one that I worry about the most of the three you picked is fear. Because fear speaks to a culture that doesn't promote doing the right thing, that doesn't promote speaking up, that doesn't promote teamwork. And until we break, and unfortunately, that still occurs. There is still a hierarchy that promotes fear. There's still people in healthcare that promote fear. Until we break that, we will never get to the point where everyone is working together for the best interest of the patient. Because you said it so eloquently, right? It only takes one. If you're that one, that's a bad day for you.
Yeah. Thank you. Dr. Rana, in moments like this, multiple standards are technically being met, yet the system really seems to be very fragile. From your perspective, what is that one decision that leadership must take together at this moment for this situation, even if it slows down the system, to preventing this from becoming a real failure again? It was a near miss.
Stop there. That will be the decision leadership must take. I'm audible?
Is he audible?
Yeah. Hello? Yes. Oh, fine, thank you. So I would expect the leadership to stop where they are if they have observed there is a flag for near miss in IPC protocols. Yes, fear is one of the factors, but when you look at the patient's online reporting about care is not there or delays and everything, but I would prefer that leadership take a call that is stop, investigate what happened, what gone wrong there, and fix it. I won't mind leadership because I would have more criticism coming out the public and patient rather than harming my patient. So I will stop things there, and then everything is fixes, move out, process is on, and then maybe post. We want to say patient, we want to make our patient more safer than putting into survey line, quickly and not investigate and looking into the crisis stage. So I think that I would expect leadership to take a call, not just going by the numbers to perform the surgeries and OR, because then you may have 10 patients harmed. Here you don't have any.
Yeah.
So I think that would be my choice for that leader to take call.
And I think very important for in such situations for people to just say stop, as you rightly said. But if you just close your eyes for a minute and you just think, have you seen around such situations happening? I'm sure your answer is yes. Have you seen people in those situations saying, let's stop and take a pause? Maybe, may not be, right? If our conscience levels allows us to really think, have we really taken it seriously? Some may have, some may have not. Have people gone back to the same, same behaviors and practices? Most probably, yes. So I think it's a lot of
I
thinking.
think as the case you say is an OR is in process, you know.
Yes.
So it's not emergency. So it's a selective elective cases, so you can wait.
Yes.
I won't mind proceeding with that flag of IPC if it's an emergency. I would prefer to try to save and then deal with that. But in normality, no.
Yeah. So Dr. Ilan, you know, this kind of a situation happened and the whole evening nothing happened. Suddenly, you know, by 2 a.m. on Sunday, this situation becomes a big problem for the hospital. Whose phone should ring in this situation and why? And what does that say about accountability in a hospital like this?
This situation should not be let happen actually. First of all, in case if it happens, the first phone call should go to the unit head. If I'm sitting, say, in Apollo Grimms Road, I think I should get the call directly rather than expecting somebody else to answer the call, because things have gone out of control. I think it has been there for many hours. I think the local team tried to resolve it. Unfortunately, it was not escalated. No action was taken. At the end of the day, we shouldn't let it happen further. I think things have gone out of control. The unit head who can make decisions at that point of time should get the call directly. It doesn't matter if it's Sunday 2 a.m. or Monday 2 a.m. or 2 p.m. doesn't matter at all. I think that kind of hierarchical system should be in place. Even the lowest junior level staff should know that I need to call that person without any hesitation to solve the problem. That's my viewpoint.
I think very well said, and you know, I will not hesitate to say this, that there are always two kinds of people, right? One who will be able to accept, want to be called and want to be informed so that you know early on and you take actions. And then there is another set of people who are like, don't bring problems to me, don't call me at 2 o'clock in the night, and just do whatever best you could do. And then later on you may realize that, you know, something has really gone out of your hands. So thank you for sharing that. Let's shift into the red line now, which is a third lap. This is like the, you know, the faster buzzer round kind of a round, wherein I'm going to ask 5 questions to each one of them. I have got one gift or a gift hamper, and we will see who performs the best among the 3 and gets the gift hamper.
I feel like sitting in FRC Viva 15 years back.
So no long answers for these questions, no context settings, and please don't use the word "it depends." Because if you use the word "it depends," it means that you have a negative scoring. Okay? So I'll start with Dr. Jim Merlino first.
Are we allowed to work together?
So one hospital process that should disappear by 2030.
Paper medical records. You know, it's interesting. We have made so much progress in digitizing the patient record. If we could just wipe out the rest of paper in healthcare, I think we'd be a lot better off.
One risk in healthcare, leaders are still underestimating.
The one thing, when somebody asks me what keeps me awake at night, it's harming a patient. And we have tremendous work to do in safety. We've made a lot of progress, but you saw the statistics yesterday. We're harming people. We don't do it on purpose, but we harm people. We have to work harder, and as more technology comes into healthcare like AI, the risk is only going to get bigger.
One safety practice that looks reassuring, but doesn't actually make patients safer.
You know, I had heard yesterday for the first time safety clutter by Dr. Engel from CUSPA. And to me, there are so many processes that we use to try and prevent safety errors. Probably most of them don't work. And what he taught me yesterday when I went and read that paper last night was that we need to look at what we're doing and we need to get rid of the things that we think are not working and focus on the things that are working. So I think there's a lot that goes into that answer.
One mistake. Very well said, actually, yeah. One mistake hospitals across countries keep repeating despite knowing better.
They ignore their culture. In the United States, we spend hundreds of millions of dollars a year on training programs and programs to bring nurses and physicians and other professionals together. You would have thought that we would have learned a long time ago, as well as the rest of the world, that we should be focusing on culture when people are just beginning their careers instead of having to focus on it when they're in their careers. We need to focus more on the culture, because when you align your culture, you can fix safety, you can get better quality, and patients will feel better cared for.
Yeah. You know, when I go across, I talk to a lot of people, or I go across different organizations, sometimes you just sit back and you realize that, you know, the word culture that you spoke about, safety culture, it's not about just doing a feedback survey from your staff and understanding what you need to do. That is just even 0.1% of the thing that you are expected to do. That is just to give you a broader understanding of what you are doing or where you are. But it's much more beyond that. It's not something that you just put it in your policy, you do a training program and tell your people to follow and to do it. It's much, much beyond that, and I think he's very well pointed it out, what needs to be done. If you could fix one thing tomorrow to reduce harm at scale, what would it be?
I'm sorry, what'd you say? No.
Right time.
I would focus on leadership. We need better leadership where people are consistently talking about the things that are important for patients, and of course it starts with safety. So fixing leadership, making sure that leadership is consistent, making sure that leadership is modeling what we need every caregiver to do.
Yeah, and though, yes, you know, the revenues are important, costs are important to be looked at, that's where the organizations would run, but what you're talking at a larger level on your outcomes, on your safety, and the way care is delivered, I think that's very, very critical and important. So I think he did a great job, and he deserves a big hand for being very candid and answering those questions. We move on to Dr. B.K. Rana. One practice that looks good on paper but should no longer exist in modern hospitals.
I think the morning rituals of doctors taking around without seeing or talking to patient.
Interesting. Doctors taking rounds without seeing a patient. Interesting. One risk that accreditation scores won't catch, but leaders must.
Pardon me, please repeat.
One risk that accreditation scores won't catch, but leaders must.
I think I would go what he said is culture of patient safety. That's the only one point I would say. They should be aware of that culture is not a bacterial culture in the O1S. It's about uniform approach across the organization, whether it's good or bad. That's the culture.
Yeah.
So that I will go with that.
Yeah, because it's not about someone who's coming into your organization for 4 or 5 days can actually evaluate your culture. But as a leader, you know what my hospital is all about. You know what I am, you know, kind of preaching and what I'm practicing in my organization. So thank you for that. One sign that tells you a hospital is compliant but not truly committed.
I would go back to the first lap is about unsigned consent forms, recap needles, blood stained, you know. So hospital compliant, you can't say everything is wrong, but there are things which are not compliant. So I think that sort of thing should not happen. What I say is it's not about the volume, it's about the uniformity of the practice. You may not go high 100% of a score. I would be preferring 70%, but 70, I can say, 24/7 it exists.
One uncomfortable truth about quality improvement, most leaders avoid admitting.
One
uncomfortable truth about quality improvement, most leaders avoid admitting.
This quality improvement is basically if they think the leader should think that they have failed, not the quality department and the manager of the quality. That's the thing it should be, guys. The quality guys. Leader should say, I failed, not you.
If the leaders could change just one mindset around quality, what should it be?
I think all your questions are going to the same answer. Unfortunately, I think it's a mindset of how I accept what I do, right or wrong. I ask questions to the nursing professional many times. Why you know there may be a chance to get the infection. Why you like this. No answer. Why don't you sign? And I seen hospital, unfortunately, getting the consent signed at the payment desk. Can you imagine that? So it's not something which quality guys do it. They set the things is individuals to practice what they should be practicing. I think there should be a culture. It's not about patient safety culture, it's about the culture of uniformity, practicing everyone around the organization.
We move to Dr. Ilan, but before moving to him, I think he also deserves a big round of applause. He really tried hard, and it's getting difficult for me to choose who performed better between the two. So Dr. Ilan, in the next 5 years, what will slow hospitals down the most? Is this people, processes, or technology?
To my belief, I would say it's processes. People can be trained, easy to sort out the issue. Technology will evolve all the time, and we have to implement it. These processes, whenever you wanted to implement this old-fashioned, unnecessary processes within a hospital, this is going to slow down the hospital. I think we have to remove many processes within the hospital and then replace with the technology. That's what I believe.
Very well said. And I think also what is important is when you do these processes, you keep patient there. You don't do these processes which are great for you or comfortable for you as a worker, but you put yourself in shoes of the patient, and then you understand what fits, what patient will go through, how many steps or touch points he will go through, and then figure it out. Thank you for that. Next question. One decision hospital CEOs will soon be forced to take, whether they are ready for it or not.
I think it should be, operational backbone should be based on the data, technology, and artificial intelligence. There are many traditional old-styled CEOs or operational leaders. I think we have to upskill ourselves to move on to data-driven, technology-driven organization. We have to adapt it. There's no choice.
Yep. There could be some new hospital CEOs who are just becoming CEOs. So one thing that such people consistently underestimate in their first year?
I would say behavior. Many people are closely watching how the CEO is behaving in certain scenarios with certain people, because the system will put a lot of pressure. How the CEO behave to those scenarios, people are closely monitoring. Of course, revenue and all these numbers are important, but more importantly, behavior of a CEO is more important.
I think, yes, I kind of agree with you, because as I said earlier, there are a lot of people who are watching you, in different situations, different meetings, what's your immediate response, what your facial expressions or body language has been. So I think that's something very important for each one of us to watch out for. One behavior leaders tolerate that quietly damages culture.
I think all of us suffer with this one behavior, I would say. There is something called brilliant jig syndrome, where somebody will be externally good in their skills and behaviors, not behavior, in the skill set. For example, there may be a topmost surgeon, excellent surgeon, but they don't follow any of the policies or protocol. They will always put the patient at risk. They won't do the, discharge somebody properly, or they won't do the WHO surgical checklist properly. If you're asking them to come for a review, they won't come for the review. I think this behavior, we have to stop it. If you are going to accept those kind of behavior from topmost people, this is going to percolate to the culture of the organization. Even the bottom line will quote that person. So we shouldn't tolerate this behavior, I would say.
You did answer somewhere my fifth question as well, but then let's say if this were your hospital, what's the first tough call you would made?
Sack them. I will try to put them on track by educating them, coaching them, many things we do. If they don't follow, I think they're not fit for the organization in a long run. It may be short term, it may be beneficial for volume and revenue, but in a long run, it's not beneficial. We need to cut it off.
I think very, very important message for a lot of people who are sitting in the audience. So thank you. I think even Dr. Ilan tried his best to win the prize of the hamper. Can we please give him a big round of applause? So with this, we move on to the last lap of our session. So for this, I have just 3 questions for each one of you, and if I would request each one of you to be super quick. One gear shift every hospital needs. One gear shift, or the final gear shift that every hospital needs. What is that one command?
Talk about safety.
One behavior.
Model it.
And one metric.
Measure it.
Okay? Very well said. Same question for you, Dr. Rana. Final gear shift. One gear shift that every hospital needs. What is that one command?
Do it right all the time. Do it right all the times.
One behavior.
One behavior, culture of safety.
And one metric.
Reactive to proactive approach.
Very well said. Dr. Ilan, the same question, one final gear shift that every hospital needs. One command.
First, do no harm.
The basis of whole healthcare.
We learned it from Hippocratic Oath anyway, so as a doctor.
Do it right all the time.
One behavior.
Behavior, yeah, speak early. I think that's very important. Escalate the issues early.
Yeah, very well said. And one metric.
I would say nowadays people are going to social media very quickly, the patients. I think try to find out a metric. How often patients go to social media before coming to the hospital, which means that there is no access in the patient at the hospital level. So find out a metric where how many escalation goes to social media directly.
Great. I think all three of them have done very amazingly well in all the questions, and I'm sure there were a lot of insights that each one of you sitting here, must have been able to derive from their experiences, their practices, their thinking process, what they have learned, in their years of experience, and what's more important and how they have shared with you. So thank you to each one of you for your time, for sharing your knowledge and understanding with everybody here. So I think it's very difficult for me to identify who's that one person who wins the gift hamper for this session. So let's talk to the crowd. Just make noise, okay? So how many you think Dr. Merlino wins the hamper? There are people who are whistling as well. How many do you think Dr. B.K. Rana wins it? And how many of you think Dr. Ilan wins it? Okay, so I don't have a decibel measuring meter here, but I think I would assume that all three of them have won equally. So I would give the gift or the gift hamper to all three of them. Wow. Let's please give them a big hand and a round of applause.
You are a great leader.
I think this should go to you, I think, probably, because you are the winner today.
No, thank you so much.
Thank you so much.
Thank you. Probably we can just do a photo together. Thank you, and thank you to a wonderful audience. Thank you to all my panelists. I would also like to call upon and say a big thanks to Yogmaya and Nishant for making the complete concept, scripting it, and helping me to do it with these beautiful slides and videos. Thank you to both of you. Thank you, everyone. Thank you.
We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement. that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference.
That was really amazing. A big thank you to our industry leaders for the engaging and high energy top gear session. Now we move to the next session. As healthcare evolves, innovation is inevitable, but safety is non-negotiable. Coming up next, the innovation safety equation session will help us to understand how to strike a critical balance. To guide and lead the session, we are privileged to have with us our distinguished session chair. May I invite Mr. Karan Puri, Chief Executive Officer, Apollo Hospitals, to kindly take the stage and commence the session. Mr. Puri leads groundbreaking advancements in cancer care, including the introduction of cutting-edge technologies like tomotherapy and India's first total marrow and lymphoid irradiation program. His leadership continues to position Apollo Proton as a pioneer in innovative cancer. Welcome, sir. With this, I would like to invite our speakers. Our first topic of discussion, Future Ready MedTech, Safe, Smart, Sustainable, will be delivered by Dr. Shravan, Managing Director and Group CEO, BPL Medical Technologies. May I please invite Dr. Shravan to join us here on the stage? A big hand of applause for Dr. Shravan here, joining us here on the stage. Next, we have a session titled Safe to Scale, WHO's role in governing innovation for patient safety. This will be presented by Mr. Nikhil Prakash Gupta, Technical Officer, Patient Safety and Quality of Care Unit, WHO, Geneva. Mr. Nikhil Prakash Gupta here on the stage with us. Following that, we will hear Engineering Safe Innovation Shaping High Reliability Healthcare in Asia, to be presented by Phung Nam Nam, Senior Clinical Leader, WinMec Healthcare System. May I invite Dr. Phung, who is joining us virtually from Vietnam. With this, I now hand over the forum to our esteemed session chair to lead the discussion. Over to you, Mr. Karan.
Thank you. Good afternoon. I know this is a second session post-lunch, but still the energies are there in the hall, so please maintain and continue with the same energy and spirit. An interesting topic, innovation. A simple word, but yet very complex. We all know what innovation is all about, and in healthcare it plays a very vital role. Innovation is essential to improve outcomes, efficiency, and access. But when you talk about healthcare, it is different from other industries. The reason? We have human lives we are dealing with. So an innovation can be breakthrough, but if it's not done in the right way, it can cause more harm than benefit to a patient. And we need to look at striking that balance and equilibrium where safety also comes into picture. And that's the reason we are here. We have people who are sitting on either side of me, and we have someone who's also joined in, to share their views on how safety and innovation go together hand in hand. I would like to invite and hand over the mic to Dr. Shravan Subramaniam, Managing Director and Group CEO of BPL Medical Technologies, to share his view.
Thank you. Thank you so much. Need a clicker. Okay, thank you so much. I had the opportunity to speak at this platform about 7 years ago, where we were talking about AI potentially transforming healthcare, and I thought this would be a good opportunity to see where we are in that journey and how far we've come, and whether we've held true to that promise. So indulge me, if you will, for a minute. Hey Meta, can you hear me?
Hi, Shravan. Yes, you are audible. How may I help you?
Okay. Do you know where I am and what I'm doing right now?
Your calendar says you have a presentation at the International Health Dialogue right now. Your satellite position says you are in Hyderabad. My inference is that you are in the middle of your speech right now.
Good. So far, so good. But we're talking about the future of healthcare and where we can go with this. And we have a great audience today. Can you tell us, Meta, how the audience is doing?
Of course. My sensors are picking data from wearables. Looks like 28% of your audience has elevated cardiovascular risk, while 9% display pre-diabetic symptoms. Would you like me to search for anything else?
Okay, this is getting a little scary, but Karan was saying this is the second session after lunch. So how are the energy levels doing now, Meta?
Sure, Shravan. 64% of your audience is sleep deprived. The average resting heart rate of the audience is 79 beats per minute. Would you like me to search for anything else?
No, I want the crowd to do better, but can you tell me what's on their mind?
Well, I wish I could read minds, but my AI abilities limit me. What I can tell you is that 98% of your audience is perplexed and is wondering if this is real.
Well, is it? What do you think? So this is scary, right? Because we are now we've entrusted our lives already with Dr. Google over the last 25 years. And between Google and Meta and all the devices that we have, our connected care, our devices, the internet and AI, they know everything about all of us. But what can we do about it? And how can we make the best use of it for the interest of patients, for the interest of healthcare? That's what I'd like to touch on today. But before we get into the future of healthcare, a quick rewind and an introduction. I'm a medical doctor. I'm a third-generation medical doctor, and I've seen healthcare right before my eyes throughout my life through my father and his father. And so just to get a sense, back in the day, what healthcare looked like and what it could look like today and 15 years into the future. When I went to medical school in the 1990s, there was actually a protocol, a textbook subject called exploratory laparotomy. Today, if you attempted to do something like that, an exploratory laparotomy, cutting open a patient just to figure out what's inside, you will probably get sued. And all the people in here, the patient safety advocates, would not be happy about it at all. But this is just a generation ago that cutting a person open was considered absolutely normal. Until about 50 years ago, the CT scan came in and it changed everything. This is the first CT scan that came out. It was a single slice CT. The images were extremely grainy, but it transformed healthcare and absolutely made a massive difference to diagnosis and therapy. Fast forward to the 80s. If you ask someone from the 80s, one of my seniors from med school, what is 2026 going to look like? This was just before the Terminator series came up and all the cool science fiction movies came out. They were imagining flying cars and all sorts of crazy tools. But really, what happened during this time? The tech innovations were absolutely phenomenal, right? For the first time in the 90s, balloon angioplasty transformed cardiac care. Interventional cardiology became a really cool and important subject. Pediatric cancers were getting solved one after the other. Exploratory surgeries got replaced by keyhole surgeries. And HIV, which was a major problem of the 80s and 90s, is now virtually solved. So what next? And what are the big impacts that technology can have? Really, the early 2000s was mostly about healthcare data. That was the age of the internet, computerized systems. You know, a lab that advertised computerized laboratory was considered to be a well-practicing, high-quality lab. So computers were everywhere, but those were mostly workflow transformations, not necessarily healthcare outcome transformations. The biggest impact that healthcare transformation had in the previous 50 to 60 years came from public health. From midnight in 1947 to today, average life expectancy at birth has almost doubled. What do we need to do if we want to see another doubling of that life expectancy? Diseases of the 30s and 40s are mostly solved. Diabetes is barely a thing anymore. Obesity is being managed. And cardiac care is mostly being either managed or delayed. And we are discovering other diseases that we have to deal with. So what next, right? The last decade, we added a bunch of tools. But what really happened was, you know, the unit of care basically changed from episodes to continuous signals. We've been in one of the most exciting, and you know, if you listen to the revving of the engines in the previous session, we were in the fast lane the last 10 years, or so we thought. But now it's a good time to step into the pit lane and think about what the next 10 years could hold. I'm just going to briefly run through a couple of scenarios. I don't want to go through all this in detail. But the point is, in the past, we were aiming for quick treatment. And the unit of care always took place in the hospital or the clinic. But now we're moving towards predictive healthcare, and it's going to be home first, and it's not necessarily going to be for patients, it's going to be for consumers, people like you and me. And AI played a decision support role previously. Now it's going to play a role integral in the entire journey of decision orchestration. So we're moving from episodic to continuous management of a patient. And the healthcare professional is moving from an executor to a supervisor and a strategist. 3 quick case studies. So let's take Uncle Raghavan, 75 years old. What is he going to do in 10 years, in 15 years? I think we're going to see Uncle Raghavan. I'm sure all of us here have an uncle or a father, Raghavan, who in 15 years is going to be requiring a lot of help, a lot of support. They probably have a child living overseas. They don't have the kind of care that our parents and their parents enjoyed at home. But could there be a bionic companion, a robot, a humanoid robot that is helping every aspect of their lives, providing companionship, preventing falls, observing their sleep patterns, observing their diet, and just providing a better quality of care, interaction, preventing loneliness for elders? Could that be possible? Answer is yes. We already have that technology in place. We have agents that are doing this. Our own Elon Musk is working on the Optimus robot. This is an example of a robot that was launched recently in India at CII. So such technologies already exist, but can they be adapted into healthcare? I think the answer is yes, and we need to open our minds to humanoid robots and companions. Quick case study 2, an other generally healthy and athletic young man in his 40s. What are his issues? What does he need to deal with? We're talking, 10, 15 years from now, we're talking 20, 40. Healthcare, as I mentioned earlier, is not going to be episodic anymore. And, even the word preventive is much hackneyed. It has to be predictive, and it has to be managed even before the episode comes up. So we're talking about healthcare at home. We anticipate that there will be devices available in the home that are programmed and customized for the individual, not the patient, for the individual. And just as we have smart watches now, we will have devices that are running in our bloodstream, that are subcutaneous, that's picking up signals from all around us, from our meta glasses, giving us inputs and helping us to prevent and manage disease long before it happens. You could have an ICU at home. You could have a preventive and preemptive ICU at home. You could have a blood draw at home, customize, get your diagnosis immediately. And, we talk about 10-minute delivery of groceries, talk about 10-minute delivery of pharmaceutical, of drugs. how about 10-minute customization of a unique, personalized pharmaceutical agent? That day is not too far, because with AI and the amount of data that we're able to pass through, clinical trials have been compressed from 10 plus years to half that time. In 15 years, it could compress exponentially to much less than that, and we might be able to devise and develop customized pharmaceuticals. That technology already exists. It's being experimented on, especially with antibiotics and other areas. So that could very much be the future. Right now, these devices look very clunky, but this was what a PC, a computer, looked like a generation ago. And today we have much more power in this watch than that entire device could store. So think of health kiosks and cubicles that you could walk into on your way to work, on your way back, and get an intervention on the spot. There is already a company that is working on remotely operated interventional cardiology. So if we already have, Apollo had already showcased remote surgeries being taken place through robotics. It can even happen for interventional cardiology. So imagine walking into a cubicle, getting a diagnosis, and getting an intervention on the spot. That future is not too far away. Let me remind you, 15 years ago, we had no idea that we would have autonomous cars. It was stuff of science fiction from movies. Today, autonomous cars are all over the place, and this can be very real in healthcare as well. And here's my favorite case study, an unborn child. Right? What could be the health interventions for an unborn child 15 years from today? Let's take Ananya. And Ananya, as an unborn child, as a fetus, probably in her 5th or 6th month, we would be able to detect her phenotype and her genotype and be able to make interventions through CRISPR-Cas9 and eliminate diseases even before she is born. That technology already exists, but it can become commonplace. It raises ethical questions, and we'll come to that later, but such technologies exist to completely manage and eliminate diseases. She could choose the time of, she would grow up into her teens and could probably program her menarche and choose when and how and if she wants to have a baby. All her clinical interventions will be made on a digital twin. We already have digital twins for aircraft and for robots and for manufacturing centers. The day is not too far when we have a complete digital twin with genetic information, with phenotypic information that we can make interventions on, simulate outcomes, and then make the actual interventions on Ananya. She would choose the time of her, of when she wants to have a baby. Menopause would be optional and managed, and that is the future that we envision for Ananya, who is to be born in 10 years. She would have a health pod at home. All interventions would be done remotely and digitally. This is Ananya at age 100. She has the same, humanoid that Uncle Raghavan had, except that Ananya is going to live to be 125. The child that is going to be 150 years old is already born, by the way. So from the 75th or the 80th year, we are no longer optimizing for longevity, but instead for quality of life. And I think that's what is important to keep in mind for the likes of Ananya. Most diseases will be eliminated or managed even before they manifest. So most cancers will be managed, most hospital-acquired infections will be managed, but truly the bottleneck is us. We need to open our mind to think about what the possibilities are. Many of the jobs the traditional jobs, and I can take the liberty of saying this as a physician, I think my job is redundant. My father's job as a pathologist was probably almost redundant in the way it was practiced before. And maybe it's only the quality people that still are going to have jobs in 15, 20 years to make sure that patient safety is paramount. But I will leave you with this last thought, and perhaps a topic current for next year's IPSC is the ethical frontier. At what point do we think about clinical interventions as a health outcome versus playing God? So I will pause here. I don't have an answer to that, but I leave that to you and IPSC for next year. Thank you.
Thanks to Shravan. What I can bet, though 64% of the audience could be sleep deprived, but they all enjoyed the session.
Thank you.
Especially the question answers and all. So yeah, thanks. In healthcare, we would have seen a lot of innovation. I'm sure there were sessions yesterday and today also. We had an eminent surgeon who spoke about telesurgery, how he was accessing the robot from one location and patient was in a remote location. So like he rightly mentioned, innovation is the next big thing. But yes, the ethical frontier is something where safety aspects comes into. And with that, we go on to the next speaker, who brings a global dimension to the topic which we are talking about. So I would like to welcome Mr. Nikhil Prakash Gupta, Technical Officer, Patient Safety and Quality of Care Unit, WHO. Over to you, Mr. Nikhil. Can we have the PPT, please? Yeah.
Good afternoon, and a very warm greeting from World Health Organization. And I should also congratulate here, let me admit that we attend a lot of global conferences, workshops on patient safety, but I would admit this is one of the best in terms of the technical content, engaging the stakeholders, and in the attendance, such a wonderful audience. So let's have a loud of applause for this conference itself. Should I say next? And my presentation won't be that exciting as my previous colleague because I'm not talking about innovation. I am going to talk about that maybe sounding a bit restrictive about governing innovation because a one-time new innovation may or may not impact patient safety or patient outcome. So we have to have a framework. And I will be talking on what WHO is doing and what is the framework where we can have a parameter that whether this innovation is really scalable and safe or it needs more work. And I would also continue with what my previous speaker was talking about, the ethical consideration. And I would like to here recall father of our nation, Mahatma Gandhi. He gave Gandhi's talisman. Many of you might have read or heard in your school time or anywhere. So what it says is, whenever you are having an ethical dilemma, wherever you are having a doubt whether this intervention, whether my action is going to work or not, think about the most vulnerable person. Think about the last person in the chain, in the queue. It may be an unattended patient. It may be an overworked doctor. It can be an attendant that is not getting information. And then think whether your intervention, your innovation is really going to help this person that is very vulnerable and last in the queue. And that will give you an answer whether this innovation is going to work or not. Can we move to the, okay, yeah, no, yeah, okay. So before coming to the innovation here, let's also look into the dimension and the quantum of harm. We usually only talk about the health harm of the unsafe care, that is how many patients are dying or getting harmed, injuries because of healthcare. We all know 1 out of 10. But it's not only about the health harm. According to our estimates, around globally, we lose around $1 trillion per year because of unsafe care. That may be because of the redos, that may be because of the litigations, and because of the process efficiencies. And also, it also creates a health system trust deficit, where people are not coming to the hospitals or health workers are getting burnout because of unsafe care incidents. So globally, WHO did a global analysis that is produced in the form of a global patient safety report. And these are some of the thematic gaps where we found that why even after a lot of innovation, we are living in an era of innovation. We are talking about AI, new models of care, digital technologies, but why the patient harm is not reducing. So these are some of the thematic areas where we thought, and you can see like awareness and leadership gap. Only 11% countries invest in research for patient safety. Policy gaps. Only 29% countries are having a national policy or action plan on patient safety. Only 26% countries have integrated electronic health records. And then implementation gap, only 34% countries are conducting any safety risk assessment for introducing new technologies. So the future is very much, I would say, bright, but we have to also look into the realities. What is the baseline where we are currently? And when we are talking at the global level, it's not only about 1 or 2 countries. We want to have the universal health coverage and the safe care for all the countries, all the population of the world. Now coming to the innovation and how we can test whether our innovation is really going to impact patient safety. So these are the 3 cardinal principles I would propose. First, whether it is safe or not. So innovation that demonstrates that it is going to reduce harm and it's not going to create new risks. Also, whether it is scalable, whether this innovation can work only in a hospital or in a region, or it can be applied to different populations and contexts and economies. And also whether it is sustainable, and that also applies to financial sustainability. A humanoid robot, I don't know how much it may cost and whether everybody can afford that or not. So we have to also think about the scale because if we want to have a real impact, we need to address the scale there. Just giving one example about, we are talking about AI very frequently here. So at WHO, we are focusing on what should be the ethical principles, what should be the guidance to develop new AI interventions in healthcare. And then it ranges from, because there may be biases, the data may be from a specific region, or there may be accountability issues or data protection issues where the data is being used. So we need to be looking into these principles. I won't go into details of all of them, but this is one area like where WHO works. We are not an innovation hub, but we like to provide guidance to the countries that how to make those innovations safe, accessible to all, and ethically sound. Now, WHO's role in governing innovation, what we do here. So certainly, we provide the global leadership and advocacy. We define norms and standards for healthcare delivery, as well as I discussed about AI and a lot of new technologies, those are coming. We help countries in enacting policies, strategies, and regulations. We monitor and we set accountability mechanisms. Like for the patient safety, we have a global patient safety action plan. And every year, the ministers of health of the whole world, they meet at World Health Assembly. And we have to report that how countries are doing on patient safety. As a convening organization, we also foster a lot of partnership and coordination and also support research and evidence. I will just give you some illustrations of how what are different programs, what WHO are running right now, or where we are having a leadership role. First of all, and very prominent, is the Global Patient Safety Action Plan, 2021 to 2030, which is right now we are implementing. And you might have seen or not, you should read about this. This is the framework. This is the governance framework or implementation framework, how we can implement patient safety for real impact. So we have seven of these strategic objectives, and for each of them we have 5 strategies. We can have a full session on this. I would love to have, or later on you can read about these. But this is the overall canvas of patient safety, what we could do. It starts from policies, from strategies, having high reliability systems, having safe clinical care processes, engaging patients, and monitoring and also safeguarding our health workers, and finally, having a synergy and coordination between all the stakeholders. We also support countries in having a broader national quality policies and strategies. WHO have produced this national quality policy and strategy guidance for that. Every year, we organize with our partners a global ministerial summit on patient safety. Last year it was in Manila, this year is in Oman. Every year we call the ministers of health of all the countries, and we discussed we have a very high level discussion of the policy direction on patient safety. This you might have all, how many of you are aware of World Patient Safety Day? Okay, I don't know what Meta is going to tell, but so we observe World Patient Safety Day on 17th of September every year. This is our official WHO World Health Day, and we lit our buildings and our hospitals in orange. Some of the hospital observe they usually wear orange T-shirts or something, orange cap. Whatever way, that is our color of solidarity for patient safety. And every year we have a new theme. So this year's theme is Safe Newborn and Child Care. And the next year we will be having another theme. So this is our one flagship offering from WHO to the whole world. To at least one day we focus and we again commit towards our patients' safe care. WHO also promotes Global Patient Safety Challenges. So you might have heard of the 5 moments of hand hygiene that is coming from the first Global Patient Safety Challenge, Clean Care is Safer Care. And then those, the safe surgery checklist that we talked about earlier in one of the sessions, that was our second challenge, Safe Surgery, Save Life. Right now we are observing the third Global Patient Safety Challenge on medication without harm. WHO also works on defining norms and standards and clinical guidelines on how you classify patient safety incident, how you should report and analyze. So the patient safety reporting learning and system work. Then we have some learning and knowledge sharing platforms like Global Patient Safety Network. Many of you might be a member of that. If not, you can go to the web page there. You can easily find on the Google or somewhere, and you can register for the Global Patient Safety Network. We are also having a focused program for certain countries, 6 right now on Global Patient Safety Collaborative, where we focus on a country for enacting policies and strategies and also capacity building for patient safety. Education and training, we are right now developing a WHO Academy course on patient safety, and WHO has already released a patient safety curriculum guide for doctors, for nurses, those for pre-service education. This is one of our flagship program, Patient for Patient Safety, where we engage patient champions, patients those might have faced any harm or those who want to work. Here, yesterday, Mr. Som Mittal was talking about, that was the Indian chapter of Patient for Patient Safety. So globally, we encourage a network of patient champions. Those can help in improving patient safety in our healthcare facilities. And then the monitoring and accountability. As I earlier said, we have a Global Patient Safety Action Plan. And for this, we are accountable to the World Health Assembly. So we track the monitoring, we track the progress of this action plan across all the countries. Right now, we have data from around 160 countries. In 2024, we produced a Global Patient Safety Report. A new report will be coming later in this year. And finally, certainly as a norms and standard setting body, a global benchmark, we produce guidance. Some of them you might be very much aware about, like safe surgery checklist or safe childbirth checklist. But we work in medication safety, in human factors, and so many other technical areas, so to provide global guidance on these subjects. So this is kind of a landscape where WHO is working. But as a global organization, we can set standards, we can provide some guidance, but at the end of the day, the implementation is with you, with the health workers, with the hospitals, with the healthcare organizations to really make it impactful. So thank you so much for your kind attention and again inviting WHO for this talk. Thank you.
Thank you, Mr. Nikhil. This clearly shows how much safety is spoken about at a global level and the steps which are taken, so the committees and all which are formed clearly talks very high of what the WHO does. We have our third speaker who's joined us virtually from Vietnam, and due to paucity of time, I'd just like to hand over directly to him. Ladies and gentlemen, I would like to welcome Dr. Phung Nam Lam, Senior Clinical Leader from Vinmec Healthcare System, to share his views. Over to you.
Được chưa? Bắt đầu rồi. So, good afternoon, dear distinguished guests and ladies and gentlemen. I'm very happy to join in the healthcare conference. And I'm sorry I could not, the last minute I could not fly to India to join on-site the conference. So thank you very much, the organization committee accept my presentation online and giving me the chance to share our experience approach way in the section of engineering safe innovation from strategy to clinical execution at Vinmec Healthcare System. Chưa được à? Anh không đẩy được slide. Okay. So the context and vision. So now in the Asia, the healthcare developed so quickly with a lot of innovation. Is the Vinmec the same? And we set the typical exam of this because during last 14 years. We developed from the 1 hospital to 9 hospitals now. And in the 2 or 3 years, we opened some more hospitals, in the total 14 hospitals. So we always balance between the rapid growth and to how to control the risk and how to keep control the safety and the quality for the patient. So for that, we try to engineer the safety and the quality like DNA of our staff. And we are proud that even if with the very rapid growth, we will keep the excellence in the critical care and get the golden standard. So we get the GCI accreditation. We are the first hospital in Vietnam with ACC and heart failure and coronary intervention. And for oncology, we are one of the very few hospitals in Vietnam where 100% of patients reviewed by the MTB. And we also implement successful specialized management in geriatric and the pain management with the opioid free. So for us, safety is not a break. Safety is the engine for the sustainable speed. So based on our experience and what we learned from the past, we try to share here some point of view from the Vinmec. So this is in the pillars of the Vinmec healthcare system. Clinical management acts as the central engine for the patient outcome and safety. And the foundation of the safety culture and education is the key. So we would like, we would like to share some key points that we learned from the past. We summarize that in the 3 pillars So the pillar one, the training ecosystem. So technology can be bought, but the mindset must be trained. We understand that. So from the beginning, we try to build the training center in the VinMec ecosystem. So we cooperate with the ASA and work with the Vin University to build the ASA International Training Center in VinMec with more than 20 ASA recognized instructors for resuscitation program. And we also on the first hospital in Vietnam established the clinical pharmacy internship program so that we can train the clinical pharmacists and build this team for the drug safety use. So one is important thing that we try to build the culture of learning in the system. We, from the leader to the every member of the VinMec, we keep in mind this culture of learning in the every activity, the daily activity, the daily safety huddle, the round, all the activity. And we also open reporting system so to encourage all the people report the near-miss event. And all together we just to build the culture shifting from the blame culture to learning culture. We focus on standardized competency for the team and focus on how to keep the consistency in the critical care. So we try to run some program to standardize the competency for the team. One example here is in the emergency team. So we, with a training center, we train all the members of the coach blue and white team so that all the member team holds a certificate for resuscitation. We also run the advanced competency training program for the team. For example, for emergency and critical care, we use a certain model, the checklist for early recognize and treatment for acute illness. That is the Mayo Clinic's model. And also FCCS, Fundamental Critical Care Support, the American Society of Critical Care program for the team. And for in anesthesia, we modify program MOCA from US to the simulation-based MOCA, focused on the case study, react on the simulation case to train for an anesthesia team. And for the nurse, we apply the American Society Critical Care ECHO standard for the nurse. So all of that results, we get a significant increase in successful resuscitation rate due to absolute protocol adherence. So we know that, so standardize the team and keep the consistency, precision care and consistency in care that engineer the safety and the quality. The pillar two, we focus on active prevention, shifting from the passive to active prevention. So here I would like to show two examples. The first example is the prevention critical care concept. We train the team and we build the team, we build the RRT team, rapid response team, to react if there is any critical inpatient in hospital. And by internal study, we know that NEWS 2 have a high specificity for early sepsis detection. So we use this tool to trigger the RRT team. So the results, the average time to antibiotic in VinMec now is 18 minutes. It's far from the international standard, is under 60 minutes, with a success rate 93% and mortality 3%. We apply exactly the same model for the cardiac and shock. And for the STEMI heart shock, door to balloon time in VinMec is now 58 minutes. So it's fit very well under 60 minutes by standard. And for shock, door to knit, 31 minutes, or door to roll, 72 minutes. The second example is the plan, the way we build the team to manage medication safety. So we manage on the polypharmacy or high alert agent. We develop the clinical pharmacy deployment in the critical area, and also we have the targeted protocol for the patient advocates who taking more than 5 medications. And also we have the protocol for the high alert group medication. We try to focus on training at the clinical pharmacies. So the pharmacy bed ratio now in Vinmec is 1 to 31. It's much better than the national standard is 1 to 200. And now the results, 100 inpatient order reviewed by clinical pharmacy and more than 12,000 interventions per year and 94% concentration rate in antibiotic stewardship. And almost all allergic patients have a warning card. The pillar 2, we focus on the operational defense. The way we organize the critical care. We focus on to build the mode of the comprehensive and team-based critical care in all the critical activity. So I show here some example that we implement in our system, the bundle model. So for the infection, we use the bundle model, and we train and encourage the team to improve the bundle compliance. And with the bundle compliance, improve almost nearly 100% now. And the results, the nosocomial infection rate, so decrease and almost zero now. For example, here in one hospital in Ho Chi Minh City, Vinmec in Ho Chi Minh City, during last 2 years, the VAP, the class B, the quality almost zero, no case for 1,000 days. The second example is the phone prevention. We implement the multifactorial intervention strategy. So we create the toxic profile for the team. We have a clinical protocol to react if there is any patient risk, and organize the environment safety beside the bedside for the patient. One of the model we focus a lot and persuade focus a lot and work with the team is a collaborative model, the multidisciplinary strength. So, for example, here is MDT, multidisciplinary route. We run this model in every inpatient department. So, patient is the center, and we build a team including doctor, nurse, clinical pharmacist, dietitian, physiotherapist, and daily the team run around where the treatment goals are set by the full team, ensuring personalized and holistic care plan. And the team follow standard structure protocol. For example, here the structure protocol for ICU delirium. With this protocol focus on sedation management, early mobilization, device optimization, sleep protocol. And the team uses this protocol for screening and try to analyze if there is any item need to fix. And outcome, measure the outcome, reduce delirium, decrease ventilator days, improve cognitive outcome. Another example, acute pain. So we use a model, multi-modal management led by anesthesiologists with a multidisciplinary team, 24/7 coverage with on-call pain specialist, with the philosophy that pain is monitored as the fifth vital sign. So we, in this model, we focus on non-pharmacological measure. And if you need the pharmacological, we focus on non-opioid first. And then pharmacological measure like regional anesthesia. And to reach that no pain, the VIP, VSA, less than 4 upon PACU entry and opioid free. We also think about to keep the continuity of care. So the bridging strategy for any patient before discharge, during discharge, 48 or 72 hours after discharge, and 1 or 2 weeks after that. We work on the team to prepare and plan for the discharge and follow the patient after discharge to be sure that everything is going well. So what is the impact? So with some of this initiative approach, we measure the outcome. And for example, here for RT effect, with the concept saving life before the cross, the in-hospital cardiac arrest per 1,000 admission improved very significantly. In 2019, it's 1.1, improved to 0.3 currently. And with the goal for this year, next year, is a 0 unexpected cardiac arrest. And for the ICU length of stay, reduced a half from the 9.4 to 4.8 days. In many specialties, we are ready to get the world-class safety and operations excellent criteria. For example, for the neurology, we are already ready for get the NAC level 4, the high level accreditation for the epilepsy, and the same for the SHOC, ASA, Comprehensive Stroke Center, and of course PCI. The ultimate outcome. So here some result. The trust and the satisfaction of the client and the staff. The customer satisfaction 99.6%, and the doctor and the nurse satisfied with the system more than 90%. So we think that safety is an investment that fuels superior clinical outcome and economic efficiency. So for the future, we need to extend more hospital, and we need to get higher, expand the higher reliability for the system. So I think that we think about something we need to focus to work in the future. Of course, the regional partnership to learn and to share experience for the practice, and do the best practice. Use the technology, AI, and concept of smart hospital to improve the quality and prevent the harm. But I think that the two items very important is that we keep in the mind the team that the concept of the philosophy of zero harm. Everything development, everything innovation, we need to try to keep that zero harm. And we need to focus on the staff, the person. So keep the continue education so that provide lifelong learning to enhance the clinical competency. So with some our experience to would like to share with you, and we are very happy to collaborate with our partner in Vietnam or in India to switch this model of high reliability healthcare. Thank you.
Thank you so much. Before we conclude, I just have a question for Shravan. You mentioned 7 years back you were a part of the IPSC, right? And I'm sure in these last 7 years you would have seen a lot many changes, innovations happening. Your comments and thoughts on, I'm sure in the next 2-3 years it will be at a much faster pace. So your comments and thoughts, where do you see next 2-3 years in terms of innovation?
Interestingly, in the last 7 years, some of the biggest changes came from public health and access. Technology has been rolling along for sure, and we're going to see some terrific growth over the next few years. But public health, access, those programs is what have impressed me the most. Of course, the buzz is all about AI, but what I think is going to happen is we'll have a multimodal approach. So it's not just about surgery, just about radiology, but all modes of care will converge through technology.
Thanks. So this brings us to an end of the session, and I think for me, important takeaways. Innovation safety equation, I feel, is not theoretical. It's something which happens across all hospitals every day, and I am sure a lot of healthcare professionals witness it. What is more important, the time when an idea is conceived, I think from there the journey starts, and every organization, every hospital, every team should empower people who are doing that journey or who are on that journey to speak up, to make sure patients are looked after and outcomes are measured, so that we again go back to the drawing board and make sure if there were some limitations which we didn't do well, we should improvise and again innovate to make sure that those gaps are diminished. Thank you so much for being a wonderful audience. It was a pleasure, and I would like to thank our esteemed speakers. We have Dr. Fung, who's joined us virtually, and we have 2 members who've come. Thank you so much.
Thank you.
Thank you. Thank you to our speakers and chairperson for highlighting how innovation and patient safety can progress hand in hand. Now, moving ahead, I would like to invite Dr. Ashwin Bele, co-founder of Life Science Presence, to the stage to finish his presentation. Thank you.
We are here for quality care. We are here for it.
Good afternoon, everyone. Thank you for this opportunity to talk here. And I'm going to be brief, but essentially, I've been not only developing clinical decision support systems, essentially AI, signal processing, image processing technologies for healthcare for the last 20 years, but I've also been implementing it. And I think there's a lot of lessons that I've learned along the way. So I thought I'd come here and share some of those lessons. It was difficult to pick which best lessons to pick from amongst the array of lessons we've learned as a collective team. But I think some of them are really important, especially for those who are considering implementing technology, particularly in hospitals. That's really where what my expertise has been and all these lessons learned from are. Let's see if it moves to the next slide. There we go. So one of the most common questions I get asked today, and in fact 17 years ago also I was asked the same question, will clinicians get replaced by AI? And my take on this is no, AI will not be replacing clinicians. Clinicians are a very important aspect of healthcare, particularly the human loop, the human touch is very important and only going to become more important as technology surrounds us more and more. But I will tell you who will replace clinicians. It's other clinicians who adopted AI into their workflow. So it's very important to think about AI as something that augments your intelligence as a clinician, but not necessarily an artificial intelligence that's replacing yours. Right? And from a development perspective, I've been, like I said, developing a variety of technologies, but the dirty little secret over here is developing a technology is actually the easy part. Adoption is the harder part. It's very difficult to get technology to be adopted. And in fact, I've been spending most of my life recently just figuring out how to ensure adoption takes place in a seamless manner. Because interestingly, healthcare always poses itself as a technology problem. But the reality is it's a workflow problem. And so if you are a technologist developing technology for hospital systems, you really have to think about the workflow more than the technology in itself. And so that leads me to my first lesson learned, which is success in medtech, especially within hospital systems, requires two things. One is product market fit, like any other technology out there, but unique to hospitals is the delivery model fit as well. So what do I mean by delivery model fit? If you think about the Silicon Valley approach of developing technology, things like Facebook, ChatGPT, etc., they built it and the users came. And the users actually figured out how to utilize the technology best for their needs. Whereas in healthcare, if you build it, it's insufficient. You then have to figure out how to integrate it into the hospitals, configure workflows, align stakeholders, train clinicians, prove value, manage change, return on investments, etc., etc., etc. And in that case, they may come. The hospitals may come to you. More than likely, you'll still have to go back to them each time to make the sale and prove all of that all at once. So one of the things, if you think about healthcare technologies today, there's actually not a lack of them, right? There are plenty of healthcare technologies out there, and going forward, we'll only see a lot more of them. But they're all point solutions. So for example, if ER bottleneck, there's a wait time that's happening, how do we take in a new patient, how do we enter their information, etc. These kinds of things can be, it's called point solutions. It takes a lot of time, but there's one solution there. Radiology, another solution. Finance, another solution. But the problem is, nobody is using these technologies in a cohesive manner. So it's all fragmented, and that's the big issue with developing technologies for hospital systems. So if you build technology from the very beginning as an operating system of the hospital rather than a single point solution for the hospital, rather than a single feature, I think you'll have a lot more success in making that work. Now, what does operating system mean? If you think about it from a CIO, CMIO perspective, usually hospitals have between 200 and 400 separate running software in their hospitals. So the CMIO, CIO is thinking about all these aspects while not just evaluating, but running those softwares in their premise. So all of these have to be provided by the technologist in order for the CIO, CMIO to think about this as a much easier way to adopt and govern and manage the technology inside a hospital. Now, if you're solving a small problem, you will have a tough time actually selling it in a big way. Hospitals actually surprisingly like to solve big problems first. And so my recommendation for those who are trying to build big problems or solve big problems is go big, go as big as possible. Here's an example of my own learning, right? We first recognized the need, which was continuous monitoring outside of ICU, outside of critical care. So we figured out how to do that in the ward, and we were able to get ICU level data outside of ICU. Then we realized, wait, that gap in data actually exists throughout the gamut of care. If you look at the patient's journey, going from ambulance to home, except for the ICU, there's a lot of dearth of information about the patient. So we built this technology to scale. We then had to figure out how to scale it across all these echelons of care. We built AI on top of that, and then we started showing earlier detection, better escalation, smarter ICU transitions, clearer triage, etc. Only once we had all of this put together, we started seeing traction at a much better scale than just the early adopters, right? It took us a while. I guess that's for me, so I'm going to jump ahead a little more. Also, early adopters trap. When you adopt a new technology, usually these hospitals who are early adopters give you a fake sense of hope that things will work out at scale. Typically what happens is when you build something for that hospital, they're willing to work with rough edges. But when you take it to a hospital that does not have the early adopter mindset, you typically end up failing in other hospitals. So for example, we built automation of summary, discharge summaries, etc., etc. Hospital was willing to work with it even in its rough format. But then we had to figure out how to solve all these handwritten notes problem, PDFs, how they wanted to talk to the system, etc. So we had to build and solve for all of those as well. Model performance is important, but when you think about statistics, usually it comes in publications like this. These are our publications for our models, peer-reviewed, big journals. They produce statistics like this that nobody wants to read, nor do they understand, except for some data scientists maybe. Clinicians don't think in this term. Clinicians think in simpler terms. They're worrying about how much workload will it add to my work and how much false alarm does it produce. If you can answer these kinds of simpler questions, there's a good chance the doctors will start thinking about utilizing your technology. Governance is a shared responsibility, and so ensure that beyond installation, as a technologist, you're supposed to continue holding hands with the clinicians in the hospital to prove that month on month you're catching the best cases that they would have missed otherwise and providing reports that they can use for continuous learning and improved care. Other final lessons really quickly, ROI is extremely important, but clinicians' ROI is very different from executives' ROI. Executives usually think about economics, clinicians' outcomes. Tiny pilots are a trap. Don't do any pilot under 50 patients. If they're saying 50, don't do it. 100 plus at least, because otherwise no adoption is going to take place. Clinical champions are very important, so find the best champion. And then lastly, once you have implemented and you've started generating revenue in hospital, start that as your starting line, not your finish line, because that is when adoption starts taking place, and you need to be there throughout that journey to help that. Thank you.
Thank you, Dr. Bele, for those valuable lessons. We now move to a session that speaks to the heart of healthcare. Let's talk kindness. This session reminds us that kindness is not an add-on to care. It is the foundation of trust, healing, human connection, and it is a shared responsibility. It is my pleasure to invite Dr. Anupam Sibal, Group Medical Director, Apollo Hospitals, to take the lead and guide us through this session. Dr. Sibal, may we please have you on the stage?
For innovation, we are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies.
Let's welcome Dr. Sibal as he joins us on the stage. Let's kindly give him a huge round of applause, please.
Safety. We are here for quality care.
Over to you, sir.
Thank you very much. Good afternoon, everyone. As we come to the close of this conference, I thought let's talk about something that I think each one of us feels deeply about, cares deeply about, and would want to experience and see more of. So let's talk kindness. Let me take you back to chapter 6, verse 32 of the Bhagavad Gita, dating back to 3000 BCE. When a person responds to the joy and sorrow of others as though they were his own, he or she has attained the highest spiritual union. If we look at the Charak Samhita, which really is the earliest published medical textbook dating back to about 400 BC, and I quote from the Charak Samhita, "He who regards kindness to humanity as his supreme religion and treats his patients accordingly succeeds best in achieving his aims of life and obtains the greatest pleasures." What exactly is kindness? And there is actually a definition. Can we, Kindness is purposeful, voluntary action undertaken with sensitivity to the needs or desires of another person and actively directed towards fostering their well-being or flourishing. In fact, there is this whole debate, is kindness the new currency? Well, patients expect kindness. A study from Mayo 7 years ago showed that patients only need on an average 29 seconds to fully describe their main concern, but usually they get interrupted within 11 seconds. So if only we gave them 18 more seconds, they would be happier. Data again shows that patients expect kindness, and they're more satisfied when the doctor is sitting while speaking to them and not standing. Very simple. Facing them and making eye contact. And I know in today's world of digital and wanting to type stuff on, they actually want you to make eye contact and caring about their emotional and psychological well-being. In this very interesting study, and this then was the subject of a book, The Rabbit Effect, they were actually studying what happens with a high-fat diet given to rabbits and heart disease. So these rabbits were given identical, very high-fat laden diet, and what was found was very interesting, that in one group there were 60% fewer blockages, and they were given the identical diet. And then they discovered that the caregiver, and there was one caregiver who, while feeding her rabbits, talked to them, cuddled them, petted them, and she didn't just pass out kibble, she gave love, and that love translated in 60% fewer blockages. In Compassionomics, there's reference to patients healing faster when their doctors are kind. And if there's greater compassion, then the odds of the patient having optimal blood sugar control is 80% higher. Compassion can result in an 80% higher optimal blood sugar. This work on kindness that has been studied at the Dignity Health and the Center for Compassion and Altruism Research and Education at Stanford, they show that when patients were treated with kindness, there was faster healing of wounds, reduced pain, reduced anxiety, reduced blood pressure, and very importantly, shorter hospital stay. And it's not just that the patient benefits, it's the doctor, the helper who benefits as well, because there's a lot of evidence to suggest that when one gives, when one helps, when one is kind, there's a release of endorphins. And in fact, a study from Emory showed that when you help someone, nucleus accumbens lights up, and that's really the area that normally lights up when you're receiving a reward or experiencing pleasure. So that's the impact on the person giving, caring, who's kinder. And in fact, Rumi, several hundred years ago, had said, when we practice loving kindness and compassion, we actually are the first ones to benefit. So it's not about the benefit to others, but it's about our benefit. And there are so many amazing examples of kindness. Dr. Colleen Coleman donated her kidney to Dr. Brian Dunn, her colleague who needed a kidney transplant. And Dr. Loyola Howe went a step ahead, and she actually donated her kidney to an unknown recipient. And when she was asked, why have you done that? She said, well, if you believe in the brotherhood of man, there are no unrelated donors. Wouldn't it be wonderful if every morning when we came to work, we were treated like this teacher treats her students? Sorry, can we play this? Doesn't allow me to play this, please. Can you just click on it and play this? Yeah, at the bottom, if you can play this. There's an audio to it. No, go back, please. It should play. So it's for the student to choose how she wants to be greeted, or he wants to be greeted by their teacher every morning when they go to school. I think there's some problem. Can you play this as well? I think all these videos you're going to have to play. Please play.
You got it, sweetie. Yay!
Wouldn't it be nice if we knew that somebody was always there to encourage us? Can you play the video, please?
Can change everything.
Wouldn't it be nice if we knew that there was someone who's going to watch out for us?
Oh, baby, how you find? All I need is my brother. I say I'm gonna get high.
And wouldn't it be reassuring to know that our team would always cover our back? You know, a Belgian journalist reported this, and this became a very big movement in Netherlands. So can you play the video, please? This patient was asked what would she want when she wakes up, and she said, I want a mango.
Surprise. En ook nog een mango drankje. Heb je nog altijd zin in mango? Ja,
So she was asked what is it that she would like, and she said a mango. And you know, getting mangoes, it's not like getting mangoes in India. Getting mangoes in Holland is not all that easy. So this nurse actually made the effort and got a mango, and also got some mango juice. And this really started the mango movement. And this is widely reported as something that transformed so many lives. Something small, something that does not require too much effort, but something that has a huge impact on what the patient wants. Now I'm going to give you a few such amazing examples from our amazing team at Apollo. And this is from Nurse Chaitali Gaikwad. She works at Apollo Hospital, Nashik, and she'd done a night shift and she was going home. And there she saw an accident victim. Someone had fallen off a two-wheeler and had hurt himself. So Chaitali got off her vehicle, assessed the patient, got the ambulance, had the patient transferred to Apollo Hospital. And she really had done what would be expected. And she would have gone home, but not Chaitali. She decided to wait. The patient needed to go to the OR. Most people would have gone, you know. They transferred a patient, the patient's gone to the OR. They've done more than what was expected, more than what their duty would expect. But Chaitali waited. She waited for the patient to come back to recovery, and she still didn't go home. She waited for that patient to move out of recovery and come to the ICU, met the mother of that patient, and then went home. And Chaitali mentions that since then she's become a family member of that family, and for everything important, they reach out to Chaitali. Mr. Devdas works as a security officer at Apollo Hospital, Navi Mumbai. And an elderly gentleman came to the hospital. He came in an auto rickshaw, and when he decided to pay the auto rickshaw driver, the app would not work, and he was carrying no money. So the auto rickshaw driver got very angry and he started shouting at this person, and Devdas, the security officer, went to the auto rickshaw driver and said, calm down. He opened his wallet and paid the auto rickshaw driver. Now this gentleman needed a consultation, he needed tests, and his digital payment gateway was not working. So Devdas, who works as a security officer, got the consultation done, paid for the tests, then arranged transport for this person to go back home. Later on in that evening, the son of that patient came and paid Devdas, and he wasn't doing this expecting that he would ever get paid back, but it was out of the kindness of his heart that he went ahead and did this. And he exemplifies this culture of paying it forward. Mr. Satyamurthy works as a duty manager at Apollo Hospital, Tynampet. It's our cancer hospital. And there was an elderly gentleman who had lung cancer, and he was very sick, and he was having his chemotherapy. And Satyamurthy discovered that this gentleman was really sad, and the reason why he was very sad was that his son was getting married in a few days, and he was going to miss the wedding. So Satyamurthy decided, along with the treating doctor, the nurse, and the paramedic, that they would do whatever it takes to take Mr. Satyamurthy for the wedding. So an ambulance was organized, a paramedic and a nurse went with this gentleman so that he could attend his son's wedding. And he later said, that was, as a father, the happiest moment of my life. So we've been over the years, and thanks to the good work of Gaurav and the team, capturing these stories in books. The first one was The Smile Behind the Mask, and we now have a second edition, and of course we are now going digital with collecting more and more of these heartwarming stories. We all know that if there was kindness at the workplace, there would be numerous benefits. Better engagement, job satisfaction, decreased burnout, a positive culture, greater productivity, and loyalty. We must always remember that there is no such thing as a small act of kindness, because none of us can ever gauge the impact of that small act. And that very small act can create a ripple with no logical end. So last year, we decided to institutionalize kindness, and we launched Kindness in Action, the Be Kind program. B, begin with warmth. E, empathize. K, kind actions. I, involve and inform. N for nurture. And D for deliver support. And let me walk you through some examples. Warmth, smiling in eye contact. Being calmer, the tone in which you speak. Empathy, acknowledging distress. Sitting in silence when needed. Sometimes all it takes is to just sit in silence and hold someone's hand. Kindness in action, reassurance before a procedure. Staying a moment longer. Everybody seems to be in a rush all the time, but if we stayed just a moment longer than needed. Informing in a language that a patient and the caregivers understand. Involve by asking what matters to you, and we cannot judge what matters to everyone. Everyone's different, all 8.3 billion of us. So to actually know what really matters is very important to you. Respecting personal choices, nurturing, checking back on progress, and offering words of encouragement. And deliver support, assisting with comfort needs, small needs, and very importantly, reaching out to the family of the patient. And then of course we have a reward and recognition program, positive reinforcement, the certificates, buddy badges, champion badge. And of course when we see that there's an opportunity for improvement, there are brush up modules for minor gaps, and of course more extensive curative models for major gaps. You know, a patient sent me this WhatsApp, and it was about this little girl somewhere in the Middle East, and she wanted to sleep in her mother's lap. It was getting very late at night. So she took off her shoes, took a piece of chalk, and drew her mother on the floor of her orphanage and went to sleep in her lap. In many ways, the relationship that we have with our patients is like that of a mother and a child. And the caregivers leave in our charge their loved one, their partner, their parent, their child, their sibling, their friend, hoping that we will look after them just like a mother looks after her child. We are all so privileged, we are all so blessed that we are in healthcare. And in fact, God has chosen us to do His work, and what we do each day is God's own work. Let us get inspired by what His Holiness the Dalai Lama has said. My religion is very simple. My religion is kindness. Be kind whenever possible. It is always possible. And I want to end with a story that Maureen told us, and Maureen's used to be the president of IHI. So Maureen got a call from the hospital where her mother was being looked after. And the doctor said that your mother is very sick, she's deteriorating, and I think we need to do a case conference, so why don't you call all your siblings and you come and meet us. So Maureen was the eldest member of the family, large Italian family. She had lots of siblings, so she called all her siblings, and they all gathered together for the case conference. And so the intensivist started to explain and said, your mother is very sick. She's likely to need non-invasive ventilation, and we might move on to ventilation. She's going to need renal support, and she might need dialysis. So while the intensivist was explaining all this, the internist, the primary physician, said, let's pause. And he said, what does mom want? Well, nobody had actually asked mom what she wanted. So Maureen was asked to meet her mom, and she went to her mom and asked her mom, Mom, what would you like? And her mom said, you know, I've had the most amazing life. I want to pass on in my home, in my bed, in my bedroom, in the environment that has given so much to me. So a decision was made, and Maureen's mom was sent home. And she passed away peacefully in her room, surrounded by her children and her grandchildren, remembering all the beautiful moments of her life. Maureen said, that day I realized that there were two types of doctors looking after my mom. The intensivist was a brilliant doctor. He knew exactly what needed to be done for my mom. He was the doctor of her body. But her internist was the doctor of her soul. And we, as caregivers, must always remember that we need to be caregivers of the body and caregivers of the soul, because our patients and their relatives expect that high degree of empathy and compassion in every interaction. So I just want to end by saying, we did an amazing job with the pandemic, right? But here is an opportunity for us to actually create a pandemic. Let's generate a pandemic of kindness in healthcare. Thank you very much. I have left a few minutes for any Q&A if you might have any questions or comments. Any comments from anyone? Any ideas on how we can actually create this pandemic? Yes?
Good evening, sir.
Hi, good evening.
I want to say a big thank you for having this session of kindness. This is, when we talk about safety, we don't have to undergo a safety event. We don't have to lose somebody to learn safety. I'm very sorry. So, I learned safety in a very difficult way. Like I lost my mother, a young mother, because of a patient safety event. So I always felt, you know, this session which you did today, I request you, and you know me, that I come every year from the time the first safety conference happened. Please continue to keep this session always. It's a request. We all need to remember we are human, kindness and compassion के बिना सेफ्टी नहीं होगा. Thank you so much.
Thank you so much, and I can personally say that you're a very kind person, because when my wife was admitted, you provided us with such great care in your hospital in Bombay. Any comments? Yes, please.
Sir, thank you. Thank you so much for such a wonderful session, and it's often very less talk topic. I think by nature we are supposed to be kind, but we find all the excuses under the sun not to do so. My request to you, just elaborate and tell us why. We all know that we have to do, but there is a gap between knowing and doing, which is the biggest problem in the world. So in this regard, how do we remind ourselves, and so that we can be kind in everything what we do in real life as a healthcare professional, for that matter, as a human being? Thank you, sir.
Thank you. Thank you. Great question. I'm actually going to wear my pediatric hat and try and answer that. Now, how many times does a toddler laugh in a day? Any idea? A toddler, someone between the age of 1 and 3. How many times? 300 times. And how many times does an adult laugh on an average? 3 times a day.
Sadly.
Right? So we are all born kind, then something happens. So we need to start becoming like children again. Actually become happier again, and not to behave in the way we've been conditioned by experiences. Because what happens is that all of us have been wronged in some form or the other, and it's so hard to forget, and it's so hard to forgive, and we become bitter. And some of that conditioning rubs off on many, many different aspects of our day-to-day existence. So I think we just have to move on to being like we were when we were children and have only positive thoughts and positive vibrations. And when we have that, then kindness will return back to us. And I think it's extremely important that we make a conscious effort to do that and do that every day. Because there are just so many challenges that we face every day. And in the pressures that we have in our daily life, in our jobs, that we perhaps don't give as much importance as we should. And we should also draw inspiration from what Rumi had said, that listen, each one of us is selfish. We always want something for us first, and that is the innate nature. But we also have to be fulfilled ourselves to be able to give. Like in every airline, don't you hear this announcement, please put on your mask before helping others, because if you are not going to be comfortable and if you are not going to be secure, you can't really help others. So I think we need to draw inspiration from what Rumi said, that when you help others, the first beneficiary is you.
Comes to you.
Yeah.
Yeah, I think just to add on, sir. So I think nobody, majority of the time, not intentional to hurt or to be rude. But actually, we should be intentional to be kind. And that's where where we should approach. Thank you, sir. Thank you once again.
And another thing that you mentioned is so important is that we end up being most unkind to people we love the most, because we take them for granted. And usually the brunt of what we are going through comes on the family, because you can't really be rude to your boss, you can't really be rude to your co-worker, you can't be rude to your subordinate, you can't be rude to strangers. I mean, some people are, but I mean, basically, and all that anger and everything and all that frustration comes home when you take it out on the ones you love the most. And so I think we need to be really conscious about that and care the most for the people we love the most, because we tend to actually be most unkind to them.
So after listening to your topic, the conference of patient safety, if a clinician or paramedic is really kind to the patient, the possibility of harm by the clinician, the safety always increases. Thank you very much.
Absolutely, absolutely. Kindness changes lots of things, and I think it's a great tool in terms of enhancing patient safety. Dr. Neelam, yeah.
Hello, everyone. My
Yes,
name is
please go.
Faiza. I am
Be a bit
leading
louder,
patient-
please.
yeah. I am leading patient experience in Star Hospitals. So what I have learned in my journey is that when we talk about kindness, it is an act of emotional and physical act towards us for our patients. So we often talk about empathy. And when we talk about empathy, we feel that it is putting ourselves into someone else's shoes and feeling what exactly they feel. But here I would also want to add a point about being compassionate. So what I feel is being empathetic might not be enough when we just feel someone else's pain, but the physical act of being involved and being compassionate and then acting on it it might make more impact towards the patients.
Absolutely, and
Thank you.
I think both go hand in hand and both have a contributory role to play. Neelam.
Thank you, Anupam. That was really wonderful. So first of all, congratulations to the Apollo Group for initiating Be Kind initiative, and also to the staff members of Apollo Group for being so kind. So, and I must say this is a very, very important topic. Sometimes we take these things for granted, and I'm sure no eyes are dry in this room as of now, because it is so close to everybody's heart. We are humans. And I think you, of course, gave strong evidence for it's not that, it's just anecdotal. It's really, there's evidence that kindness actually improves patient care and patient safety. But also, if we are kind to our patients, it will also increase the engagement with the patients. When they'll be able to open up and share their, their problems. So congratulations to you, and I think this is a wonderful topic, and I joined the pandemic.
Thank you so much. And when somebody who's led the patient safety movement for 20 years says she's joining the pandemic, I think the pandemic is alive and kicking and ready to spread. This question keeps coming up, and I'll just, is like, what is the least we can do for our patients? And I want to just share this story, and this was about a patient in a hospital in Chicago. And she got, the lady got a call from the hospital saying, your father's very, very ill. He's not going to last for very long, so why don't you just rush back from work to the hospital? So she did whatever she could to get back to the hospital, and there she saw a nurse holding her father's hand. And the nurse said, he passed away a few minutes ago, and he wasn't alone. I was with him holding his hand. Now in that hospital, they didn't have an overtime policy, and the nurse was not going to be given anything extra for staying on, but her character, her values did not allow her to leave that patient alone before that patient's daughter arrived. And she was willing to give time. And I think everyone in healthcare can give more time to their patients. And no matter how busy you are, whether you're the busiest surgeon or you are the charge nurse, I think everyone can give a little bit more time, and sometimes we underestimate that power of the extra 2 minutes or 5 minutes or 10 minutes. So each one of us can be more generous with our time, and that in itself would be a way of expressing kindness. Please.
Sir, first of all, I'm Dr. Pranjal from Guwahati JNRC. Sir, first of all, congratulations to your team for institutionalizing kindness or making things ingrained in your culture of the organization. Just to extend the thought,
yes.
We should not be limited to patients and attendants only. We should be kind to each other also. What I mean to say is that being a leader or being a supervisor, we should be kind to each other, our colleagues, our supervisee, or across the hierarchical line. Because yes, it's true, everyone has accountabilities, everyone has timelines, tasks to be completed, but along with that, the staff, healthcare is one of the most stressed industry. All the studies say that healthcare is the most stressful profession. So we don't know what my colleague is going through. He may be going through a financial hurdle, he may be going through a family hurdle, he may not be all right all the time, every day. So asking a colleague just for a cup of coffee, having a lunch together, or going out for a movie together, whatever, a small discussion, something as small as sitting with the colleague silently and ask, how are you? So small acts of kindness along with her colleagues and along with her team is very important. We, being the healthcare workers, should be the ambassadors of kindness in the society. That's my final call. Thank you,
absolutely, sir. And it's just so relevant that just as we are talking about kindness, Dr. Preeta Reddy walks in, and she's the one who actually coined the term which we have believed in for decades now, tender loving care, TLC. Ask any Apollo family member about TLC, and that's something Dr. Preeta Reddy coined. So let's put our hands together, because this discussion wouldn't have happened if she hadn't coined that term. And our chairman, Dr. Reddy, has taught us, and some of us who had the privilege of being trained directly by him, and I just want to share that because there are a lot of young people, and you might not hear this again. So chairman always says that whenever you look after any patient, please treat that patient just like you would want your parent, your child, your brother or sister, or your husband and wife treated. Do not do anything more. Please don't do anything extra, but don't do anything less. And if you think like that, suddenly your entire approach approach to the way you look after patients changes. And I think to our colleague from GNRC, you run a very fine hospital in the Northeast. Excellent observation about being kind to each other, being kind to colleagues. But like I said, very importantly, be kind to family. So while we start the pandemic of kindness, let each one of us make a promise that when we go back home today or tomorrow or whenever we reach home, we will be kinder to our family members, to the ones we love the most, because I think they want that kindness as well, and that all that kindness that we have shouldn't only be reserved for our patients. Any Gaurav, are we good? Or yeah, we good? Great. Well, thank you so much for such an engaging session, and really value the comments that came from you. Thank you so much.
Thank you, Dr. Sybil, for such an engaging session. Ladies and gentlemen, we now move to a moment of recognition and celebration as we present awards under various categories, honoring individuals and teams whose dedication, innovation, and excellence have made a meaningful impact. It's our honor to invite Dr. Preeta Reddy, Executive Vice Chairperson, Apollo Hospital Enterprise Limited, to deliver the valedictory address. Please join me in welcoming Dr. Preeta Reddy here on stage, everyone.
We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for
Namaste. I honestly can't believe that it's been 12 years and this is our 13th event. So for all of those who've come for this pilgrimage year on year, and for the organizing team, a big namaste and thank you. It's, it's wonderful to have valued clinical leaders in this gathering, people who run hospitals large and small, but with so much of passion and compassion, to have new partners who we're very excited to work with, who've come all the way from Kenya, everybody who represents the who's who in quality. Thank you. I know Neelam by name and face, but there's so many others. The head of ISQA, the JCI, Jonathan was here, and many other organizations. All this goes to say that we converge to this wonderful city of Hyderabad, and I know we move throughout the country and we will take it overseas. And we do it because I've spoken to people who come and they have said that, ma'am, it's like a pilgrimage for us. And that, I think, is what really keeps us going, keeps us excited, because at one point when I was asking, how many people are attending, they said, well, it could be 5,000, but it's actually 27,000 because people have logged in. And the fact that so many people are committed to doing what we're all doing together is there only because we don't do it for ourselves. Every day, Anupam spoke about kindness, Anupam spoke about TLC. And to me, I think it's very relevant in today's world. Because today, with the onset of AI, which honestly speaking, we have to embrace, we can't live without. The fact that, we are humans, we are a superior race, and the fact that the patients and their families depend on us, whether we are clinicians, whether we are just, a healthcare support system like I am and many other leaders are, all of us have to, we have this single-minded focus, and we're here for the patients and their families because we have to do what we're doing every day. So while there is technology, while we need the technology to scale, to go deep, to really commit to better outcomes, the fact remains that it is our head, It's our hands, it's our brain and our heart, which really has to take that intuition, that hard work forward. So my gratitude is there for each one of you who is there today. My gratitude is also there for the organizing team who every year try to raise the bar in multiple ways. And I also speak to all of you with quiet optimism, because the optimism is there that all of us are coming together with a single-minded purpose, with sincerity and hope. Unless mankind does not hope, we will not make the world a better place. And I was talking to the chairman of a very large Kenyan company, and he said, my son is doing all this. And I said, you know, it's the next gen. And when the young leaders are there in this auditorium, I do have that sense of optimism, because it is you who are going to be the flag bearers of the future, and we will be the ones who will be the support system for all of you. And I think today is really about that. Through multiple, you know, we started off as one group, and it was for technology and healthcare 13 years ago. Then the whole quality piece got added in. And now we've got so much more. So we have HOPE, which is the first one. We have IPSC, which is about our patient safety. We have THIT, which is then for the technology. And now we've added Clinovate, because we really feel that the clinicians are such an important part of what we do. And in the area of oncology, it'll be neurology, you know, better cardiac work, more deep, rare diseases. And the fact is that, you know, we can dare to dream and really use genomics to make it better. We can use data science to really predict what is going to happen and intervene far before anyone could even dream the possibilities. I'm excited about the future. While I did say quiet optimism, there is a sense of, you know, feeling young and wanting to go to work and doing these things, because the future is exciting. And we need to harness the possibilities of what we can do for the future, because I think we owe it to mankind. We owe it to the fact that the world has to be a better place for, you know, for the future generations. We learned such tough, hard lessons during COVID, but there were a lot of good lessons which we learned. And that was a lesson of collaboration. That was a lesson that we cannot do anything alone in silos, that we need to exchange with each other, we need to talk to each other, we need to work with each other. Unless we do that, we can't really achieve. And I think that was one of the most positive learnings of COVID. So we will come together to do, you know, things like that. And our chairman has told us every day that, you know, when he started, he said, I did this because I just had to do it for that patient and that family, because they needed us and they depended on us. And now we are looking at millions of people which we have to do. So it's kind of replicated, it's kind of become a movement. But at the end of the day, the ethos is the same, that we have to do it for the patients and their family. And it really is a very stark reminder of the fact that we have to take healthcare of international standards wherever we can. And for those of you in the THIT piece, you would have seen and understood that we dare to take it to the remotest locations, because we feel that people in remote locations need as good care as fast as we can for them too. And that is happening so well, and I think it's happening from a very committed and a very exciting team. I, in fact, knew Atul Gawande some time ago. We made him come to India when we were on this beginning our quality journey. And a lot of you might remember about his checklist manifesto and how we put checklists into our country. But one of the things he said is that, you know, don't say that I'm excellent and I'm fantastic. Better is possible. And every day, it doesn't take a genius to be better, to make things better. But imagine if there were 1 million of them making things better. It's beyond what a genius can do. It takes diligence. It takes moral clarity, which is so important. It takes ingenuity. And above all, it takes a willingness to try. So I think if we've taken time off and we're sitting in this hall and we're listening to each other, it's because we have a willingness to try. We have this willingness to, make that difference, to move the needle. And to me, that is the most significant fact that, we do it time and again. And this is our 13th year, and God willing, we will take it as many years as we can in as quick and better ways using technology as we can. One of the most heartening pieces of what we've done is that the policymakers and practitioners have come together for this conference. Technologists and caregivers have come together for the conference. Regulators and innovators have formed teams, and global leaders and grassroots champions. So we've actually covered the entire spectrum of the possibilities. And that really makes this whole effort extremely heartening for all of us. So before I close, I would really like to offer my sincere thanks to all the delegates for participating with commitment and willingness to keep learning, to our speakers and moderators who've come from such different vast geographies, who enrich every conversation in our shared journey. And of course, to our organizing team, without who all of us wouldn't come together so seamlessly, and who worked tirelessly behind the scenes, not only to make the conference a huge success, but to make the world a better place, to make our country a better place, to make India proud in the global healthcare map. Thank you all for doing what you do. God bless you all. So I'd like to close by saying thank you. We're part of a great, wonderful community. While I'm proud to be an Indian, I'd love to be a global healthcare citizen with all of you. Thank you, and Jai Hind.
Thank you, ma'am, for gracing the occasion with your kind words. We now have a short video showcasing the highlights of these 2 wonderful days. So let's focus our attention to the screens. Team, may we please have the video now? Ladies and gentlemen, we now move to a moment of recognition and celebration as we present awards under various categories. The online nomination process was formally initiated in September 2025, and the response we received was truly overwhelming. We received a total of 278 nominations from 84 organizations, a remarkable testament to the growing commitment towards patient safety and quality excellence.
Few awards were given yesterday during gala dinner, but jury felt that quite a few nominations were noteworthy. Hence, a few outstanding nominations have been identified across categories and selected for IHD Excellence Award. As we begin with IHD Excellence Award, I would request all the award winners to kindly come forward and receive the awards. May I request Dr. Preeta Reddy to please be here on the stage and give away the awards, IHD Excellence Awards, ladies and gentlemen. The first category in IHD Excellence Awards, Excellence in Patient Experience. And the award goes to Ramakrishna Care Hospital, Raipur. May I request members from Ramakrishna Hospital to please join us here on the stage to receive the award.
We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for
members from CK Birla Hospital, Gurgaon, to please come up on the stage. Sharda Hospital in category Excellence in Patient Experience. Care Hospital, Murshidabad. KIMS Research Foundation and Area Hospital, Narsipatnam. Congratulations to all the winners under this category.
We are here for patient safety. We are here for quality care.
Ladies and gentlemen, we are presenting Excellence in Patient Experience Awards.
Let's give all the winners a huge round of applause, please.
We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference.
Hospital, CK Birla Hospital, Sharda Hospital, Care Hospitals, and KIMS Research Foundation and Area Hospital. Congratulations to all the winners. Now we move to the next category.
That is the Green Health Award, and that goes to Care Hospitals, Banjara Hills. May we have the team from Care Hospitals come and receive the award, please?
We are the leaders of tomorrow. We are the champions of today.
The next award goes to Healthcare Digital Innovation and Adoption, and the winner is CK Birla Hospital, New Delhi.
I request team members from CK Birla Hospital, New Delhi to come up on the stage and receive the award. Next category, Innovation in Patient Safety, and the award goes to Downtown Hospital Limited. The first award goes to Downtown Hospital Limited. I would request members to walk to the stage. The second award winner in this category, Karwar Institute of Medical Sciences. May I please request members to join here. BM Birla Heart Hospital, Calcutta, and Arite Hospital under the category Innovation in Patient Safety.
We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing.
Congratulations to all the winners.
We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference.
Our next category of awards is Innovation in Fire Safety, and the award goes to Fortis Hospital, Mulund.
Congratulations, Fortis Hospital, Mulund. Now we move to the next category, Operational Leadership, and the winner is Mazumdar Shaw Medical Center, Narayana Health City, Bangalore. May I please request team members from Mazumdar Shah Medical Center, Narayana Health City, Bangalore to join us here on the stage to receive Operational Leadership Award.
And the last award, the category is Patient Safety Trailblazer. And the award goes to Sri Kamachi Medical Center, Thanjavur. May we please have the team join us on the stage to receive the award. Sri Kamachi Medical Center, Thanjavur.
We are the ones who paved the way. We are here for patient safety. We are here for quality care. We are here for innovation.
Ladies and gentlemen, today is not just about announcing winners, it is about celebrating a movement. The Safe-a-thon journey began at the regional level with an overwhelming responses. 120 passionate participants, each bringing forward ideas rooted in safety, innovation, and impact. From these 48 outstanding teams, we shortlisted to complete at the Safe-a-thon finals. May I request the winners of Safe-a-thon? May I request the last winner of the category Patient Safety Trailblazer to join here on the stage. The winner is here with us, receiving the award from Dr. Preeta Reddy.
Thank you, ma'am, for being there with us and felicitating all the winners. Let's give all the winners a huge round of applause.
Congratulations.
Congratulations, everyone.
Now we move to the winners of Safe-a-thon. A big round of applause for every single participant who took this journey forward. Before we move ahead, I would like to place on record our heartfelt appreciation to our esteemed jury members for their time and rigorous evaluation. Our sponsors, BioRx Venture, Advisors Private Limited, and Indian Healthcare Angels, and our participants who reminded us that safety excellence begins at the grassroots level. Today, we are delighted to recognize both our regional winners and the Safe-a-thon final winners, because every milestone in the journey deserves to be celebrated. May I request Dr. Vishal Gandhi, founder of BioRx Venture Advisors Private Limited and lead of Indian Healthcare Angels, to join us here on the stage for prize distribution. May I also request Dr. Katsan Engel to join us here on the stage to reward our Safe-a-thon winners, and Mr. Balaji, Quality Head, Chennai Main Hospital, to join us here with both our dignitaries. A big hand of applause, ladies and gentlemen, as we announce the regional third prize, and the cash prize is rupees 10,000. It goes to 7 winners, starting with PD Hinduja Hospital and Medical Research Center, Mumbai. May I request members of PD Hinduja Hospital winning Safe-a-thon Award to come here on the stage and receive the award. The second winner, Live-O-Fi. Live-O-Fi, may I please request members from Live-O-Fi Institute to please be here on the stage with us. Narayana Health, Ahmedabad. Shayatri Hospital, Corporate Office, Pune. Aritya Hospital, Hyderabad. Gleneagles Health City, Chennai. Indian Institute of Technology, Indore. Ladies and gentlemen, the winner of Safe-a-thon. The regional third prize goes to the members joining us here on the stage. big hand of applause for all the winners of Safe-a-thon. Cash prize of rupees 10,000 from our dignitaries present on the stage.
Now we have the regional second prize, cash prize of rupees 15,000, and the award goes to Team 2 of Gleneagles Hospital, Mumbai, NSHM College of Management and Technology, Kolkata, Kiran Multi-Specialty Hospitals, Surat, Inamdar Multi-Specialty Hospitals, Pune, Manipal Hospitals, Whitefield, Bengaluru, Rainbow Children's Hospital, Chennai, and Indore Institute of Pharmacy, Indore. Let's congratulate all the winners with a round of applause, please.
These are our regional winners for Safe-a-thon. Ladies and gentlemen, a big round of applause for our Safe-a-thon regional second prize winners. Now we move to regional first prize winners, and the cash prize is of rupees 25,000. May we invite our winners here on the stage, Team 1 of Dr. L.H. Hiranandani Hospital. IBCS SOA deemed to be University, Bhubaneswar. Third winner, Serbotech, Ahmedabad. The fourth winner here, WMF Willow, Poonawalla Memorial Hospital, Hardaspur, Pune. Regional first prize winners of Safe-a-thon. The Safe-a-thon journey began at the regional level with an overwhelming response, 128 passionate participants, each bringing forward ideas rooted to safety. And here we are rewarding the winners. First prize, the next winner is Dr. P.S. IMS and RF, Andhra Pradesh. I hope members from WMF Willow, Poonawalla Memorial Hospital, Hadapsar, Pune are available here on the stage. Announce the regional first prize winner's name again. Cash prize of rupees 25,000, and the winners receiving the rewards here. Team 1 of Dr. L.H. Hiranandani Hospitals, IBCS SOA deemed to be University, Bhubaneswar, Serbotech, Ahmedabad, WMF Willow, Poonawalla, Pune, Dr. P.S. IMS and RF, Andhra Pradesh, MOSC, Cochin, and PathScan Technologies Private Limited. A big round of applause for every single participant who took this journey forward before, and they have participated in Safe-a-thon journey that began at the regional level with an overwhelming response. Before we move to Safe-a-thon finals, we would want to congratulate all our regional Safe-a-thon winners. I would like to announce the winner of Regional Safe-a-thon third prize again. PD Hinduja Hospitals, hope you have received your reward. Liverfy Hospitals, hope you have received the award. Narayana Health Ahmedabad team, hope you have received the award, the regional third prize winner, Safe-a-thon, ladies and gentlemen. And Gleneagles Health City, Chennai, winning regional third prize award, Safe-a-thon.
Are the regional winners for the Safe-a-thon. Ladies and gentlemen, we now move to the next category of awards, the Safe-a-thon finals. The Safe-a-thon finals winners were selected after a rigorous evaluation based on problem clarity, risk and safety relevance, innovation and feasibility, implementation potential and impact. The competition was intense, the ideas exceptional, and the decisions incredibly challenging. So, without further ado, I announce the second runner-up for the Safe-a-thon finals, winning a cash prize of Rs 25,000, IBCS SOA deemed to be University Bhubaneswar. I'll name the participants: Mr. Louis Fotso, Mr. Adarsh Patnaik, Ms. Ipshita Sethi, Mr. Chidananda Jaina, Mr. Suvam Mohanty. Let's have all the winners on the stage, please. And let's give them a huge round of applause, please.
As we move to first runner-up, Safe-a-thon finals, may I have the privilege to invite members from Manipal Hospitals, Whitefield, Bangalore, Dr. Rajesh G, Dr. Ishani, Ms. Paulami, Mr. C.A. Abhishek, Dr. Anuradha. May I please request these members to join us here on the stage to receive first runner-up Safe-a-thon, the cash prize of Rs 50,000.
And now we move to the first winners of the Safe-a-thon finals, winning a cash prize of 75,000 rupees, and the award goes to Indraprastha Apollo Hospitals, New Delhi. May we please have Dr. Mohit Chaudhary, Dr. Himani Aneja, and Mr. Uday Thakur join us to receive the award.
Back with us because we are going to have Lucky Draw Challenge where you have got a chance to win a MacBook.
The bumper prize awaits you, so let's stay back. Thank you, our esteemed guests, for felicitating the winners. And to every participant present here today, Safe-a-thon is just not a competition. It is a commitment to building safer healthcare systems. Your ideas have the power to prevent harm, strengthen systems, and most importantly, save lives. So let us take these innovations beyond the stage into our hospitals, processes, and everyday practice.
Now we move to our next category, paper and poster presentation winner. I am delighted to announce that 300 papers and 150 posters were presented, and the topics were emerging trends in patient safety, process innovation and outcomes improvement, advancing care with technology, building greener, smarter hospitals, and patient engagement and enhancing experience. And with this overwhelming 300 papers and 150 posters which were presented, we have decided the winner, and I would request Dr. Neelam Dhingra to please be here on the stage with us to award these winners winning the paper and poster presentation challenge. May I also request Dr. Jacob Thomas to join Dr. Neelam Dhingra here on the stage to reward the winners of paper and poster presentation.
We are here for innovation. We are here to make a difference.
So for paper winner, I would like to announce the second runner-up, Ms. Pushpalata, Ms. Christy Sam, and Ms. Thamirai Selvi from Apollo Children's Hospital to please be here on the stage with us. Also, I would request Ms. C. Jennifer to join them to receive paper presentation second runner-up award.
May I also request Ms. Rekha Chakrabarti to join us on stage to felicitate the winners, please?
Ladies and gentlemen, paper presentation second runner-up goes to Children's Hospitals, Chennai. The first runner-up from St. Louis Hospital. I would request the following members to join us here on the stage to receive the awards. I would request members from St. Louis Hospital to please join us here on the stage, winning first runner-up under paper presentation category. Janilin L, Tapitan, Chaliza, and Majida. I would please request you to join us here on the stage to receive first runner-up paper presentation award. Out of 300 papers and 150 posters which were presented, here we are rewarding the winners. And the winner under paper presentation category goes to, any guesses? Paper presentation winner, any guesses? Sorry, I can't hear you. I would request members from G. Kapuswamy Naidu Memorial Hospital to please be here on the stage to receive winner paper presentation award. Dr. Kaushik, may I please request you to join us here? Winning the category paper presentation. Now we move to poster presentation. Second runner-up from Sri Venkateshwara College of Pharmacy. I would request Mr. Nisar Ahmed and Ms. Trishita to please join us here on the stage to receive the award. Poster presentation, second runner-up. And first runner-up in poster presentation goes to IHMR Bangalore. May I please request Dr. Kalidasan to please be here on the stage to receive the award under poster presentation category, first runner-up, IIHMR Bangalore. Ladies and gentlemen, please give a big hand of applause to the winner. And now we announce the winner. Now we announce the winner under this category. Manipal Academy of Higher Education. May I request Ms. Usha Rani to please be here on the stage to receive the award, winner for poster presentation. Ms. Usha Rani, Manipal Academy of Higher Education. I would request the members, the two hospitals who couldn't complete to come here on the stage to receive their IHD Excellence Award to now please come here and receive their awards, who missed out on receiving their awards while the time it was getting announced. May I please request BM Birla Heart Hospital Kolkata team to please be here on the stage and receive the award under category Innovation in Patient Safety IHD Excellence Award. And under category Operational Leadership Award, the team we got to miss to collect their award, Mazumdar Shaw Medical Center, Narayana Health City, Bangalore, to please come here on the stage and receive their award. Mazumdar Shaw Medical Center, Narayana Health City, Bangalore, receiving Operational Leadership Award. Thank you, Dr. Neelam. Thank you, Dr. Jacob. Thank you, Ms. Rekha.
And for the final category of awards for today, the Winners Awards, the much awaited Winners Awards, where we had a series of games and we had humongous participation. And to felicitate the winners, may I please invite Dr. Patrick McNeil, Mr. Gaurav Loria, and Dr. Anupam Sibal to the stage to felicitate the winners, please. Dr. Patrick McNeil. Okay, so we have Mr. Gaurav Loria with us, who will be felicitating our winners. We start with the first category, Humor in Healing, where we had to submit some funny healthcare memes, and the prize is a smart ring. The award for the funniest meme submission goes to Dr. Samhita Shanava from Apollo Specialty Hospitals, IPSC number 266861. Do we have Dr. Samhita with us here? Dr. Samhita? Okay. We also have another winner, Lieutenant Colonel A. Subhashini from Military Nursing Services. Ma'am, may we please have you join us? Ms. Deepa will be collecting the prize on behalf of Dr. Samhita. May we please give her a huge round of applause.
Team Apollo Vanagram receiving the award here.
Whistles and applauds both are equally welcome. For the next category, hashtag hustle, post, tag and win, share and tag on social media. The prize is a smart ring and the award goes to Mr. Raja Rajan S. from Sita Rama Raju University. Mr. Raja Rajan S. And we have our winner joining us on stage right now. So whistles and applauds both, please. Now coming to the next category, the Ishq Registration Awards. The grand prize being a tablet. We'd invite our guests to please do the lucky draw for us. Could we please have the lucky draw bowl? Could we please have a mic on the stage so that we can announce our lucky winners?
Some excitement before we announce the winner, which is already picked.
How excited are you? The grand prize also awaits. So let's keep the excitement going. We have a couple more lucky draws awaiting us.
So it's Akash, phone number 842. Akash, are you here? Okay. Dr. Srinivas Narayan Mishra. Dr. Srinivas, are you there? Please come.
And Dr. Srinivas wins a tablet.
Akash? Akash, where are you?
Now the next category is the Stall Championship Challenge. Again a lucky draw where we will decide 2 winners. So let's have the lucky people, the prize being a tablet. Ladies and gentlemen, the Stall Championship Challenge, where we were supposed to visit as many stalls as possible and collect the tags.
This is Miss Palluri, AIG Hospitals. Are you there? AIG Hospital. Okay. I'm sorry for the pronunciation. Adi Mulam from Mahavir Institute Medical. Lieutenant Colonel Subhashini, Secunderabad. Are you there? Are you there? No. No. Geetika, Venkateshwar College of Pharmacy.
And we have the winner walking towards us now. Let's congratulate her.
Okay, we have one more, so we'll probably just see who else is the lucky one. Kedar or Kesar, we can't read it clearly, from Amara Hospital. Not there? Okay. We're just going to pick up the last two. If you are there, you will get it. Hafsa Anjum. Hafsa Anjum. Okay. The last one. M. Praneeth. M. Praneeth. Not there? Okay.
No, M. Praneeth,
there is somebody
I
who's
think
claiming
is
to
here.
be Praneeth. Sorry? You can speak from the mic there.
Is it M. Pradeep or Praneeth? Apollo Hospitals. No.
What is IPSC? Your IPSC registration number is 266 300. Okay, then you are the wrong Praneeth. Okay, let's move on to the next
So
one.
let's now move to the next category, the Clinovate Dose of Luck, and the lucky winner again gets a tablet. We'll choose one lucky winner. One from oncology and one from women's health.
So for these, we will just pick out two. If you are the lucky one, at least from this two, you will get the tablet. Dr. Sheikh Shamili. Dr. Sheikh Shamili.
Sujata. Sujata. Okay, just one more. Shrutika. Shrutika, SVCP. Shrutika, are you there? Oh, good. Come.
Congratulations, Shrutika.
Uday Kumar. M. Uday Kumar. M. Uday Kumar. There somewhere? Okay.
Now for the last category, the most exciting one, the bumper prize. Are you ready to know the winner? I didn't hear a good yes. There we go, all right. So now we have the lucky draw for the MacBook winner.
So for the MacBook, there are going to be maximum 5 attempts. If in these 5 attempts you are not there, I am definitely taking the MacBook. So, okay. First one, let's hope someone gets it at the first count. Amrita Ganguly. Okay, so Amrita gets the MacBook. That's like being real lucky.
Let's congratulate Amrita. Let's congratulate her, please. She's the winner of a MacBook.
Congrats, many congrats. Thank you, Dr. Patrick. Thank you so much. Thank you, everybody.
Mr. Loria, may I request you to stay on the stage, please? So congratulations to all the winners. As we come to the conclusion of this remarkable conference, it has been truly inspiring to witness insightful discussions, groundbreaking ideas, and shared commitment to patient safety and healthcare excellence. To formally conclude this inspiring conference, we are privileged to invite Mr. Gaurav Loria to deliver the vote of thanks.
Thank you, Smriti. Respected leaders, distinguished guests, partners, speakers, colleagues, and dear friends, as we arrive for the final moments of IHD 2026, it's been both an honor and a joy to stand here and offer this closing vote of thanks for everybody on behalf of the complete organizing team. Over the past 2 days, we have witnessed global dialogue, powerful ideas, and meaningful collaboration. But before we close, it is important to recognize what truly made this possible. At the outset, my gratitude to our leadership, Dr. Pratap C. Reddy, Dr. Preeta Reddy, Dr. Shobna Kamineni, Dr. Sunita Reddy, and Dr. Sangeeta Reddy, Dr. Madhu Shashidhar, Captain Dr. Usha Banerjee, as well as Dr. Rohini Sridhar. It will not be fair if I don't take these 3 names who have been the real supporters and pillars for us for the conference. Mr. V.C. Ramesh from Pharmacy and Mr. Murkanandan and Mr. Rajendra Reddy from Procurement, without whose support we wouldn't have done this. Also, I would like to thank all our partners that you see here. Each one of them definitely contributed either in terms of helping us financially or in terms of being a knowledge partner or a support partner or even a flying partner. So I think that was a great support from all our partners, and I would really like to thank sincerely all the partners, especially Winmec, Pfizer, Roche Diagnostics, Samsung, and more than 100 partners who have been with us in this journey. To all the speakers, moderators, partners, and sponsors, but now I want to speak about the real driving force behind IHD 26. Over 4 months of real hard work, day and night, so many calls, so many follow-ups, so many discussions internally within the team, outside with a lot of people and a lot of teams, checking, testing technology, late night calls, following up on travel schedules of people. Conference really stands here because of each one of you today. to all our members in the registration and delegate management team, to our logistics team, speaker management team, stage, AV and production team, track hall coordinators, Hope and Clinovate track teams, exhibition stalls team, awards paper poster, award night teams, F&B team, housekeeping team, app management and tech team, workshop teams, special events, media communication team. And a very special thank you to Hyderabad team on the ground that was a big supporter for us, from regional CEO of Hyderabad to every HOD of the department and team member that really contributed and supported to make this event a grand success. But, you know, in all these thank yous, I just want to tell the whole team that worked with me closely for the last 4 to 6 months is what you have created here today is not just another event. This may be the 13th edition of the conference, but I think you have created a larger platform that influences how healthcare improves across countries. And I was super delighted, and I know that people just don't come and say on your face that, you know, it was a great conference, because we have heard inputs, feedback and criticism also at times. But today, I was very happy when I was walking around the stalls or when I was meeting different speakers, friends, guests who had come, and they said, you know, the kind of discussions that have been happening, the kind of topics, the kind of content, speakers, you know, your whole agenda, as well as the way it's organized being very smooth as a process, and even the exhibition partners saying we had so much of footfall from such a smart crowd who engaged with us and, you know, who really look forward, and we look forward to working with them. I think that was something super amazing, and that was something which was really nice to hear from them. So, entire organizing team, I just want to say, take a moment to look at what you have really built, take pride in it, celebrate it. And all of us need to celebrate together. Definitely we will do it, but because of this level of excellence comes only when teamwork, passion and belief, you know, comes for one shared purpose to deliver what we had envisioned that we need to deliver. So thank you once again everybody for being there, for being a supporter in every way that you have been. Without you, we wouldn't have achieved this global milestone for healthcare where we have reached today and what we did today. So thank you once again, all of you. Please travel back safe, and we'll see you at 2027 IHT. Thank you. Please come up. We need to take our, you know, the photo, standard photo every year that we do. So please come on the stage. All the organizing team. I don't see Reshma, Vamshi and that whole registration team. Okay. Please make sure everybody is here. Please call everyone. Please call people from the Clinovate and the Hope team as well. All of you, please come on the stage. Prithvi, I don't see Prithvi also. Can you please call everyone? Okay, come, please come, all of you.
We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference.
Guys, come fast, quick.
We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. For innovation, we are here to make a We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. For innovation, we are here to make a difference. We are the International Health Dialogue. Technology is our power. We commit to improve safety across. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies. We are part of a global movement that is changing people's lives. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the leaders of tomorrow. We are the champions of today. We are the ones who shape the future. We are the ones who pave the way. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are the learners and the teachers. We are the seekers and the finders. We are the thinkers and the doers. We are the dreamers and the achievers. We are here for patient safety. We are here for quality care. We are here for innovation. We are here to make a difference. We are not